Good morning, everyone. Welcome to CRC 2026 Day 2. I hope you all had a good night's sleep last night. We're going to start the first session on vasculitis. I'll call upon the chairperson, Dr. Ramesh Joyce, to come onto the dais. The panelists, Dr. Ruchika Goel, Dr. Arul Rajmurugan, and rapporteur, Dr. Kirti Talari. Over to you, Dr. Ramesh Joyce. Mics are kada? Mics.
Good morning, everyone. A warm welcome to everyone for the first session of day 2 on vasculitis. I have Dr. Ruchika Goel, Professor CMC Vellore, and Dr. Arul Rajmurugan, who's a professor and HOD from Madras Medical College, as my panelists, and Dr. Kirti Talari to support us from Yashoda, Hyderabad. Today's session will have 4 cases. Yeah. And we will also acknowledge our eminent abstract reviewers. You have all the names there. Thank you, abstract reviewers. So today's session, we have 4 interesting cases lined up. And I'll call upon the first person, Dr. Shaurok Khanna, to start his presentation.
Good morning, everyone. This is the title of my presentation. It's a diagnostic labyrinth from inflammatory arthritis to vasculitis, orogenital ulcers, and granulomatous enteritis. I'll be presenting on behalf of my guide and mentor, Dr. Rohini Samant, and we'll start the presentation. So it's the case of a 36-year-old gentleman. He presents to us in 2017 with inflammatory arthritis involving bilateral MTP and bilateral PIPs. RF, on evaluation, RF is positive, anti-CCP negative, and ANA by immunofluorescence was negative. We start him on methotrexate 25 milligrams per week and sulfasalazine 2 grams per day, with which he improves. However, 1 year later, and prior to the sudden onset of these symptoms, he has 3 months of throbbing headache and presents with sudden onset slurring of speech, left-sided LMN 7th nerve palsy, and right-sided ataxic hemiparesis. He's evaluated, and MRI of the brain with angiogram shows restricted diffusion in the left paramedian pons with distal narrowing of basilar artery. In view of the 3-month history of throbbing headache and the distal narrowing of basilar artery, we suspect this was CNS vasculitis, and we treat him with Visalone 20 milligrams and mycophenolate 500 milligrams, 4 tablets per day. His neurodeficit gradually improves, and he becomes non-compliant to treatment by 2020. In December 2022, he presents to us again, this time with fatigue, 8 kg weight loss, and 3 episodes of recurring oral ulcers, and one episode of a doubtful scrotal ulcer. USG abdominal imaging done outside revealed a splenomegaly with hypoechoic cystic lesions, and CECT of the abdomen revealed hepatomegaly with those splenic lesions being described as being maybe a sclerosing angiomatoid nodular transformation or a lymphoma. PET-CT done showed a moderate grade activity in the spleen with no other activity found elsewhere, with a few abdominal nodes. He's evaluated with a few blood investigations. CRP is elevated, ANA blot, APLA profile, HLA-B51 are all negative. He visits us in Feb of 2023 and we advise him a splenic biopsy which reveals foci of caseous necrosis with ill-defined granuloma. 6 weeks, at the end of 6 weeks, the TB culture doesn't grow any mycobacteria. And we felt that at that time, tuberculosis sort of explained most of his symptoms. So we started him on empirical AKT and discharged him on HCQS. 2 weeks later, he presents with evening rise of temperature, throat pain, odynophagia. We withhold EKT for a couple of weeks and then restart it. He's okay. April 2023, he presents to us with fever with erythema nodosum lesions. We start him on prednisolone 30 milligram taper and add tofacitinib as the steroid sparer, meanwhile continuing AKT. He improves with treatment, but in July of 2023, on tapering prednisolone down to 10 milligrams, he develops fever, oral ulcers, and appetite and weight loss. Repeat PET CT shows an increase in the size and the number of splenic lesions with small volume to centimeter sized lymph nodes in the abdominal, pelvic, retroperitoneal, and bilateral inguinal and femoral lymph nodes. We advise him splenic biopsy, but he's again lost to follow up, which has kind of been a recurring theme in this presentation course. He stops AKT after 6 months in August, and he's better. Fever has resolved. EN lesions persist, for which he uses PRED 5 milligrams SOS. December 2023, few months later, he presents to us with lower abdominal pain, recurrent oral ulcers, 7 kg weight loss, 1 episode of scrotal ulcers. At this time, he reveals to us that he is actually a homosexual. And we do a few labs. HIV is negative. CBC is, apart from hemoglobin of 9.5 and counts of 13,300, unremarkable. Creat is normal, CRP is elevated, 97.6, stool calprotectin is slightly high, 274. CCT of the abdomen reveals circumferential mural thickening of the distal ileum, and which extends up to the ileocecal junction, and the splenic lesions have now calcified. CT angio of the abdomen is normal. He undergoes a colonoscopy next, and the colonoscopy reveals multiple aphthae. Histopathology of the lesion shows focally caseating epithelioid granulomas, suggestive of moderate active colitis and granulomatous inflammation. The gastroenterologist involved comments that this could be a Crohn's versus Behçet. 6 weeks TB culture, again this time is negative. So looking at his constellation of symptoms, so we start him on PRED 20 milligrams taper and add azathioprine and tofacitinib as DMARDs. So looking at his constellation of symptoms, with there being inflammatory arthritis, the basilar artery occlusion, constitutional symptoms, erythema nodosum, bowel lesions, and orogenital ulcers, we feel a diagnosis of Behçet's could best explain his illness. But there is a twist. This is not the only, the story doesn't end here. In December of 2024, as I told you, he's a homosexual. He presents to us with penile and perianal ulcers with a lot of discharge. So it almost looked like to us as a condyloma lata presentation. TPHA done at that time was positive. VDRL was positive, and he was diagnosed with syphilis. He was treated with benzathine penicillin, 2.4 million units once a week for 3 doses, with which his ulcers heal and he improves. He remains on follow-up with us. Last he has seen us in April 2025. His ulcers have healed, and he's better with tofacitinib 5 milligrams BD, PRED 5 mg OD, and azathioprine 75 milligrams OD. Just to summarize, in 2017 he presents to us with inflammatory arthritis, for which we give him methotrexate and sulfasalazine. 2018 he presents to us with a pontine vascular lesion, for which we give PRED and MMF. 2022-2023 he presents to us with orogenital ulcers and splenic granulomas, for which we treat him with antitubercular drugs, prednisolone and tofacitinib for the erythema nodosum lesions that he had in the middle. 2024 he presents to us with enteritis and recurrent aphthosis that we treat him with, and on which he is currently on prednisolone, azathioprine and tofacitinib. And in December 2024 he presents to us with those discharge renal and penile ulcers that we diagnose as syphilis and treat him with benzathine penicillin. So learning points: just like any connective tissue disease, Behçet's can also evolve and present with sequential organ manifestations across specialties. So in this case, every time he presented to us with a different organ being involved, making the diagnosis a little bit tricky. We should stay vigilant for emerging clues to prevent diagnostic delays. So intestinal Behçet's is known in, intestinal manifestations are known in Behçet's, and the incidence is variable from 3 to 60% of the cases depending on the cohorts. Most commonly, Behçet's affects the terminal ileum, and the presentation is in the form of deep punched out ulcers which are non-granulomatous. But granulomatous enteritis, even though it is rare, it is well reported, with again the cohorts showing some variability. Fecal calprotectin levels can be elevated in Behçet's as well, or in any form of inflammation in the gut. And neurological involvement in Behçet's is also reported, and with the variability of 5 to 49%, with a pooled average of 9.4%. Even though majority of it is parenchymal involvement, there is some vascular involvement as well. Arterial involvement is, however, rare, being less than 1%. And this is we had a question to the panelist.
Thank you, Saurabh. So before asking my panelists for comments, I have one comment to make. Can the whole thing be syphilis? Why bring in a new diagnosis of Behçet's? Because your oral ulcers in the first instance responded to multivitamins. The second time it was associated with fever. There were only 2 episodes of scrotal ulcers, but then you had a lot of genital ulcers later. So can this be just syphilis? That's all.
We also thought about this, but we felt that the natural history of syphilis, it wasn't following the natural history of syphilis, with the tertiary manifestations, CNS involvement happening first and the secondary manifestations of ulcers happening later. We felt that did not really match, and we feel that Behçet's sort of...
the ulcers were painful or painless ulcers?
Ulcers were painful ulcers. The scrotal ulcers that he's had, they were always painful.
Syphilitic ulcers are painless, no?
Yes, sir.
So, I mean, I still think Behçet's is a little bit far-fetched to think. The other thing is about the role of tofacitinib. Even if this was Behçet's, let's take it. Let's think that syphilis was negative. There's still not much data to support use of tofacitinib in Behçet's. Right now, the best drugs that are suited for most manifestations of Behçet's are cyclosporin and azathioprine. So if you did not get relief with azathioprine alone, then a combo of cyclosporin is good enough. But Dr. Ruchika will take it.
No, I also concur with Dr. Ramesh that it is, rather than put syphilis as the first diagnosis, one thing which is very clear in this patient is that it is a granulomatous disease, because it is just not granulomatous enteritis. You have shown granulomas in spleen as well. So 2 places having granulomatous disorder is something which is not acceptable in a disease like Behçet. So that's one thing. Second thing is that the chronology of symptoms is, yes, it is not explained by the syphilis per se, but then we should not forget that it is all treatment. You are giving immunosuppression in between. So how that immunosuppression changes the natural course of syphilitic manifestations also, we are not sure. So I think there's only one hard point in this patient which we can, I think we should cling on to, is the two places showing granulomas. So it is a granulomatous disorder, whether it's an infective or it is, we are dealing with some autoinflammatory disease also, we do not know, it's inborn reserve immunity, we do not know.
Arul?
So if you want to put into one single basket, I would rather vote for IBD, inflammatory bowel disease. The close contender will be tuberculosis infection associated with some primary illness, rheumatological illness, which we have to pick it up. The HLA-B35, there is one which favors IBD, Crohn's disease. Then granulomatous colitis, splenic infarcts, CNS vasculitis, even scrotal ulcers. Everything speaks in favor of IBD. You can, if you want to explain everything with a single diagnosis, inflammatory bowel disease. So I would rather think of inflammatory bowel disease and treat them. If you want, if you can exclude tuberculosis, any infective granulomas, then I think better to treat as IBD.
Just one or two comments from the audience. Anybody wants to say anything? Madam.
So when we were students, we were taught if you know syphilis, you know whole of medicine, because it really affects all systems. And meningovascular syphilis can come in second stage, which would come within 2-3 years of onset of the disease. And with immunosuppression, what actually makes me wonder is when somebody is coming with, say, joint pain and rheumatoid RF positive and nothing else, whether one should be asking for VDRL and treponema pallidum antibody test,
Dr. Vinod?
Ramesh, good morning. Yeah.
Great case, thank you.
One second, Dr. Vinod is speaking.
Just one clarification. I think at his third or second admission, he was given steroids 20 milligram per day and started on azathioprine. And how much after time as tofacitinib was added?
So first we added him on azathioprine and steroids because he was not completely controlled with that. Maybe 6 months later we added tofacitinib.
Okay, so did you go up on the dose of azathioprine?
We went up till 75 milligrams. We didn't go up.
That would be considered suboptimum. What was his body weight?
He was 65 kilograms or so.
Okay, thank you.
Dr. Gupta, you want to say?
Yeah. I have a patient, 45 years, female, HLA-B51 positive, presented only with right ileocecal junction lump, and that was excised and found to have Behçet's. I put on azathioprine, and she's asymptomatic, present partially for 6 months. Okay, did I do anything more other than azathioprine, or shall I add more things to maintain it? And how long to continue the azathioprine in these patients? Because it is a vasculitis.
Azathioprine, if you're give it at 2 milligram per kilogram, maintain the full dose. That is what I would say. Your 60 odd patient, 62 kilo weight patient also probably requires more azathioprine. The other thing I saw you, even in your case, was the dose of steroid. I mean, if this was a CNS vasculitis, 20 milligrams of prednisolone for a 60 kilo person, if this was CNS vasculitis, is grossly inadequate. So, if we don't have to use fancy drugs for everything, conventional drugs do well but we just have to optimize the dose. So that's the one thing. And coming to Dr. Gupta's, I mean, if your disease is controlled on azathioprine alone, then it is good enough. You don't need anything more beyond that. So azathioprine is a good enough drug, but for various manifestations of Behçet's, I have found adding cyclosporine works a lot, except for neuro, where you're not supposed to use it. But otherwise, cyclosporine is a very good drug for Behçet's. Still you don't have response, then anti-TNF is a good option.
Then how long to continue the...
I mean, see, it's like any other rheumatological disease. I mean, we generally, at least for any major organ manifestation, I would keep the dose of the systemic DMARD at least for 2 years in remission. And then you can always slowly taper and see whether there is any other organ flare, whether you need it or whether you come down to the minimum basic that is required. Sapan.
Yeah, I agree with your Behçet's. You have to remember its brainstem involvement is seen in Behçet's. So he had brainstem area vasculitis, orogenital ulcers, so to start with. And we were always taught that the Behçet's and Crohn's is almost the same spectrum. I mean, you get intestinal lesions, oral lesions, posterior uveitis, दोनों में होता है, except that is granulomatous. So you brought Crohn's because of granulomatous vasculitis that you had at two places. The only thing I wouldn't have done is combination of tofa and azathioprine. I'm not sure if people have used that. It's a very deadly sort of.
I don't know, especially with a thrombotic event, whether you may want to, not want to, I don't know. Because the
Otherwise-
data is not great still in Behçet's. Thank you, everyone. We'll move on to, thank you very much, doctor. We'll ask Dr. Sarthik Verma to come over and give the next presentation.
Good morning, everyone. First of all, I'd like to thank all the CRC team for giving me this opportunity to present. And also my mentor, Dr. Sakir Ahmed sir, and the whole team, the Department of Rheumatology from KIMS Bhubaneswar. So I'll be presenting when a known case, known disease diverges from its expected course. So here's my presentation. So here is a lady who is 64-year-old female with known case of diffuse cutaneous systemic sclerosis, ILD association from 2001. By that time in 2001 means it's 25 years of disease. And the 2001 she presented with early skin manifestation and GRD. So initially she was started on methotrexate. And over the course of illness, after 4 to 5 years, she was found to have ILD association and was started on monthly cyclopulse. And following which she was on tadalafil and she was doing well. With a stable lung disease, she was doing well and she was on irregular follow-up. But last follow-up she had 3 months back was doing well. Now she presented to us with complaint of 2 months of history of progressive lower limb edema, worsening dyspnea and fatigue, decreased urine output and hemoptysis 1 episode just 1 day before she presented to us. She also told for these complaints in between she had fever episode which was not documented. And also for these complaints in view of, as we already explained, if you have some symptoms, so you should consult the local physician. She consulted there and she was given some oral antibiotics and also some over-the-counter steroid which was also not documented. So with this presentation, when she presented to us on initial, and she was very stable lady and strong lady, I mean to say. With this presentation, she came to in busy OPD and on presentation she had tachycardia of 126 per minute, blood pressure of 140/90 and respiratory rate of 36 per minute. We asked for the saturation. Saturation was 72% room air, but she was managing and her respiratory rate was, although it was 36 per minute, but she was telling me, okay, I'm managing it. With this scenario, we had a doubt that patient is having either LRT. There are so many things which were there in our mind. So we initially started on oxygen support and directly we shifted this patient to ICU. And as a part of like disease, we start considering the infection, empirical antibiotic after sending all the routine investigation and blood cultures. So for initial investigation, which showed like patient has anemia of 5.8 gram hemoglobin with neutrophilic leukocytosis of 18,000 and platelet counts of 3 lakhs with elevated acute phase reactants. And to our surprise, renal dysfunction was there and creat of 2.6 and urine routine was showing proteinuria, hematuria and pyuria. On quantification, protein creatinine ratio spot was 3 gram. Although liver functions were maintained, she had hypoalbuminemia and hypergammaglobulinemia. We considered the possibility of infection. We sent all cultures before starting antibiotics and procalcitonin was 0.36. ABG suggested only hypoxemia, but there was no metabolic acidosis as such. Although I couldn't get the first chest x-ray, we did SRCT thorax on the second day. So it was showing multiple background ILD and GGOs. So we had problem list, of that patient is having worsening hypoxemia who was stable for long and drop in hemoglobin which was 10.6 in the last visit around 3 months back, now it's 5.8. Renal dysfunction, either it can be AKI, RPRF or maybe we had doubts. And bipedal edema, within 24 hours we did echo, there was normal left ventricular systolic function and active urinary sediments also and with new onset hypertension. So with this long history of systemic sclerosis presenting with these manifestations, we had multiple differentials. First, we consider scleroderma renal crisis. although it is seen in the first 5 years of disease, but in systemic sclerosis long-standing with previous history of undocumented steroid abuse and we were not sure. Second was infection. Maybe just infection which triggered AKI, and whenever there is background to autoimmune disease, we always think maybe it's a SLE overlap. So we thought of that thing also, and we sent investigation. And one possibility, drop in hemoglobin, hypoxemia, DH was also considered, and vasculitis possibility was also made. So we sent the initial investigation, like blood culture, urine culture, everything was negative. For lupus overlap, we sent complements and TDS DNA, ELISA levels, it was normal. Then we started on antibiotic within 2 to 3 days. We also sent this ANCA profile on suspicion of possibility of pulmonary renal syndrome. Within 2 days, we were giving antibiotics, everything, but she was not improving. To our surprise, on the day 3 in the night, we got this report, the anti-MPO is strongly positive. So it was also a surprise in patient with systemic sclerosis positive. So it can be due to some infection also incidental. Then we repeated it. And again, it was similar, high titers, more than 300. So we discussed again with radiologist team, what do you think? There is hypoxemia, this presentation, they told it's looking like because the patchy involvement in the lung, the diffuse alveolar hemorrhage is more possibility than infection. So considering the pulmonary renal syndrome, we went ahead with, in the background antibiotic, we went ahead with steroids. So we gave steroid 15 mg per kg methylprednisolone pulse, 750 milligram over 3 days from day 4 to day 6. On the day 6 itself, we gave cyclophosphamide as per UAS protocol. But as I told, initially she was managing well, but because of prolonged hypoxemia, respiratory fatigue, we informed everything about the patient, like the patient has background lung involvement, intubation will be required. We delayed, but ultimately we had to go for intubation. So on the day 4, she was given elective ventilatory support. And despite doing treatment, she was having improvement in hypoxemia. There was improvement in urine output, and creatinine was going down. As you can see here, then from creatinine, the baseline was more than 2.5, it went down to like less than 1.6.5. So she was doing well, but the issue was architectural distortion in the lung. So while recovery of hypoxemia, it was very difficult to wean her off. While weaning her off, there was decreased lung compliance, so she was going to her CO2 narcosis. So this was again very tough thing. Like after 7 days, we always give an option of tracheostomy because prolonged E-tube like exposure is not good. And we explained everything. After good consent, we went ahead with percutaneous tracheostomy. Her oxygen requirement was minimal, only 30% FiO2 she was requiring, she was doing well. But now the course of come with the prolonged critical illness of hospitalization. During this hospitalization of like tracheostomy in situ, she had some hospital-acquired infection, candidemia, and blood cultures, and tracheostomy tube culture also Klebsiella. During the course, because we gave cyclo, after 2 weeks we have to repeat second dose of cyclophosphamide. This time she had cytopenia, thrombocytopenia basically, and neutrophilic leukocytosis, and again further drop in hemoglobin. So this was, we thought ki there is again relapse of the disease, we have to give something. So in background of infection, in background of some disease, in background of we have to treat, so we gave IVIG as a choice because whenever there is infection, there is always risk. When plasmapheresis is also an option considered, but in risk of hypotension, we choose over to IVIG. But despite all measures, she was deteriorated. She keep on deteriorating. She required need for dialysis. But we informed all these things to nephrologist team. They told ki we'll wait and we'll see whether we can go for it or not. Ultimately, despite doing all these things, dialysis was planned. But just before the dialysis, she succumbed. So this is my timeline of clinical events. The day 1, when she presented to us, day 2, day 3, we gave empirical antibiotic, but day 3, we could confirm the diagnosis. But despite treating everything improvement, this was very difficult to wean her off, and it further prolonged the hospital stay. And during hospital stay, in background of lung disturbance, lung architectural distortion, she had hospital-acquired infection, and further complicating the scenario. So these are my learning points from the case, that a patient presenting with such presentation like lung involvement and renal dysfunction, not always scleroderma renal crisis, but ANCA vasculitis is also one possibility we should consider. And it has a broad differential, not just the first and most common will always look for SLE overlap in background of systemic sclerosis. So it's more common to have SLE overlap. And ANCA vasculitis also it is seen in 15 to 20%, but clinically it is less than 1% as per prevalence on various cohort. And possibility of secondary vasculitis is essential. So early initiation of high dose steroid and cyclophosphamide can improve pulmonary renal syndrome. So we were thinking if we could get this ANCA profile report on the day 1, we could have started pulse therapy and we could prevented this intubation. And further course maybe something else like outcome could have been changed. So despite all measures, mortality is very high in such scenario. And so these are my questions to the panelists. So should ANCA profile be a routine in systemic sclerosis patient presenting with new renal dysfunction or hemoptysis? Second is how early can this ANCA profile be detected and what is the average time required for reporting? It depends on the lab to lab ultimately, but what is the optimal immunosuppressive therapy in patient with such scenario like systemic sclerosis, ANCA vasculitis overlap, particularly in this ICU setting? And when is the role of plasmapheresis or rituximab in such scenario? And how aggressively should we treat diffuse alveolar hemorrhage when the infection is risk? Thank you.
Thank you. So, interesting association, extremely rare. I mean, even after seeing ANCA vasculitis for 20 years, I've not seen an overlap with a scleroderma. Well described in literature. ANCA positivity is different in scleroderma and actual manifestation of GPA is different. You look at different cohorts, scleroderma cohorts. In the Australian scleroderma cohort, about 8% of patients were ANCA positive. And in an American cohort, none of them were ANCA positive. So it depends on which cohorts you have seen in whatever literature is published. So mere ANCA positivity obviously would not mean that you would want to do anything unless the manifestation. I think the key, I mean, you've done everything correct. In terms of management, what is right, what is wrong, nobody can fault you. Because nobody would think of ANCA vasculitis in a scleroderma patient because it was a nephritic picture. You obviously sent an ANCA, which is justified. So there is no question about it. Whether you would do routinely and other things, I'll ask my other panelists to comment on. Whether you would have done anything different, probably not. When you had infection, whether giving IVIG any quicker rather than later would have made any difference, we don't know. Whether there is any role for plasmapheresis straight away, we don't know, because plasmapheresis itself is controversial in alveolar hemorrhage. Whether this is alveolar hemorrhage in the first instance, we don't know, because CT scan, yes, there are some features of ground glass opacities. There's only one episode of hemoptysis, but we don't have any other proof. So we went by what the radiologist felt was the best and what the clinician thought was the best. There's nothing wrong there. But it's not a confirmatory diagnosis of alveolar hemorrhage. It could be some vague infection or it could have been a fungal throughout and once you've immunosuppressed, things got worse. Okay, I'll ask Dr. Arul for his comments.
So, whether you have done any bronchoscopy?
Yes, sir. This was, I was going to tell, that's first 3 days of hospitalization, we asked for bronchoscopy with pulmonary team. Actually, she was admitted in RICU itself. But because of her oxygen requirement, the vitals, they didn't go for it. They told ki no, it's not the right time and doing this procedure will be more hazardous to her. And we were thinking not to intubate her and we'll keep on NIV if it can be managed properly. So
any renal biopsy planned?
No, sir. Renal biopsy.
So when you have proteinuria, glomerular proteinuria caused, it may be a glomerular nephritis. Then you are justified in doing ANCA. Not routinely for all SSC patients. Right now we have a patient with SSC with elevated renal parameters, fluctuating blood pressure. So it's very difficult to treat whether we can give high dose steroids or whether we have to give immunosuppression. But for that we have to have some justification. So unless we have a proof for anything, even for a DAH, bronchoscopy, at least you could have done bronchoscopy and confirmed DAH, and then you can go ahead with strong immunosuppressives. Otherwise, better to give it to the nephrologist to manage renal involvement. Then we can take the patient for immunosuppressive therapy.
The only other thing is because the patient had hemoptysis, even the sputum you can give it for Pearl stain. That is one thing you can do, because basically what are you trying to prove? You're looking for hemosiderin laden macrophages.
We tried, sir. During hospitalization, we tried, but she was not able to cough, and that time so it
Sure,
was not.
that's okay. Dr. Yochana.
One thing, why the X-ray chest on admission is missing from this presentation, and second thing, clinically she did look like pulmonary renal syndrome.
Yes, ma'am.
Now, when you diagnose pulmonary renal syndrome, there is no reason to wait for ANCA report. Treatment of pulmonary renal syndrome or whatever etiology, whether it is occurring in poorly managed SLE or scleroderma or occasionally in RA patient, treatment is same. Full dose steroids, so methylprednisolone 1 gram daily for 3 to 5 days, and cyclophosphamide full dose, not urolupus or urovas. So 1 gram of cyclophosphamide, and then if the patient doesn't respond or develops complications of immunosuppression, that's a different thing. Or one can then think of say plasma exchange. But when you give not full treatment for pulmonary renal syndrome, you get stuck up like this.
Yes, ma'am. This was the dilemma. The first differential we kept is pulmonary renal syndrome, infection, everything. But to give pulse therapy in the such patient in background of infection is very risky, dicey. And the markers, although.
Dr. Ranjan.
So patient's creatinine decreased to less than 1. So in the last 5-6 days, what exactly happened? Was it another episode of DAH that deteriorated?
No, sir. She got bloodborne infection sepsis. So there was Klebsiella, grown, candidemia, and she persisted to have, like, initially she had improvement in inflammatory markers. That it was very high at the beginning. She had improvement everything, but during the course she had some multiple infection, tracheostomy infection, and bloodborne. There was Klebsiella. So
Okay,
it was all sepsis at the
Sapan?
end. And procalcitonin also went up.
ANCA and in scleroderma, as you said, was actually my colleague's dissertation back then, 2002, and she found, I think, more than 10% in her own study. So as he said, that is well known. My question was, what precipitated the ANCA after so many years? You said 2001 se scleroderma tha usko.
Yes, sir.
And
The onset
this
was-
is now.
Yes, sir. It's
What must
after
have-
25 years, sir.
How suddenly it got precipitated and you had such a devastating, this was DH, right? Not ILD. Because MPA can have an ILD kind of manifestation also, MPO, and that is different.
She has also.
She
was
had DH,
super-
right? Hemoptysis and all.
Yes, sir. She had hemoptysis. She has diffuse cutaneous system involvement with ILD. It was very, very bad ILD from the beginning.
So the last pulmonary worsening was because of more of ILD kind of thing, or was it more
More
of
of
DH?
DH, sir.
So
She
what
was
must have?
managing
I
with
was
that ILD
wondering
part was stable.
what could have precipitated the MPO suddenly after so many years.
Nobody can say. Dr. Ruchika, final comments?
No, earlier the classical teaching is you have scleroderma and all. But nowadays we are seeing presentations of ANCA vasculitis with scleroderma. It's just that it was not existent. It's just that we were not testing because we followed a very vertical
One
approach.
is vasculopathy, one is vasculitis. So
Yeah, so earlier we followed, but I'm fairly convinced that it is DH because a 5 units drop in hemoglobin with ground glass opacities in the chest X-ray, and along with some renal involvement. I don't think you have to wait for any other testing to call it as diffuse alveolar hemorrhage, because just a 5 grams drop in HB doesn't happen overnight, and you have hemoptysis, which is a clinical sign. So I think the clinical syndrome wise is very perfect, and we have seen ANCA vasculitis and scleroderma coming after long periods, especially when a patient presents with ulcers. Earlier we used to pass it on as scleroderma associated different causes of ulcers. But now these patients have peripheral neuropathy, and when you test for ANCA, it comes as positive. And then we don't stop. We've done a nerve biopsy also, and we have shown that there is a necrotizing inflammation. So it is not heard of, and our threshold for testing for ANCA and scleroderma has actually lowered down after many of these cases. Only thing is that I also agree with ma'am that you should probably have treated with full dose of methylprednisolone in the beginning, and last, I think during the course of time she has succumbed to infections, there's no doubt. And you don't have to do actually a biopsy. You can just do serial aliquots of BAL. When you had intubated her, that point of time, did you get blood in the tube?
While she was intubated, we planned for bronchoscopy, but we thought it may cause further risk of infection opportunistically. So we thought of it's clearly looking like DH, we should treat it rather than to confirm the diagnosis.
I mean, clinically, she was anyway better. She was anyway better clinically. So I think there is no doubt from the management part of it. I think we agree what you have done. There's no doubt about it. Okay? Thank you very much.
Thank you, sir.
So one query, sir. Sir, here, sir. So,
Oh, sorry.
so I'm a second year DNB resident. So I wanted to inquire, since the background disease was diffuse cutaneous systemic sclerosis, and she already presented with a picture of scleroderma crisis. So won't giving steroids be more hazardous? So won't the picture looks more like thrombotic microangiopathy, because it would have, if it would have been DH, we gave pulse methylprednisolone on day 6. The hemoglobin would have
Yeah, very
continued
good
to
question.
drop.
We look for peripheral blood mastocytes
So
were normal.
won't
So we ruled out
it
that
can
thing
be
first.
normal initially also. Won't plasmapheresis would have been a better option, considering the systemic sclerosis part and the active glomerulonephritis plus DH part. We could have circumvented the use of steroids also, sir.
So the thing about two things now in terms of the steroids, see, this is a rare association. So nobody knows actually what is the correct way to do. On one hand, you have a dreaded disease like alveolar hemorrhage, which carries a very poor prognosis in itself, whether you, even after treatment. So you're not wrong in considering high dose steroids because you're doing it in the best interest in that acute situation. So I would go by high dose steroids if it is required. There's nothing, it's not that every patient who had scleroderma who received steroid is going to land up with renal crisis. It's only that those who have high steroid exposure are more prone, that's all. That is one. With respect to what agent to choose, I mean, definitely cyclo is the choice here. I don't think we would go for rituximab here. In terms of plasmapheresis, yes or no, the data is still not out on the role of plasmapheresis in alveolar hemorrhage. We know now in renal disease when to give, but in alveolar hemorrhage, the data is still not out. Still, plasmapheresis itself carries a huge risk of infection. So I don't think we are wrong in doing plasmapheresis also. You look at various recommendations, plasmapheresis is left to the discretion of the treating physician. Nobody says don't do it. You look at various international recommendations, one says you can do, one says you can't do. So it is left at your discretion at an individual patient level. But, yeah, but I wouldn't fault him for not doing plasmapheresis either. So in terms of management, I think we agree what has been done. Okay? Thank you.
Thank you.
Can we ask the third presenter, Dr. Nitin Gowda, to come?
Good morning, everyone. My case is about clot or vasculitis, the arterial diagnostic dilemma. She was a 30-year-old female, mother of 2 kids, with no comorbidities or abortion history, presented with fever, migratory joint pain, and pleuropericardial effusion with transient arterial rash, which was lasting for few hours, never more than 24 hours, and with no sequelae like hyperpigmentation or scarring or ulceration. She had history of Raynaud's also. These were there for the past 5 months. She presented to us with digital gangrene involving the left, second, and third fingers. When she came to us, she had already had CT angiography done, which was showing ulnar artery thrombosis. This was the initial presentation investigation, which revealed mild neutrophilic leukocytosis with thrombocytopenia and elevated inflammatory markers such as ESR and CRP. Her renal evaluation was normal, and immunological workup ANA, ENA, DSDNA, RF, anti-CCP, and ANCA were negative. APS profile and LAC were negative. Cryoglobulins were negative. Infection markers including HIV, HCV, hepatitis B were negative. And to our surprise, she had low complements and direct Coombs test positivity. We had a dilemma between the vasculopathy and vasculitis in this case. We treated her on lines of both initially with steroids, methotrexate, hydroxychloroquine, tadalafil, and warfarin, with therapeutic INR target of 2 to 3. With these, fever settled, there was no recurrence of urticaria. She was doing well for our good and for the next 6 months. Then comes the steroid tapering on OPD basis, which landed her in readmission. She had fever, cough, loose stools, and there was recurrence of urticaria this time. Initial evaluation done outside showed imaging pleuropericardial effusion with bronchial wall thickening. We treated her with empirical antibiotics and steroid escalation with H1H2 blockers. In hospital, we tried switching anticoagulant from warfarin to apixaban, as she did not have any high risk factors like triple IPS positivity or LAC positivity. During this switch, she had right toe pregangrenous changes. In the second admission, the evaluation surprised us again. She had leukocytosis, but this time it was not neutrophilic, it was eosinophilic. The absolute eosil count was around 3,200. And thrombocytopenia was persisting. The inflammatory markers were elevated again. And this time also she did not have any renal involvement. We repeated the ANA and the cryoglobulins, which were negative, and our C3, C4 was persistently low. The Doppler lower limb arterial done showed right and left posterior anterior tibial artery thrombosis. And we had the eosinophilia, which was a surprise. We did thought of hypereosinophilic syndrome. So we went ahead with the hypereosinophilic syndrome evaluation. Bone marrow showed no atypical cells or blast cells in the bone marrow. These all were mature eosinophils. And FISH panel, the genetic testing for the hypereosinophilia did not show any mutation or translocations. And this time also, urticaria resolved with higher dose of steroids, H1H2 blockers. And she was discharged on steroids, hydroxychloroquine, warfarin, and azathioprine. In the follow-up, she was on azathioprine 75 mg, tapering doses of steroid with H1H2 blockers. The pregangrenous changes had resolved, and she had no recurrence of diarrhea or the urticarial rash. There was no new pulse loss. The eosinophilia and thrombocytopenia were resolved. The diagnostic dilemma was between the vasculitis and the vasculopathy. To support vasculitis manifestation, she had leukocytosis, low complements, the elevated acute phase reactants, and the systemic symptoms. The points against the vasculitis were the atypical nature of the rash, which was very transient, lasting for a few minutes to hours. And the thrombocytosis was expected in the vasculitis as per the conventional teaching, but she had thrombocytopenia. And we thought of immune-mediated vasculitis, most likely small vessel vasculitis, but she had macrovascular thrombosis, like recurrent arterial thrombosis in the medium vessels. As a part of vasculopathy, we thought APS, though it was seronegative, because she had thrombocytopenia, which was persistent, and the recurrent thrombosis, and the Raynaud's phenomena, and the Coombs positivity. And when we tried to switch from warfarin to apixaban, she had recurrence of the thrombus at multiple sites. The points against the vasculopathic prototype, the seronegative APS, were the eosinophilia, urticaria were not explained, the elevated acute phase reactants, and the low complements. Still, the dilemma is going on in my mind that it is vasculitis or vasculopathy. So what I learned from this case was the profoundly low C3, C4, the transient urticaria, the recurrent arterial thrombosis. It may be a atypical immune complex mediated vasculopathy. The hypocomplementemic urticarial vasculitis, which may be a better bet in this case, may involve macrovascular arteries also, not just the cutaneous or the small vessel vasculitis. In limb-threatening thrombosis and with low complements, acute phase reactants being elevated, and the negative serology like ANA, APS, LAC, we should not wait for a label. We should start the immunosuppression and the anticoagulant as soon as possible. And in this case, I agree with the drawback that we could not do biopsy, and anti-C1q antibody, which maybe supported the diagnosis of hypocomplementary arterial vasculitis, could not be done due to the financial constraints. These are the key questions for the panel.
Thank you. So I have a few things here. One thing, let's give him a clap first. We agree that there is an immune activation. There is thrombocytopenia, there is raised acute phase reactants, there is low complement. But I have my reservations about the diagnosis of urticarial vasculitis. You're saying there are recurrent urticarias which come and go, which you're not leaving any pigmentation. Urticarial vasculitis usually presents with an edematous urticaria that usually leaves pigmentation, and a simple skin biopsy can be more confirmatory. Yes. So maybe, a skin biopsy would have helped to confirm a diagnosis whether this was urticarial vasculitis. That's number one. Second, if we leave the urticaria a little bit away, because urticaria is such a common, chronic simple urticaria is such a common thing in the community that we don't have to marry it to the presentation. You have a lot of other things going on here. 2 major episodes of arterial thrombosis with negative APLA. We don't know whether this is a seronegative APS still, especially because there is thrombocytopenia also. And it could still quite be a possibility. And given that there was a recurrent thrombosis after apixaban, we'll have to assume that there is an element of seronegative APLA. Now the question is whether seronegative APLA can explain everything, or we have another disease in addition to the seronegative APLA. That is the question. Because your inflammatory markers were high, you don't get raised inflammatory markers in APLA as a requirement. So there could be an additional inflammatory process going on in addition to the thrombotic process. Few things. Can this be DADA2? Everything you have here can be explained by DADA2 except hypocomplementemia. That's the only thing that I can't explain, but then you never know. DADA2 is an emerging syndrome. You can have cytopenias, you can have urticarias, you can have thrombosis, and the type of gangrene that you showed in the big toe, it is this sort of a livedoid type of gangrene is seen more with medium vessel disease. So I think sending DADA2 screening will be good for you, at least because you know whether you're looking at an inflammatory or an infective process. Can this be paraneoplastic?
Sir, constitutional symptoms were not there, and with these treatments she has responded. In the follow-up, probably we will...
In the follow-up, keep it in mind,
Yes, sir.
because when you have a seronegative syndrome where everything is negative, look out for unusual manifestations and always keep in watch. Even though the age is young. You never know.
Yeah.
You never know. So have a low threshold to do a PET scan if you think it is relevant. That is one thing. So these are the 2 things I wanted to say. Hypereosinophilic, and the other thing is, once again, with hypocomplementary vasculitis, such big arterial thrombosis is unheard of.
Yes,
Unless you have hypocomplementary vasculitis occurring on a background of a connective tissue disease. Otherwise, it is unheard of.
Yes,
so this is something that is going to evolve. We may not be able to give a label to the problem, but personally, I would definitely send a DADA. Dr. Arul?
One more close differential is hypereosinophilic syndrome. So we can explain with urticaria, eosinophils, thrombosis, response to steroids. That's a straightforward diagnosis.
That we did
Unless
consider, sir. But the index presentation did not have any eosinophil. We have done the bone marrow.
Fish panel, that's
and
what
fish
I
panel also we
said.
have
But
done.
clinically, first
Yes, sir.
possibility is other than all the diseases we have discussed.
I just want to say, I think you have to send a whole exome
We
sequencing
had
for
planned,
this
ma'am, but the
patient.
issue is the financial issues. Eventually, we
And skin biopsy has to be done. When she develops urticaria, you can't just sit with HUVS. You can have atypical presentations. You can have urticaria also resolving and all. Although the classical teaching is that you have to have a persistent urticaria, which is more than 24 hours to call it as HUVS. But you have evidence of classical complement pathway activation. Another thing is that hypereosinophilia was first when she developed the gangrene. That time also eosinophils were high.
no, ma'am. Index presentation, there was no eosinophilia.
Because hypereosinophilia can explain thrombosis.
Yes.
Macrovascular thrombosis is very well described. So if she develops, hopefully she won't, because you are now giving her anticoagulation. But if she develops, then you have to watch for whether it coincides with the episodes of eosinophilia, because that may be just a surrogate thing, and that is why she requires more than fish.
Regarding the skin biopsy, even I was the managing resident, I was at confusion because it was lasting for few hours. It would be too early to do the biopsy of the urticarial lesion, because too early skin biopsy or too late skin biopsy may not yield the...
Whenever you have the lesion, you got to do it. Many a times we have picked up patients like this. In fact, we tell them, we discharge them from OPD, they don't get appointments. So we tell them wherever they are, you go to your dermatologist and get the biopsy done. Don't wait for your appointments to come to us, and get the slides with them.
Lymphoma. One more thing you have to consider is lymphomas. Sometimes it can present with all these manifestations.
That's why I said unexplained hypocomplementemia, cytopenias, thrombosis. The first instance of thrombosis, I had the ulnar artery thrombosis. Was it a similar type of vascular lesion as the big toe, or it was a frank gangrene?
It was gangrene.
Frank gangrene. Okay. Anything else?
Ranjan
wants
one
to say
basic
something?
question.
So when you say
Can
urticaria,
the,
Dr. Ranjan?
So once you say urticaria versus urticarial vasculitis, usually the urticaria would last more than 24 hours, and as I told, it will leave. So within in vasculitis, so that will give you that window when patient can undergo the biopsy. Number one. Number two, your thrombocytopenia can be explained because the patient was 3+ DCT positive. That would have caused splenomegaly, and hypersplenism would lead to thrombocytopenia. So
splenomegaly was not there, sir.
So you checked. Okay, fine. And the third thing is you may probably try doing IgA isotypes of ACL and anti-beta to GP1 because you are calling it seronegative. So before calling it seronegative, rare cases can be positive for that. So that's my suggestion.
Dr. Radhakrishnan.
Urticarial vasculitis does cause so much of eosinophilia compared to allergic urticaria?
I mean, the degree of eosinophilia is always difficult. I mean, you can get all sorts of eosinophilia. That may not help us solely to differentiate, that's all.
Thank you, sir.
Sapan?
Yeah, so very interesting case. I think what we forget sometimes is the demography. Young female, we start thinking of connective tissue disease spectrum. It may be A negative, we know that it is. But you have DCD positive, you have globulins which are high. I think protein was 7 with an albumin of 2. So the globulins are around 5. I saw the report. So hypergammaglobulinemia, complements low. So immune complexes are being consumed. As he said, AIHA was also there. And the concept of urticarial vasculitis versus urticarial differences that we were taught traditionally, there are reports from France which say that aisa zaruri nahi hai. You sometimes just get urticarial lesions. So as Ruchika said, you have to biopsy then, only then. So it's the only issue is whether the vasculitis was from eosinophilia or was it because of vasculopathy. That we don't know. And I'm sure there must be reports of hypocomplementemic urticarial vasculitis with eosinophilic vasculitis. You will get those kind of case reports also. The only thing is the ANA is usually positive in 80-90% of these cases. That is the only odd thing. But demography is something we should always remember. So,
yeah, I mean, even I looked at after I read this case on the risk of thrombosis in hypocomplementemic vasculitis. It is not. Unless you have an associated, unless there is an associated major connective tissue disease. We have a student there who wants to ask.
Sir, I just wanted to know what is the evidence of vasculitis in this? Can't it just be EVANS with some TTP overlap, with some ADAM-TS13 maybe deficiency, which can have low complements as well and can have prothrombotic risk as well? Why are we thinking of an immune complex mediated or a vasculitis in this, sir? It can just be an EVANS syndrome with ADAM-TS13 deficiency.
See, I mean, the only reason here was the low complement. As you rightly said, yes, it could be the whole spectrum. That's where the whole debate, that's where this case is being presented, vasculitis versus vasculopathy. Although none of us will be able to confidently say whether it is vasculitis or vasculopathy.
You said there was pericardial effusion. What was the ejection fraction? 2D echo must have been done, right?
Yes, ma'am. Debuted twice in the both admissions. It was normal. She had only persistent serositis and it was TAP. It was transudative only.
Thank you. I think,
Fish, you can do a biopsy even if you don't get any yield. Next time patient develops urticaria, you have to do biopsy.
Fish for?
If you can do genetic analysis, you can definitely do a biopsy. Skin biopsy is mandatory for this patient.
Absolutely.
so I think we go home with a message about skin biopsy. Nothing wrong in screening for DADA2. Keep paraneoplastic in mind. Next time, some unusual presentation comes up, any seronegative patient who doesn't fit the bill, always think of other causes. Okay? Well done. Thank you.
Thank you.
So we have the last presenter for this morning session, Dr. Venkat Sai.
So, good morning to all the dignitaries on this stage and also in the audience. I am Dr. V. Venkat Sai, first year DNB resident from KIMS Hospital, Hyderabad. I am grateful to my mentor Dr. Sharchandra Molli and also Dr. Sriharsha sir. So here I am presenting my case, vasculitis without borders. So this is initially evaluated elsewhere. A 42-year-old male who is a military male presented with low-grade continuous fever, maximum temperature 99 degrees, relieved with a daily tablet of paracetamol 650 mg. And he has a history of weight loss of 8 kg in a span of 3 months with easy fatigability, and left upper limb claudication symptoms with diminished radial artery pulse on left side in June 2025. Apparently, the patient has lost all the records. Only the last record was available, and this data is taken from that last record. So there was a significant past history to the patient. He is a known case of hepatitis B since 2018, and the record showed that the hepatitis B was not active and he was not on any treatment. And he admitted in November 2023 with chest pain and shortness of breath and into the cardiology department, and diagnosed to have aortic regurgitation and hypertension, but the etiology was not established there. Patient was started on tablet telmisartan 40 mg. So in the workup noted there, the CBP, mild leukocytosis, neutrophilic is there. ESR 60 mm, CRP 24, both inflammatory markers are raised. ANA by AF and ANA profile were negative. C ANCA, P ANCAs were negative. And CT angiography demonstrated diffuse circumferential wall thickening, luminal narrowing in ascending aorta and ascending aortic arch with aneurysmal / dilated segments. And coronary CTA reveals anomalous origin of right coronary artery from left coronary sinus with interarterial course, a congenital anomaly. There was no documentation of PET-CT anywhere in that old record, and we are not able to collect the old records also as they are not available. Patient was diagnosed with Takayasu arthritis, and patient was started on injection tocilizumab 560 mg IV monthly, tab prednisolone 30 mg with 5 mg tapering every 10 days, and tab methotrexate 10 mg once weekly. This all happened in June 2025, and with the following treatment, the fever subsided, fatigue improved, and the left upper limb claudication symptoms improved according to the patient. He received 3 doses of injection tocilizumab 560 mg and currently on tab methotrexate 20 mg and tab prednisolone 5 mg. He presented to KIMS OPD in October 2025. Sudden onset right ankle pain and swelling for 8 days, and sudden onset right elbow pain and swellings in 6 days. Initially, he went to orthopedics, cardiology, and cardiologist, as there was no PET-CT, maybe they ordered a PET-CT scan. And then after seeing the PET-CT report, it was referred to vascular surgery, and from vascular surgery, the case was referred to rheumatology. So vascular surgery team and rheumatology combinedly saw this case after that. On examination initially, pulse rate was 82 per minute, all peripheral pulses are felt. There was no, as documented in the previous, left radial pulse was not felt. Here we could palpate the left radial pulse also. But the right brachial and right radial artery decreased in intensity, and also right posterior tibial artery decreased pulse. And bilateral dorsalis pedis also there was decreased pulse. No carotid bruit and no renal artery bruit. Radioradial or radiofemoral cannot be commented. Blood pressure, right upper limb 130 by 80, left upper limb 135, left lower limb 140. Not much differential blood pressures are seen. Temperature was 100 degrees and right ankle edema is present. C1, S1, S2 normal, and musculoskeletal system, there was right elbow swelling and tenderness with right ankle swelling and tenderness. Initial investigations revealed a total WBC count of 12,490, and there was thrombocytopenia, platelet count of 67,000. ESR was suppressing the normal, CRP 2.95. Remaining all parameters are within normal limits. So the whole body PET-CT ordered by cardiologist revealed hypermetabolic short segmental non-opacification of right tibia peroneal trunk, and there was circumferential thickening in the ascending aorta and arch of aorta, and there was splenic infarcts. So this was the aortic thickening and the carotid thickening. And along with that, color Doppler revealed right brachial artery with thrombosis, right tibioperoneal trunk, dorsalis pedis, and first dorsal metatarsal artery with thrombosis, arteritis, and thrombosis. So extensive workup is done for the patient. APLA panel LAC DRVVT ratio 1.24, mild positive. Considering all the possibilities, we have to rule out all the medium vessel, muscular medium vessel, because splenic arteries are there and muscular arteries are involved. So we had a doubt that this was a large vessel with medium vessel extension, and the medium vessel workup was done. So HLA B51 and 52 are negative. The pathology was negative. He's a background of hepatitis B, but there was no active disease, but still a polyarteritis nodosa could be a possibility. So we had screened for ultrasound abdomen, then grade 1 fatty liver with mild splenomegaly. And infectious workup, as there is aorta involvement, we had sent for VDRL negative, MON2 QTB gold negative, and we repeated the HBsAg, quantitative DNA which was low, HBeAg negative, no active disease now also. And CT peripheral angio revealed the similar findings which correlated with the Doppler. CT abdominal angio revealed splenic infarct plus mild splenomegaly, and the renal artery and the splenic artery are normal with no bleeding or no aneurysms. Splenic infarct, and the CT angio showed tibioperoneal trunk involvement, and the CT abdominal aortogram revealed there were normal splenic and renal arteries. So now we are with a diagnostic dilemma. There was splenic infarct, but there was nothing can be seen in the splenic artery, looks almost normal. So the problem list was in 2018 he has hepatitis B, 2023 hypertension and aortic regurgitation, etiology was not known. June 2025 diagnosed as Takayasu arthritis, given 3 doses of injection tocilizumab 560 mg IV monthly. And now he presented with arthritis with thrombus in right brachial artery and right tibioperoneal trunk, and the splenic infarcts and thrombocytopenia. So our DDs at that time was polyarteritis nodosa, vascular base, DADA2 vasculitis, large vessel vasculitis with medium vessel involvement, and APS. So the 4 points against polyarteritis nodosa are splenic infarcts, medium vessel involvement, and hypertension. But there were normal splenic and renal arteries and no aneurysms or bleeding anywhere. Large vessel vasculitis with medium vessel involvement, there was circumferential wall thickening of the ascending aorta, although there was no PET uptake. Vascular base, large and medium vessel involvement, but normal femoral vein thickness, HLA B51 negative, pathology negative, no other systemic features of base. APS, lupus anticoagulant, mild positive, but thrombosis in multiple vessels, but circumferential wall thickening of the aorta and medium vessels, we say otherwise. And DADA2 vasculitis, medium vessel vasculopathy, splenic infarcts, thrombocytopenia, everything can be explained, but the aortic thickening cannot be, carotid thickening cannot be explained solely by DADA2. So the diagnosis is given medium vessel vasculitis, splenic infarcts, acute thrombus in the right brachial artery, and with a background disease of large vessel vasculitis, congenital anomaly, chronic hepatitis B, and hypertension. Advised patient for ADA2 levels and also whole exome sequencing with close follow-up. So there was a after 3 months of tocilizumab also he developed the medium vessel vasculitis. So we thought we'll, considering all the possibility of vascular base, polyarteritis nodosa, DADA2 vasculitis, and the failure of tocilizumab, we had proceeded TNF alpha may be the best option at that time. So we had started tenofovir alafenamide as a prophylaxis for Hep B therapy and started adalimumab, 1 injection, and injection heparin followed by tab rivaroxaban as suggested by the vascular surgery team. Methotrexate, prednisolone in tapering doses, we continued the aspirin which was started 3 months back, and for hypertension we continued telmisartan. But we thought we'll follow up in 15 days. There was emergency presentation in 10 days post-discharge with weakness of right upper limb and lower limb with altered sensorium. Patient conscious, intermittently obeying commands, but there was a right upper limb, right hemiplegia. Emergency CT revealed subarachnoid hemorrhage, and CT angio revealed bilobed aneurysmal rupture in M2 segment of the left MCA territory. Patient was admitted in the neurosurgical ICU. So we could see the subarachnoid hemorrhage, and there was a bilobed aneurysm from the superior division of proximal M2 segment. So this bilobed dissecting aneurysm of the proximal M2 segment caused intracerebral hematoma and supratentorial hydrocephalus. Right frontal EVD was placed. High pressure clear CSF noted. EVD kept for CSF diversion and ICP control. But despite all these measures, patient had neurological deterioration with brainstem death, grade 4 encephalopathy and apnea test positive. So along with the previous problem list, we have now fatal bilobed intracranial aneurysm with subarachnoid hemorrhage. So this is a case for open discussion. We had, there were not much key learning points. We had so many questions to ask the fraternity. So when medium vessel disease appears in a patient with established large vessel vasculitis, the diagnosis deserves rethinking. This pattern may reflect disease evolution and overlap vasculitic syndrome or a parallel process. Serology and imaging do not provide absolute clarity in complex vasculitis, differentiating polyarteritis nodosa, Behçet, Dada to another variable vessel vasculitis. Vascular involvement in vasculitis is dynamic and may not respect traditional vessel size boundaries which were given. Apparent shift between large and medium vessel disease should prompt reassessment of the underlying biology. So my key questions to the panelists were, in a patient with concentric large and medium vessel vasculitis, arterial thrombosis and splenic infarcts, which single diagnosis best integrates all the findings. When large vessel involvement coexists with splenic infarcts, should this be approached as a large vessel with extension or medium vessel with secondary large vessel involvement? In this clinical context, we have no clue that the aneurysm is acquired due to inflammatory or vasculitic process, or it is a congenital aneurysm, because routinely we don't screen because there is no headache, no symptoms of CNS manifestations. In this clinical scenario, which treatment modality would be most appropriate? TNF alpha considering all the possibilities, polyarteritis nodosa, cyclophosphamide, or we have to give tocilizumab another, and what factors would guide that choice? Thank you.
Thank you, doctor. So the first thing I want to tell you is the classification for large vessel, medium vessel, small vessel is only for our ease.
Yes, sir.
Okay, it is not a diagnostic classification. Okay, it's a classification criteria, that's all. We know of cases of vasculitis which have a significant overlap between the vessel sizes. So there are cases of large vessel vasculitis with present with medium vessels. Or we have, on the other hand, we have patients with medium vessel vasculitis which have large vessel, and small vessel vasculitis with aortitis and even temporal arteritis. So we don't have to bring in another new diagnosis of medium vessel. So we don't have to be paranoid about the vessel size. It's about managing the patient that becomes more important here. That's the first thing. Now I have two questions for you. Had you seen this patient in the beginning? Now you're not responsible for what was done before. Gone for tocilizumab. You know, you said the patient was treated with tocilizumab at diagnosis.
Yes, sir. Sir, frankly, sir, the CT which was done previously showed the aneurysmal and also dilatation. There was no PET CT, and we could know what is the activity there. And the patient does not know anything. And their assessment was only written. So
no, I'm saying, had you seen the patient, would you have used? That's all was my question. I'm not asking about their assessment. You won't know about it, no? The reason why I asked you this question was I don't want students to go home with the message that biologics, tofacitinib is the treatment for every problem in this world. There is still conventional, because if you look at Takayasu data, the primary endpoints were never met in the tocilizumab trial.
Yes,
all the secondary endpoints were met.
Yes,
we are still using, it's not that we are not using, exceptional situations we are giving as the upfront treatment. But for every Takayasu, I don't think you should rush in, because you saw the methotrexate was 10 milligrams and tocilizumab was given. I mean, if you want to reduce inflammation so urgently, you can even give JAK inhibitors.
Yes, sir.
You don't even have to go to that. But that's just a learning point.
Maybe initially we would have seen, maybe we have started methotrexate on this.
I would have thought.
And the problem is here, I don't think the patient responded to tocilizumab, sir, because even after 3 months of therapy, as soon as the steroid tapered from 30 to 5 mg, he developed again.
So it's a different question whether 3 months is enough to gauge response to therapy.
Yes, sir, definitely.
What parameters you would have used to say the patient responds? So it's a different discussion altogether. We leave it for now. And one more question I have for you, while differentiating medium versus large vessel. You said the renal arteries and the splenic arteries were normal. Where do you expect arterial involvement in polyarteritis nodosa? Which artery is involved?
Medium vessel to small vessel.
No, which artery? So you said renal artery and splenic artery were normal. Would you expect a renal artery aneurysm in polyarteritis nodosa? No.
That was because there was a hypertension at 40 years of age and the etiology was not known. We thought it would be the renovascular hypertension and we want to rule out that, sir.
That
That's
is there. I was asking about the arterial involvement. It's important to understand that in polyarteritis nodosa, it's not the main renal artery that is affected. You have to look at intraparenchymal arteries. So when you ask for a CT angio, please ask your radiologist to do early arterial phase and late arterial phase, because otherwise they will miss out on the intraparenchymal aneurysms. So the lamellar and the arcuate arteries have to be looked at, and it needs a certain degree of reconstruction of images to pick up microaneurysms. So just because the renal arteries were normal, it will not exclude PAN.
Yes, sir.
Now I'll give it to the expert on Takayasus to comment.
I'm not very clear about the diagnosis of large vessel vasculitis, although I was confused with what is the imaging finding. But from what I got from you, there is only a circumferential wall thickening.
Yes, madam.
And you said ascending aortic narrowing. I have not basically seen ascending aorta being narrowed.
No, it was mentioned in the previous.
Yeah, whatever previous, we are not talking about previous, present, and future. We're just talking about what the patient has. So finally, after your discussion, what is the finding in the ascending aorta is what I wanted to know.
We could only find circumferential wall thickening and carotid thickening here.
Yeah, so I'm not very convinced with the diagnosis of large vessel vasculitis. I feel she's behaving like PAN to me.
Yes, ma'am.
And you have to treat
We have to
PAN. And more important is that you go to targeted therapy only after establishing what the disease is. If you are not sure about which pathway are you dealing with or which disease are you finally targeting, it is good to go with non-targeted therapy rather than going with targeted. Any targeted we talk about.
Now, what's your clinical diagnosis? When you see the patient, examine the patient with the history and clinical examination, what's your diagnosis?
Sir, on examination, there was only decreased pulses in the right brachial and right.
What's the BP?
Sir?
What's the BP on the right side?
130 by 80, sir. And left side 135 by 80, left lower limb 140.
You say pulse is weak, not decreased pulse, weak
Yes,
pulse.
yes, sir.
BP is normal, pulse pressure is normal. Is that correct? Which is wrong? Your recording is wrong or your clinical finding is wrong? So you should not miss basic clinical examination. At least for rheumatology, you should have a correct clinical examination findings. Otherwise, it's very difficult to diagnose. This is where we will end up. After all, PET, CT, angio, everything, you will not be able to come to a conclusion unless you have a strong history and clinical findings. So for the clinical findings, as per your records, you have not shown any weak pulse or low in disparity, BP disparity, pulse disparity. Only the imaging findings shows that there is involvement of arteries.
Sir,
Then thrombosis. Patient had thrombosis, no?
Yes, sir. So, sir, at that time also we had the same doubt, sir. Why we are feeling only decreased intensity, but the pulse was. But, sir, can I?
Right. Don't forget about that. One important thing you should not forget is when the patient has regurgitation, AR, no? AR, cause for AR is due to aortic regurgitation. Another possibility is during the immunosuppressive therapy, somebody develops some serious complications, suspect infections, infect endocarditis, myocardic aneurysm. That could be there. That one possibility you have to consider.
2D echo, I did not mention, sir, but 2D echo we did, sir. It was normal. Sir, I had a doubt, sir, that these muscular arteries, when I looked up into the literature and when speaking to some people, these muscular arteries, if the occlusive thrombus is so much, only the pulse will be completely. If there is eccentric occlusion or if there is a
no, when the pulse is weak, pulse pressure should be low, no?
Yes, sir.
So BP is normal, pulse pressure is normal.
Okay, sir. I got
weak pulse indicates low pulse pressure.
Yes, sir.
So I'd just like to add one point. Clinically, when we feel the arteries, there will be a difference, but not necessarily it should reflect on BP, because most of the time the cuff we use is not the correct size cuff for lower limbs. So that can cause differences. A smaller sized cuff can increase the pressure, but the difference between the right and the left, that is difficult to explain.
Sure. Dr. Yojana?
One suggestion, I feel more specific triponomal tests also need to be done. Even though VDRL is negative,
Madam,
TPHA or FTFBS, were they done?
TPHA was done, madam.
And it was
negative.
Okay, because you didn't mention.
If I remember, hepatitis B was positive in him, right?
Yes, sir.
Why did you forget that? Can all this syndrome be explained with hepatitis B? Hepatitis B has been described to be associated with multiple vasculopathic manifestation, including thrombosis.
Yes, sir.
So you seem to have forgotten what you have done with hepatitis B. Though you started with hepatitis B therapy, parallelly you are trying to put on the immunosuppressions. So the question that comes in patients with hepatitis B positive pan-like or pan-like manifestations, so you need to treat both of them simultaneously. The outcome will be otherwise bad. So you seem to miss the whole hepatitis B in your entire spectrum of discussion.
Yes, madam. Hepatitis B is initially not treated, sir, but whenever we took over the case, we started on tenofovir alafenamide for the prophylaxis, sir.
So I think to conclude, few things. Whether this is large or medium, it doesn't matter. Whether the cerebral aneurysm was congenital or acquired, I don't think we'll ever be able to tell you.
Yes, sir.
Because nobody knows. Nobody has ever imaged the cerebral vasculature.
There was no classification also, sir, when I looked at the literature. But the reports available were bilobed and multilobed aneurysms are usually, at the bifurcation points, were usually congenital. The treating neurosurgeon said that when they went, there was a clear neck which was suggestive of a saccular more than
more a congenital aneurysm.
More a congenital, and he has already one congenital anomaly, so the more.
So that's an important point for us to learn.
Yes, sir.
Okay.
And also the size, sir. Size of the aneurysm was 13.5 mm, sir. So usually inflammatory or vasculitic aneurysms are less than 5 or more 5 to 10. 10 to more than 10 is generally considered as large aneurysm and usually congenital, sir. So.
Sure.
What's the height of the patient?
Sir, sir.
What's the height of the patient? Is the patient marfanoid?
The patient marfanoid.
No, madam. This patient is not marfanoid.
Okay. In terms of therapies, I think once again it's going to be difficult. You will probably have to choose a drug that fits both for large vessel and medium vessel.
Yes.
That is the only thing you can do here. Otherwise, it's going to be difficult. Thank you very much. And we finally come to the last part of the session. Dr. Kirti is going to take over and sum it up for us. Yeah. Oh, quick while Dr. Kirti goes.
Would a simple skin biopsy or an arterial biopsy would have helped? Takayasu would have showed granulomatous inflammation, which would have solved all our doubts. Or if we would have had any necrotizing.
Which skin biopsy? Where would you biopsy? There were not.
Any arterial biopsy.
Arterial is difficult, huh? I mean, it's not easy to do an arterial biopsy. You can only do it post-mortem. Antemortem arterial biopsy is going to be difficult.
For medium vessel vasculitis, we can at least do a deep punch biopsy and maybe look at the...
No, if you have a proper skin lesion that is suggestive of vasculitis, you can do a skin punch biopsy, a deep punch biopsy. But when you don't have any such skin lesions, arterial biopsy you can't. That's why you depend on so much imaging, and there's so much debate about how imaging, talks about this. So that is not something that we can do. Lastly, anticoagulation. Your thoughts, Dr. Chika?
I don't think this patient deserved anticoagulation.
Okay, Dr. Keith.
Good morning, everyone. So at the outset, I would like to thank Dr. Sharan sir and Dr. Vinod sir for giving me this opportunity, and I'm also happy that I'm not a part of the panelists, because I don't have to discuss all these cases when they come to me. I just have to give you all the conclusion. So I would be just giving a brief summary of what we've discussed and what are the key learning points, along with my personal comments added here and there. So we've had the first case where there was a middle-aged male who presented with arthritis, pontine infarcts, initially a doubtful scrotal ulcer, then developed splenic granulomatous disease, and then a granulomatous enteritis, then later developed multiple genital ulcers with a lot of discharge. So to start off with, when it was just arthritis, pontine infarcts, okay, it's fine that a vasculitis was considered, and they've started immunosuppression. But here the most important point to learn was there was the optimal dose of immunosuppression for somebody in whom you're suspecting CNS vasculitis was pretty less to start off with. But later, when there was a clear indication that there is a granulomatous condition running, obviously the differentials have to be infective versus immune mediated versus inborn errors of immunity. So once there is a suspicion that this could probably be an infection, because splenic granulomas and granulomatous enteritis both cannot be explained by Behçet's, then definitely we have to be very careful with the kind of immunosuppression we choose, especially in a person who already had an infarct. I really think tofacitinib should have been a very cautious decision to take, adding tofacitinib in this particular person. So in this entire case, I would say that infection would lie first, and definitely, as discussed, syphilis probably could explain the entire spectrum of manifestations. And all of us have learned that syphilis is a great masquerader, so it could actually have all these manifestations. Fitting everything into a single condition is possible even in immune-mediated disorders like Behçet's. Can be encouraged, but again, when there are very atypical manifestations like granulomatous enteritis or splenic granulomas, so obviously Behçet's probably was not the diagnosis here. I also wanted to know why investigations like HLA-B35, HLA-B40 have also been done in this patient in the very first visit. Okay, fine. Then the second case, if we look at systemic sclerosis with ANCA-associated vasculitis, well-known association that ANCA is associated in individuals with systemic sclerosis, mentioned in Hochberg in itself. But having said that, the manifestations of ANCA-associated vasculitis in a patient with scleroderma is not very commonly seen. But of late, a lot of immune-mediated manifestations are being seen in patients with systemic sclerosis, which we classically learn as a condition of vasculopathy. And as Dr. Ruchika has rightly mentioned, that more and more ANCA-related manifestations are being observed in patients with systemic sclerosis. So our threshold for testing for ANCA in individuals with systemic sclerosis has to be lowered. The second thing is when the patient presented with sudden onset worsening breathlessness with so many shadows and evidence of glomerulonephritis with active urinary sediments and worsening creatinine, how early to immunosuppress? Like, should we start pulse methylprednisolone on day one itself? Definitely. The picture was very clearly a pulmonary renal syndrome, so outrightly we would have actually started pulse methylprednisolone. But frankly, when you are seeing the patient, somebody who has been stable for so many years, suddenly lands up to you with breathlessness, fever, with those kind of shadows, infection will always be on our mind before we actually try and immunosuppress this patient. So I think in that particular situation, BAL would have really made a huge difference in this patient. You could have taken the decision earlier, rather than waiting for ANCA titers, or and probably a renal biopsy would have also helped. Coming to role of plasma exchange, again, there is no clear indication for plasma exchange in alveolar hemorrhage. It's a very individualized decision that people could take. But that does not rule out the possibility of giving high-dose corticosteroids in these individuals. Moving on to the third patient, where the diagnosis was not very clear, basically an immune complex-mediated condition with classical complement pathway activation, with most of the antibodies being negative. So predominantly a seronegative condition with the immune complex mediated activation with thrombosis, thrombocytopenia, and later the patient has also developed eosinophilia with urticaria. Again here, I think the diagnosis can be clinched by doing a skin biopsy. So skin biopsy becomes a very important investigation here. Beyond this, the other differentials which Dr. Ramesh sir has told us about, that is DADA2 and paraneoplastic manifestations, have definitely to be considered in this particular patient. Hypereosinophilic syndrome again is a possibility, but there are certain odd points for hypereosinophilic syndrome. The fourth patient, clearly vasculitis does not have boundaries. It is basically the predominant vessel that is involved which makes us label whether a patient has large, medium or small vessel vasculitis. So here it was typically a medium vessel vasculitis, predominant medium vessel vasculitis with hepatitis B positivity. So automatically the first diagnosis here would be polyarteritis nodosa. There is very minimal evidence to suggest that there is large vessel vasculitis. There is non-FTG avid mild circumferential wall thickening noted in the ascending aorta and other parts of aorta. So there is some overlap with large vessel vasculitis. The second important point that we've discussed here is that before jumping on to giving drugs like tofacitinib or biologics, conventional DMARDs have to be given at the appropriate doses before we say that this patient has failed on conventional disease modifying agents. And clinical examination is the key to diagnosis in all rheumatologic cases. History and clinical examination most of the times clinches the diagnosis. If you look at the overall session, I think if there's a single learning point for all of us, optimal immunosuppression is what is recommended. You should neither under immunosuppress a patient nor over immunosuppress a patient. So that optimal immunosuppression is the key point that you have to learn at the end of the session. Thank you.
Thank you, Dr. Kirti. With this, we close this session. Thank you very much for active participation from the audience, and I'd like to thank all my colleagues here who have been here with me this morning.
I thank Dr. Ramesh Joyce and all the panelists and the rapporteur concluding session on time. And we'll go to the next session, that is on miscellaneous rheumatic diseases. May I invite Dr. Chandrasekhar as the chairperson, and panelists Dr. Arun Hegde and Pooja, rapporteur Dr. Shyam. Over to you.
Good morning. At the outset, I thank Dr. Sharath and his team for inviting me to be a part of this session. I think you have heard through the specific diagnostics, which are of a great keen interest to most of us as rheumatologists, the vasculitis, rheumatoid, lupus, and so on. And also we are forced to encounter a few of the things which we are not really very keen or very much working with. Of course, they happens to be sometimes quite interesting, and that's one where we have grouped him into as a miscellaneous group of diseases. I think we will start the session. Right. Thank you. So I take this chance to acknowledge our eminent abstract reviewers, Dr. Madhuri, Dr. Abhilasha Manvatkar, Dr. Sunitha, Dr. R.K. Naidu, Dr. S. Nayan Patel, Dr. Soumya Khota, Dr. Ramineni Tejaswini, Dr. Gupta, Dr. Savan Kumar Apani, Dr. Kaveri Nalinda, Dr. Sri Harsha Vedulu, Dr. Vishal Marwa, Jitin Matthews, Dr. Kaustav Mitra, Dr. K.V. Kishore Babu, Dr. Shilpa Suvarna, Dr. Soumya Ranjan Tripathi, Dr. Anu Srikanta. I think we have 4 cases to be discussed. I think the first one is the enigmatic swelling, a decade-long journey, followed by Unmasking the Mimickers, and two more of them. I think I will call upon Sri. No, not Sri. Dr. Yoga Priya to take over.
Good morning to one and all. I am Yoga Priya, second year general medicine resident from AIIMS Raipur. Okay, now I am going to present the case of 24-year-old female who initially presented to us at the age of 12 years, and it is a decade-long history. Initially, her symptoms started nearly at the end of 2012 and early 2013. At that time, she had complaints of right-sided neck swelling since 2012, which was gradually progressive, and it was not associated with fever, night sweats, or weight loss initially. So on grossly, the patient had multiple matted lymph nodes involving the level 2, level 3, level 4, and level 5 cervical lymphadenopathy with fixity to the surrounding structures. And on biopsy, and the patient had initially treated elsewhere, and she came to us by 2015. Both in outside hospital as well as in our hospital, she had underwent multiple FNACs as well as biopsies, which revealed granulomatous lymphadenitis with necrosis, sometimes showing not even necrosis also. And however, AFB was negative, CBNAT was negative, PAS stain was negative, as well as GMS was negative. And as shown in the picture, the CECT revealed conglomerated right-sided cervical lymphadenopathy. So considering the clinical scenario, the most common diagnosis in our country, we also thought it was tuberculosis. And then we initially tried with ATT for 6 months. It was during the period of 2013 to 2014. However, even after 6 months of ATT, the patient did not show any resolvent symptoms. And next time we did a re-biopsy as well as repeat FNAC was done. And again we considered it was whether it was MDR TB, and she had also received second line ATT for 9 months around the period of 2016 to 17. And in one RT-PCR, she was detected for NTM, and she was also received rifampicin, ethambutol, and clarithromycin. However, there was not any resolvent symptoms. The patient continued to have swellings along with the fever and the constitutional symptoms. Now, since we thought it cannot be no more an infective process, we went ahead with PET scan. The PET scan revealed FDG with cervical, axillary, and internal mammary lymphadenopathy. And we had a differentials between granulomatous lesion versus lymphoproliferative lesions. And the patient had ESR, high ESR of around 170, and the patient also had MAM2 negative. So we thought whether it was a granulomatous lesion like sarcoidosis. However, the patient did not show any response to treatment with steroids. So whether it was infective or inflammatory. And the patient continued to have symptoms. Around the year of 2020, we did a repeat biopsy and repeat FNAC was done. It showed a granulomatous lymphadenitis, but this time it came, the IC showed positive for CD15 as well as CD30, and we thought it was Hodgkin's lymphoma. The patient also received ABVD for 5 cycles and underwent radical neck dissection. And this is the PET scan following the treatment, which showed some resolvent lymph nodes. So PET-CT showed residual diseases, and at the end of the therapy, the biopsy showed fragmented lymphoid tissue with extensive fibrosis and collagen, and tumor board discussion was done, and the chemotherapy was withheld. However, and it was thought to go ahead with other autoimmune workup if the patient continued to have symptoms. And to our surprise, the patient continued to have lymph nodes, right-sided neck swelling, and at this point of time, we did ANA by IF, which came positive for nuclear homogeneous. However, the patient did not have any other symptoms. So at this point of time, we had differentials between whether it was infective, inflammatory, and malignancy, and autoimmune. Following this, the patient had lost to follow-up for around 2 years. Now, again in 2023, the patient presented to us with an added manifestation. At this point of time, the patient had right-sided neck swelling, multiple right-sided neck swelling, just 3 months before presentation. However, there was no fever, no constitutional symptoms, no skin rash or joint pain suggestive of any autoimmune disease underlying. And along with it, she also had swelling in the right submandibular region for the past 2 months and associated with painful right-sided jaw movements as well as dysphagia. She also had added complaint of blurring of vision in the both eyes, which was painless, progressive, right followed by left, and there was no history of trauma, headache, double vision, eye redness. This is the clinical picture. So the patient had multiple firm, mobile, non-tender right-sided lymph nodes. And since the patient had blurring of vision, we went ahead with a fundus examination, which showed snowball appearance suggestive of bilateral vitritis. So at last, where were we? Whether it was infective, inflammatory, malignancies. And this point we had all the differentials of Kikuchi, whether it was Kikuchi's disease or because of elevated ESR, whether it was sarcoidosis or it was any IgG4 related disease or disseminated NTM or lymphoma. So other investigations revealed like CBC was normal. During the course, the ESR had come down to 65 and serum calcium was normal and serum ACE was also normal. And HIV was non-reactive. ANA blood was also done, which was showing rho 52 kd. And MPOPR3 was negative and IgG4 levels were within normal limits, along with serum ferritin being normal. So we went ahead with vitreal biopsy and sent the sample for AFB and CBNet and liquid culture, and which all came out to be negative. And at this point, we did a repeat cervical lymph node biopsy, which showed reactive lymphadenitis, but at this point, it was not positive for CD15 as well as CD30. So meanwhile, during the course, the patient also developed complaints of difficulty in speech, and the patient also had flaccid dysarthria, and she also had uvula deviated to the right side with tongue atrophy and tongue fasciculation. At this point of time, we did a CECT neck and head, which showed a mass involving superiorly up to the base of the skull and involving the right parapharyngeal as well as the posterior nasopharyngeal space. And we went ahead with the nasal endoscopy and and we found to have a mass around the fossa of Rosen-Muller, and biopsy was done, and biopsy showed positive for cytokeratin, which was suggestive of nasopharyngeal carcinoma. So putting all these together, the patient from the very beginning had persistent lymphadenopathy, and then during the course of time, she tested positive for CD1530 suggestive of Hodgkin's lymphoma, and she had also developed a nasopharyngeal carcinoma along with the uveitis, which is vitritis. So all these, putting together all these, we come to a conclusion of chronic EBV infection. The diagnostic criteria of chronic EBV infection includes, first one is severe infectious mononucleosis kind of symptoms, which is lasting for more than 3 months. And the detection of increased number of EBV genomes in peripheral blood or affected tissue, and EBV infected T or NK cells on the peripheral blood or affected tissue. And it should be like a chronic illness that cannot be explained by the other diseases. So in this patient, he had a EBV DNA viral load of around 47,000 and EBR fish was positive. So this patient, along with the discussion with the tumor board, she went ahead with neoadjuvant chemotherapy, gemcitabine and cisplatin, followed by radiotherapy. And currently, the repeat PET scan showed resolving in symptoms, and she is doing well. So the key take-home messages include chronic EBV infection should also be considered as a close differential to autoimmune disease, infection and malignancies. And every ANA-IF positivity or blood positivity doesn't mean a presence of an autoimmune disease. And granulomatous lymphadenitis is a pattern, not a disease. Refractory to appropriate treatment should prompt diagnosis and evaluation for non-infectious and viral etiologies. And my questions to the panelists are, what are the immunologic manifestations of EBV infection? And when and how to suspect EBV infection? Should EBV be considered in an unexplained autoimmune serology with lymphadenopathy?
I think it's a wonderful case. I think it's an eye-opener for all of us. I think even the last of the case in the session before, there was a hepatitis B which was sitting. And here also, there is a virus which was sitting and causing the trouble of a differential manifestations, which as a specialist in rheumatology and working in immunological cases, we should keep our eyes open. Most of the infections can sometimes mimic several of the autoimmune disease. The vice versa is also a possibility. And the worst to happen is you may have both of them together. I think many of us in our experience would have had a sarcoidosis and tuberculosis overlapping, and we would have a lot of infections which overlaps the manifestations plus being a part and parcel of the same autoimmune disease. And I think the message is very clear. Yes, I think I agree fully with you that we need to keep the infections as one of the differentials when we get on with some of these manifestations. EBV is known to have several of its manifestations, being having a high affinity to infect the immune system cells, especially B cells. Triggers B cells in a polyclonal way. It can have most of the manifestations that you are described with autoimmune manifestations. In my experience in last 2 decades, we have EBV presenting as urticaria, only plain urticaria, EBV presenting with several of the autoimmune diseases, or a chronic persisting lymphadenitis evolving into a different manifestations. I think we need to keep our eyes open, especially with reference to EBV. Same also holds true with cytomegalovirus. So the question comes, when you are not sure of these kind of situations, it's always best to have once a screen for EBV. And also, if also for a CMV, think about these two as viral diseases which can manifest with it. ANA testing can be positive in many of the viral infections, including EBV. EBV is never an exception since it polyclonally stimulates. So in an unexplained scenarios, it's always best to have EBV being tested. First to do the panel of different antigens, followed by the demonstration of the virus genome in either in the PCR method or in the cell levels. So that's where you can demonstrate that yes, there is a possible EBV infections, and treatment can be targeted at EBV infections. That helps a lot in getting the patients right in track. So I think I call upon Dr. Hegde. Any comments?
Yes, so sir has summarized most of the things. Some other things which can be associated with the EBV, one is HLH. We saw one case yesterday. Apart from that, mononucleosis acute presentation, we all are aware. So basically you suspect EBV whenever there is a constellation of maybe a cervical lymphadenopathy, constitutional symptoms, long-standing fevers, and you are not able to reach a diagnosis. Always think of a background EBV, and you know how to screen for it. You have to do a viral capsid antigen, IgG, IgM. And Ig is an old infection, IgM is a new infection. You can also do the early antigen IgG on the EBV DNA titers. High titers are very, very suggestive of EBV infection. And of course, the gold standard is as you said, in situ hybridization. That's the gold standard for picking up a latent EBV infection. And should EBV be considered in an unexplained autoimmune serology with lymphadenopathy? Yes, we should always keep it in our at the back of our minds. And as sir said, it's known to affect the B cell. So you can have a polyclonal B cell activation leading to hypergammaglobulinemia. It can induce cold agglutinins, false positive antibodies like rheumatoid factor, ANA. That's why you got your ANA as positive. It can also cause certain immune manifestations like autoimmune hemolytic anemias, thrombocytopenias. So vast variety of infections can even precipitate, EBV can precipitate certain X-linked immunodeficiency disorders. And also it can precipitate a flare in RASLE. So basically you have to keep your horizon wide.
One more thing I like to add to it, that from the beginning itself, though the patient had granulomatous lymphadenitis, she did not respond to ATT. Okay, and thereafter considering sepsis, again she did not respond to treatment. So when she was not responding to the treatment, standard line of treatment for what we think an etiology for granulomatous lymphadenitis in our country, so we should think about something else. Even though autoimmune markers were positive, but yes, think about infections which can mimic autoimmune diseases. I think keep our vision much more broader and just not limited to only the autoimmune diseases. That's my take on this.
Yeah. Anything from
I'd just like to add one. In mid-80s, when the etiopathogenesis of rheumatoid arthritis was evolving, in fact, the concept of rheumatology in India was evolving. We were thought that one of the important etiological factors for rheumatoid arthritis was Epstein-Barr virus. It's given in almost all textbooks in those days. So it can cause polyclonal stimulation and can give rise to many manifestations.
Yeah, I fully agree with, actually see the relationship between the infection and autoimmune disease is a highly controversial, which is going on from decades. We think the virus stimulates it or virus facilitates it, but it could be probably the rather facilitate rather than stimulating it. The both are the possibilities. Yeah.
Sir, actually my thing is, why not consider chronic active EBV? That's a slightly different thing. You are told it is a chronic EBV. There are clear criteria for that, because patient has had a remission exacerbation like a roller coaster ride. and that is the important point. It's a relatively new disease. As Colonel Hegde said, we need to do a EA. We have the full panel, and right up in the diagnostic workup, we need to do that, because we have a lot of referral bias. By the time it reaches our teaching institutions, it has been worked up with all that. So we need to think from the physician angle oftentimes, and not think only from the rheumatology perspective.
My comment is that this patient had lymphadenopathy which persisted for 12 years, and she started developing new nodules one after the other. So that itself should have, because this is some lymphoproliferation is happening for so long, that should trigger a search for a inborn error of immunity. And most likely they are EBV-driven lymphomas or lymphoproliferative disorders. And even though she is a female, the most commonly described EBV-driven lymphoproliferative are XLPS, X-linked lymphoproliferative. There are a lot of other mutations which have been described, which can cause EBV-driven lymphomas. So I think that should also be.
Yeah, I would agree with Sundaram here. So not only X-linked lymphoproliferative disease, there are several other immune deficiencies which can predispose to EBV lymphoproliferation. EBV is a ubiquitous virus. Why this patient is harboring EBV in her lymph nodes for so long, for 10 years? So I'd be interested in her genetics, what predisposed her to develop such a kind of EBV lymphoproliferation. It will have a therapeutic implication, because if you find an inborn error of immunity, the immune cells are the problematic, you would go for an upfront hematopoietic stem cell transplantation. Probably you can arrest the further progression of disease. Or if it is something like a APDS, activated PI3 kinase delta syndrome, you may consider, apart from treating EBV, you will consider a immune modulatory agent such as sirolimus or leniolisib.
Yeah, please.
So granulomatous reaction can be there to any antigen. We had similar case where granulomatous, we also did mistake of diagnosis sarcoid and all. But I learnt in the pathologist that you can have a granulomatous reaction to any antigen. So that can be there in lymphomas also to present with sometimes. My question was what they all said, that the Rho was also positive, Rho, and so must have been since long. Rho antibody must have been since memory tests and all. Would rituximab early on have prevented the complication in this patient giving EBV Heto? Just wondering.
No, I think so I'll take that question. See, the use of rituximab in the presence of Epstein-Barr virus is a little contradicting and controversial. When there is a high B cell proliferation, you can use a rituximab with a balanced coverage of anti-EBV drug. So the overall outcome has said to be good, especially if you have a high proliferative B cell with the other manifestations of EBV. You can use rituximab, balancedly covering the EBV proliferations. Yeah, thank you, Yoga Priya. I think the lesson we learned from this particular case is actually, as a specialist in immunology, handling the immune suppression, seeing many of the autoimmune disease, we should keep our eyes open for a possible infection in the background. Either it could be the manifestation or it could be a part and parcel of the manifestations. With this, I'll call upon the next presenter, Dr. Subin Philip.
Good morning, everybody. I'm Colonel Subin from JIPMER, and my guide is Professor Molly Mary Thaba. And I'm going to present a case when IgG4 misleads a multi-system fibroinflammatory puzzle. So it all started when a 22-year-old MBBS intern was brought in a very sick state by her father to our OPD, that is around around November 2024. With a diagnosis of refractory IgG4 disease, quite sick state, and a history dating back for around 1.5 years. So it all started in June 2023 when she had a pain abdomen, typical pancreatitis with biliary vomiting, amylase lipase was raised. CT showed peripancreatic fat stranding, CBD was dilated. Few atypicalities were there, that is, there were features of retroperitoneal fibrosis and right hydroureteronephrosis was there. on the basis of retroperitoneal fibrosis, pancreatitis, IgG4 levels was done in the hospital, which was elevated. And on that basis, she was diagnosed as biliary pancreatitis and IgG4 related disease and underwent ERCP and stenting. She also underwent DJ stenting for the hydroureteronephrosis. For the IgG4 related disease, she received MPS pulse followed by prednisolone. Following this, she used to have recurrent pain abdomen. She had recurrence of pancreatitis. She had an episode of cholangitis with fever and pain abdomen. CT severity score was around 4. CBD stent obstructions were there, for which the stent replacement was there. The stent was replaced. She was placed on antibiotics for the cholangitis. She was started on azathioprine as a maintenance immunosuppression, and the prednisolone was tapered. Following this, for the next around 10 months, she was okay. She continued her internship. She used to have on-off pain. Her creat had come down to 1.8, still carrying the diagnosis of IgG4-related disease on azathioprine 100 mg. Now, things went haywire from August 2024 when she had recurrence of fever and started new symptoms in the form of breast lump and perineal skin thickening. On evaluation, she had bilirubin of 4.8. This urine PCR was 2.1 with worsening azotemia, for which she was evaluated with the help of a renal biopsy, which showed some features of tubulointerstitial nephritis. Elevated plasma cells were there. Few IgG4 cells were there in the report. The breast and perineal skin biopsy report also was labeled as favoring IgG4 related disease with a positive CD68 and 138, and she was labeled as refractory IgG4 related disease, and due to recurrent stent block, she underwent this ERCP, and lap cholecystectomy was planned. But as per the discussion from the treating physician, what had happened is that the intra-op, when the lap cholecystectomy was performed, the surgeon described that the gallbladder was typically hard, like a porcelain bladder. They had to abort the procedure. They had to place a biliary drain. Following this, she used to have on-off infections, fever was there. She was, before coming to us, almost 1 month she took injection meropenem. She was placed on prednisolone 30 mg and started on MMF of 500 mg BD. So when she came to us, she was sick looking. Immediately she was admitted. She had Cushingoid facies. She had pallor, left axillary lymphadenopathy was there. There was no salivary lacrimal gland swelling. She had fever, tachycardia was there. Musculoskeletal examination was normal. She had a non-tender mass in the right breast, and she had perineal skin thickening with local tenderness. There was anal stricture, mild bleed was there. Rest of the systemic examination was normal. On evaluation, at our hospital, hemoglobin was 8.6 with a normal TLC platelets. She had azotemia, that is urea was 62, creat was 1.6. There was slight transaminitis, amylase lipase was elevated. There was hypoalbuminemia, urine PCR was elevated, that is 2.95. Tumor markers were elevated, CA125 and CA199 was elevated. In view of sepsis, the features of sepsis, blood culture was done, which showed MDR E. coli growth with synergy test positive. After discussion, we started on ceftazidime and aztreonam, with which the fever gradually improved. The immunological investigation showed a negative ANA, P-ANCA was 2+, HSCRP was elevated. IgG4 levels in our center was normal, and normal complement levels was seen. Her ultrasound showed now multiple small hyperechoic areas in the periportal areas, and with scarred kidneys, and DJ stent was in situ. She used to have intermittent chest pain during admission, severe chest pain requiring analgesics, for which, though the ECG and TROP was normal, echo showed some RWMA in the anterior and lateral wall. So the infection was found, fever the patient was having intermittently. She was having severe chest pains requiring opioid analgesics. So there was a question, why, if the patient is having with a label of IgG4 for the past 1 year, why is she not responding to the standard treatment? Meanwhile, to evaluate the ultrasound findings. There was history of jaundice, the recurrent infection in the GB pouch. MRCP was done, which showed a mass in the porta hepatis with few other atypicalities. So the differentials of malignancy came higher than IgG4 related disease. Meanwhile, the patient started deteriorating. New manifestation was there in the form of CVT. The patient had right eye ptosis, diplopia, worsening fever was there. This is the MRCP, which is showing the mass in the GB fossa. There were hypo-intensities in the kidney. There was a mass in the liver. There was hydroureteronephrosis, mass in the breast, and sigmoid sinus thrombosis was there. We asked to get all the slides from the previous hospitals. On the review of renal biopsy, IF was negative. There were features of tubulointerstitial nephritis. IgG4 staining was just 0 to 2 plasma cells per 50 HPF. There was no increase in the IgG positive plasma cells that was seen. The lymph node biopsy, FNAC, was done in our center, which was inconclusive. The GB specimen we had got, that also did not show any malignancy, any features of IgG4 related disease, but extensive fibrosis was there. The breast and perineal biopsy, it was CD68 and 138 positive, and pan-CK was negative. The CBD brush cytology was also reviewed, but there were no malignant cells. So we thought of doing a PET CT and further do a biopsy. The PET CT, as you can see, was showing multiple organ involvement, especially the pelvic region. If you will see, there was extensive involvement, bilateral breast, liver, kidney, pleural deposits were there, myocardial deposits were there, and other atypical deposits were there in the form of muscles. Axial and appendicular skeletal involvement was also there. So finally, we did the biopsy of the breast, which we had thought that, okay, the differential is Erdheim-Chester also. We'll do the biopsy. We'll see if it is negative, then we'll send for BRAF mutation. But the biopsy of the breast showed these sheets of atypical cells, atypical lymphoid cells, which was strong CD20 positive, high Ki67 index. CD3 was not expressed, indicating a high-grade diffuse large B-cell lymphoma. So she was managed by the oncology team and started on rituximab, cyclophosphamide, epirubicin, vincristine, prednisolone chemotherapy regimen, with which she has got complete remission, complete radiological remission is there. She has been asymptomatic for the past 6 months, has completed her internship now. So considering what were the things towards IgG4, retroperitoneal fibrosis was there, plasma cell rich interstitial nephritis was there in the kidney biopsy, early steroid responsiveness was there. 1 year she was doing quite okay. Mild IgG4 elevations were there early. Against were multiple things like a young age, fever, pain. All this was against IgG4 related disease. Her biopsy did not show any sufficient evidence of IgG4 related disease. She was progressing despite all the immunosuppression. PET showed atypical organ involvement, and the breast mass finally showed high-grade DLBCL. Though on reviewing the literature, in fact, other lymphomas can show higher level of IgG4 cells. IgG4, IgG ratio can be elevated in other lymphomas also. And this is a case review of 31 patients in whom IgG4 related disease were actually lymphomas. In them, what atypicalities were seen is that whenever there is axial lymph nodes, high increased size of the lymph node is there, elevated LDH, ESR, CRP is there, they point more towards lymphoma, whereas pancreatic involvement, retroperitoneal involvement, and the histological features goes towards IgG4 related disease. And they can even have features of IgG4 in the form of 4 patients had dense lymphoplasmacytic infiltrate, 3 had fibrosis, 2 had IgG4 cells more than 10, and 1 had IgG4 by IgG ratio more than 40%. So to take home, we had a patient managed elsewhere as a case of IgG4 related disease, but had lot of red flag signs. We had, she underwent lot of biopsies, underwent lot of painful procedures, but finally we could get the diagnosis and manage. There was lot of atypicalities, and definitely PET CT might help us to guide the biopsy for the tissue diagnosis. Thank you.
Thank you for a nice presentation. It's a take-home message is actually, see when you have a red flag signs, labeling a patient as IgG4 disease without having an adequate tissue diagnosis is inappropriate. I mean, the thing is, she has been multiple time biopsied, though they have identified the presence of plasma cells, but I don't think the IHC for IgG4 staining has been done or done towards the end of the day. I mean, that's where we miss the bus. That's where the criteria also emphasizes and insists that a pass-through if there is a proven histopathology diagnosis. Otherwise, they need to fulfill a lot of criteria, and most of the criteria still suggest to keep it as probable unless proved otherwise. I mean, the take-home lessons is this. Of course, IgG4 disease can evolve into the lymphomas, but your case very clearly suggests that when you went back to her old tissues and did the IHC staining, none of the IHC staining showed it to be IgG4 positive. So it's a lymphoma which was missed rather than a IgG4 disease evolving into the lymphomas. Any lymphoproliferative disease can evolve into lymphoma down the line. I mean, there must be one or two case reports which I tried to get, but I couldn't find. But we should keep our eyes open for evolving of any of these kind of disease through the time into the lymphomas. I mean, that's something which we have to keep in mind. Hegde from.
Yes, sir. Again, the main point is the red flag. So fever is a very important red flag. IgG4 usually will not have fever. And this patient had, I think, the second presentation there was fever, and the third presentation maybe there was some infection also, E. coli, so the fever was there. Secondly, the response to steroid is not very optimal. It is a very poor response to steroids. Thirdly, extensive nodal involvement and larger size of lymph nodes should take us towards lymphoma rather than IgG4. If you look at the organ involvement, pancreas and submandibular is more in favor of IgG4. And the other lymph nodes, like the other glands like lacrimal and the other organs would take us more towards a lymphoma. And as you said, high ESR and CRP is more towards lymphoma than IgG4. And higher LDH and more severe anemia would take us, like she had severe anemia 8.6, I think. That would also take us towards a diagnosis of lymphoma rather than IgG4. Like sir said, I could find one single report where a autoimmune pancreatitis has progressed to a lymphoma. That is the only case report I could find regarding the answer to your question number 2. Apart from that, the literature is very scarce about IgG4. There is some mantle cell lymphoma and all reported, but not too much of literature is there about progression of IgG4 to lymphoma.
My take on this is that I think it was lymphoma all the while. It was never an IgG4 related disease. Why? Because there were, though IgG4 levels were high, but the classical features were absent and the patient did not respond to treatment. And apart from that, sir already mentioned there were some atypical manifestations like fever, even breast lump, perianal skin thickening. These are not manifestations of IgG4 related disease. And so I think PET CT should have been done earlier with the earlier core biopsy. I think this would have saved her from all the pain that she underwent.
Pardon?
UPCR is not high in IgG4RD.
Yes.
Proteinuria you do not get in IgG4RD. That's
exactly.
I mean, this is a case of where the confusion was with IgG4, but in general, in adolescents, we see this happen a lot, where patients are labeled systemic JIA, and they will have fever, they will have raised inflammatory markers, some arthralgia, no overt arthritis, and but actually they would never really qualify for a diagnosis of systemic JIA. The fever would be not so much like a quotidian pattern, and there would definitely be type B symptoms. There's an eagerness to start steroids to these patients, and I think this was worse during the immediately post-COVID period, when that diagnosis of MISC was allowing people to start steroids for patients where they suspected MISC. And I've seen around 4 children in that era who actually had lymphoma, missed as either MISC or systemic JIA, started steroids, and then the situation became, and all these patients eventually died. Even though we made the diagnosis subsequently, they actually died because the one problem is with lymphomas is they can be very steroid sensitive, and it can take a long time for the disease to bounce back to a level where we can recognize it. And in that period, all sorts of messy things can happen. And so we really have to be very careful when we give diagnostic labels that involve the use of steroids, because we can mask serious diseases that can be treated differently.
I mean, that's a perfect message to everyone, especially the youngsters. Before you pick and choose the steroids, make sure yourself that the diagnosis is 100% sure. Only in exceptional circumstances is to salvage time for the patient to be back to bouncing. That's the only place where you can use an steroids of high dose, bring her back, wean it off early, get back to the diagnosis. Yeah. Yes.
So I think the other thing is anemia. So we had a similar case, and I don't know if Sanket is in crowd. My colleague, he had said the same thing. A patient आया था, the referring hematologist did everything, biopsy and all, and a very eminent hematologist of Ahmedabad, and he said to start treatment for IgG4. This is IgG4, and Sanket was the first to see. He said, "Sir, fever, eh? I really don't think." Now, how to tell that gentleman that this is not IgG4, the big man, you know? So we said, "Sir, we can't start this, that." The other thing was anemia in that patient. 4-6 transfusions within 2 months. That much of anemia, like in stills also, couple of patients I saw, 2-3 transfusions within 2 months. You don't see this much of anemia in our patients, so except for hemolytic anemia. And this patient ultimately turned out to be an adrenal CA. She died actually. 2 months down the line, she had a mass, B symptoms, fever, high fevers, very high CRPs. The pressure was to start something, as everybody said. And we gave in also a little bit of steroid. We gave in to that, but ultimately we said, no, this has to be biopsied. My question was, and yesterday also there was a similar case discussion here. In that small group which they report as atypical, 2 pathologists saw that, and I pressed them to see. They said, we cannot call this a malignancy. But is there something more that you can do looking at the clonality of these cells to actually, pick up if these are IHC bhi kiya tha. So, but can we have something more, because that group of cells in the second biopsy was large, and that is how the malignancy was picked up, adrenal CA. Is there some kind of clonality or test we can do in those patients, because even the pathologists are, and it may be difficult. It's not that 2 pathologists have seen, it's not easy probably, but carcinoma being missed becomes a problem, because so. Can we have some, are there those kind of tests?
As to the best of my understanding, probably the IHC and doing some of the genetic techniques could be of some help, but they're expensive and not easily available. Those are the 2 things which are there. And we need to remember that what we are testing is on a small sample of the big mass. So it's the chance of both the treating doctor and the patient that we pick the right specimen. That's always a problem in these kind of tests. Yes.
Just one second. So fever generally does not occur in IgG4 already is a really good take home. Like it could be infection, it could be lymphoma. I remember one patient of mine referred to me by a very senior chest physician for some lymph nodes here, biopsy, and IgG4 raised, start IgG4 RD treatment. And I was very skeptical because of this patient all the time having fever. I said, you start, it doesn't look like IgG4 RD. And I told the relatives also, doesn't look like, because this feature is something against. So the chest physician started the patient on treatment for IgG4 RD. With steroids and methotrexate, and patient actually had tuberculosis, developed paraplegia, and poor guy is wheelchair bound. So, like fever should really make you alert that it could be infection or malignancy, and very rare or shouldn't occur only in IgG4.
No, as you said right, the systemic manifestations are usually milder or lesser in IgG4 disease, because it's been time and again mentioned that IgG4 is a benign proliferation of the plasma cells, which is dysregulated to have more of secreting IgG4, which is in turn responsible for fibrosis. See, that's the process and the mechanism which we have. So we don't expect too much of a systemic manifestation in IgG4 disease per se, whatever the extent to which it is infiltrated. Usually most of the manifestations are the organ-specific manifestation because of the organ's fibrosis. So here she had a lot of other things which were not explainable. That should alert us to make ourselves doubly sure that it's an IgG4 disease. I mean, that's a nice take-home message. We have time, I think.
Hello.
we are done.
Sir, one question is there, sir.
Yeah.
It's a PET scan we are all doing, sir, but PET scan was showing multiple infiltrate at multiple sites. In this case also, I have seen 4 patients, sir. We are doing lot of biopsies. Lot of biopsy will give inconclusive report. Then it's very difficult to convince one more biopsy, and that 2, 3 biopsy, one will pick up like lymphoma. 2 of my patients came with myositis with muscle infiltrate. Then they were not responding to, initially they will respond to steroid. As this in this case, they will respond to steroid. They will respond, but when after 6 months, they will not respond when patient is becoming bad. Then we are doing multiple biopsy. Then one biopsy will show us, yeah, T-cell lymphoma is there. And PET scan, if you are doing, there are too many sites showing SUV 3, 4. So the problem is from where to get that biopsy, because in my setup it's very difficult to convince patient and to convince pathologist or other people to get that multiple biopsies, because they were like 1 year disease is there, it's not lymphoma, it is not T cell or B cell lymphoma, forget about it, and patient has already done 3 biopsies. So how PET scan will help us to get the proper biopsy sites?
No, see, the rule as I understand and remember is you should take the biopsy, if possible, from the site where there is highest SUV and where there is an highest uptake. And also, if you have a previous analysis or previous workup done, it should be picked up from a site where it is not too old nor it is too new. The rule continues to be the same. The reason is, 2 newly appeared lymph nodes or any other things could be reactive, whereas the one which is too old would have fibrosed enough to get you into any of the diagnosis. The best is to take something which is in between these 2 areas. The next thing is, in the PET scan, if you are suspecting a possible IgG4 disease, instead of going to the routine PET scan, there are fibrosis-specific PET scans. You pick and choose that. If you are sure about IgG4 disease, ask your nuclear medicine department to do this set of scan. That should help you to differentiate whether it is an IgG4 related disease or any other proliferative disease. I mean, this is a way where you can make the best use of the PET scan in these kind of situations. Yeah. Thank you, Colonel. I think it's very nicely presented. The take-home message is, from the second one is, don't forget your another enemy, the malignancies. The first enemy is an infection. The second enemy is going to be your malignancy. And I call upon the next presenter, Meghana Somshekar, Dr. Meghana Somshekar.
Next, whatever it is, you ask the question.
Very good morning to one and all present here. Continuing along the lines of the previous case, I'm going to present an interesting case which does not just change the diagnosis for the patient, also changed our approach to these kind of patients. So starting with January 2020, when the patient first presented to the Department of General Medicine, he's a 40-year-old male with hypertension and diabetes. He presented with complaints of insidious onset of shortness of breath, which was present for the duration of 2 months, along with complaints of noisy breathing, which was present for 1 week. He had no history of any fever, cough, chest pain, or palpitations. On examinations, his vitals were stable. However, the patient had stridor. He had bilateral monophonic inspiratory wheeze, and his other systemic examination were within normal limit. This was suggestive of an upper airway obstruction, so they went on with a ENT evaluation. They did a direct laryngoscopy, and it showed a circumferential submucosal hypertrophy at the subglottic region with about 30% patent airway. And they took a biopsy from this region. Meanwhile, the patient was empirically managed with hydrocortisone, nebulization, antibiotics, and other supportive treatment. They evaluated him further. His routines were normal, including the APRs which were within normal limit. They did an NCCT neck and thorax, which showed circumferential wall thickening in the subglottic region with luminal narrowing. There was no other significant finding in the NCCT. Meanwhile, they got back the biopsy report, which was suggestive of acute and chronic inflammation composed of lymphocytes with scattered plasma cells. And the IgG4 IHC, which was done, showed plasma cells of 10 to 12 per high power field, which was suggestive of IgG4 related disease. During this time, while the patient was still in the hospital, he developed redness of both eyes along with mild pain, and he was diagnosed as episcleritis. At this point of time, a rheumatology consult was sought from the department, and we advised some rheumatological workup which showed, including ANCA, IgG4 levels, ANA, and rheumatoid factor, everything were within normal limits, and even his workup for TB was within normal limits. So we went on to look for any other evidence of IgG4 related disease, as the biopsy was just showing 10 to 12 per high power field of IgG4 related, IgG4 positive plasma cells, no other evidence of significant fibrosis. So we wanted to see, is there any other evidence? So we went on to do a whole body PET CT. To what it revealed to us was, there was soft tissue thickening with FDG avidity, which was present along the mediastinum, just retrosternal abutting onto the cardium. And there was also thickening of the large vessels, starting from the ascending arch of aorta, descending aorta, up till the bifurcation of bilateral iliac arteries. So considering this, we had a patient with large vessel vasculitis, subglottic stenosis, episcleritis, and histopathological evidence suggestive of IgG4 related disease. We made a diagnosis of IgG4 related disease and started the patient on pulse steroids. He received 250 milligrams of methylprednisolone for 3 days, along with cyclophosphamide. Considering that the patient had subglottic stenosis, we wanted a rapidly acting drug, so we chose for cyclophosphamide. He received this treatment, and within a week, the patient started to improve clinically, and he was discharged on oral steroids. And he received cyclophosphamide doses for next 3 doses, following which, owing to the COVID pandemic, patient was lost to follow-up. For the next 3 years, patient was not on any medications. However, the patient says that he was symptomatically fine, and there was no deterioration that he noted. But 2 months later, 3 years later, for duration of 2 months, patient again developed shortness of breath, which worsened from MMRC grade 2 to grade 3, along with chest pain, which was dull aching, non-radiating, not associated with any cough, hemoptysis, fever, or diaphoresis. He had significant weight loss of 8 kgs over 2 months, and he had also developed a cutaneous nodular swelling, which was present along the right shoulder on the posterior region, which was associated with significant pain. At this point again, on examination, patient had cervical lymph nodes bilaterally, which were approximately 1 into 1 centimeter in size and non-tender, and systemic examination again were within normal limits. We did the routine investigation. At this point, his creatinine was on a slightly higher levels, and his HbA1c was within elevated. CRP was 22, and the echo showed that the ejection fraction was 65%, and there was no evidence of pulmonary arterial hypertension. I'm sorry. So we repeated the PET CT to see what is the disease activity status of the patient. So here what we could see was that there was worsening of the large vessel vasculitis that we had seen. There was increased thickening, asymmetric circumferential thickening of the large vessels, again extending until the bifurcation of the aorta. And then there was also increased soft tissue thickening and avidity, which was present along the intraatrial, interatrial septum and intraventricular septum region. And there was uptake in the medullary cavity of bilateral femori and bilateral tibia. By now you must have guessed what we are dealing with, and we also knew that this is no more IgG4 related disease. So we discussed with the hematological team, and we went ahead with the bone marrow, and that showed marked increase in histiocytic activity with prominent histiocytes with CD68 positivity suggestive of histiocytosis, with CD1A negative and S100 negative with CD207 negative suggestive of non-Langerhans cell histiocytosis, most probably Erdem-Chester's disease. So the cutaneous nodule, which was bothering the patient because of the pain, it had to be excised, and this biopsy was done. It showed foamy histiocytes with Tauton giant cells, and along with histiocytes, which showed strong positive for S100 and CD68, and CD1A was negative, and ALK1 stain was negative. And what it showed was the characteristic feature of emporipolysis, that is histiocytosis engulfing the lymphocytes or the plasma cells, which is characteristic of Rosai-Dorfman disease. Along with that, the IgG4 stain which was done was also showing IgG4 positive plasma cells of 7 to 8 per high power field. So as you can see in this table, the patient had CD68 positive, CD68 positive cells, S100 positive, CD1A ALK1 negative. He also had Tauton giant cells, which is classical of ECD more than Rosai-Dorfman disease, and emporipolysis, which is more common with Rosai-Dorfman disease. So to confirm whether we are dealing with ECD or RDD, the histopathologist went ahead with another staining, which is cyclin D1 and OCT2 staining, which is said to be very sensitive for Rosai-Dorfman disease. That turned out to be positive. So at the end of this journey. The story so far was in 2020, patient presented with subglottic stenosis with epic scleritis, PET-CT showing periaortitis or large vessel vasculitis, biopsy suggestive of IgG4 positive cells, diagnosed as an IgG4 related disease, treated with steroids and cyclophosphamide 4 doses, lost to follow-up thereafter, presented with complaints of shortness of breath, cutaneous nodular swelling and cervical lymphadenopathy, along with PET showing periaortitis, intramedullary bony lesions and cardiac soft tissue thickening as well. Bone marrow biopsy showing non-Langerhans histiocytosis, nodular biopsy suggestive of Rosai-Dorfman disease. So we came to a final diagnosis of histiocytic neoplasm with an overlap of Erdem Justice disease with Rosai-Dorfman disease. To go ahead with the treatment, we did a BRAF mutation analysis, which was found to be negative in this patient. We advised the patient to go ahead with chemotherapy with MEK inhibitors, considering he had significant organ involvement. However, owing to the financial constraints, patient refused the treatment. So the hematology team decided to start the patient on steroids and azathioprine, which was started for him. The key learning points from my case is that ECD can closely mimic IgG4 related disease, leading to diagnostic delay. Multisystem involvement, including coated aorta and bone lesions, should raise suspicion of histiocytosis. Overlap syndromes such as ECD RDD may occur and require combined clinicopathological imaging and histological evaluation for accurate diagnosis and management. These are my questions to the panelists. Thank you.
No, I think it's a very nice case. I mean, I'm not very sure whether the first diagnosis IgG4 can be completely attributed, but of course, there were a good number of plasma cells which were IgG4 positive. The only thing is that the serology is not really the indicator of either to exclude or to include the diagnosis of. You can have enough number of patients with IgG4 disease with normal IgG4, and the other way around also we have seen in the previous case where IgG4 was high, but it's not really the IgG4 disease. So serology is not a real distinctive marker. It's usually, as we said, as we were discussing from the last two cases, it's the progression of the disease which you have to keep in mind, and the organs that are typically affected by that. If anything which is not classically described with IgG4 disease is present, you should raise your question that are we dealing with something else? So, I mean, that's where probably both your team as well as the hematologist could come into the right conclusion that the diagnosis could be anything else other than the IgG4 disease, and the ongoing staining of the tissue that has been extracted has definitely helped you to conclude the diagnosis. So the immunotherapies conventional is not that great with reference to when it comes to the ECD-RDD overlap, but of course, it's always the patient consent which matters. So in this case, given the choice, we would have gone to little more aggressive immunotherapies, but of course, the ultimate decision maker is the patient. The way we have trying with this, we have to wait and see how things go. Sometimes it can work, but under normal circumstances, we don't expect it to work.
So I think it's a very, very interesting case, and cases of Erdheim chest studies are very, very orphan, and we hardly see. I have maybe seen only one in the last maybe 10 years of practice. So congratulations to you on successful management of this case and diagnosis. Regarding the first question, key features that reliably distinguish early ECD from IgG4, did you ask the history of any bone pains?
So he did not have any bone pains. It was an incidental pickup during PET-CT.
Yeah, so what the literature generally gives is the early features of ECD are usually bone pains, and because they have osteosclerotic lesions in the lower end of the femur, in the metadiaphyseal region, which accounts for these bone pains. And the reason we miss these lesions on PET is because the usual protocol for a PET is up to mid-thigh. So you have to be very, very particular that if you are suspecting a ECD, then you have to tell your nuclear medicine specialist to scan the entire lower limb and not restrict it to mid-thigh, otherwise you'll miss this lesion. Secondly, other early ECD manifestations are retroorbital masses. So even this patient I don't think had any retroorbital mass. They can have early CNS manifestations like symptoms of diabetes insipidus, cognitive dysfunction. And apart from that, what is the optimal diagnostic approach? The ECD and RDD, we should not treat it as watertight compartment. There will be an overlap between both the clinical manifestations. Lesions of RDD mostly will be more of cervical node. The nodal masses will be higher, and you'll have more incidence of dural CNS dural masses like meningiomas. And as far as the biopsy goes, you have clearly mentioned the ECT, the foamy histiocytes with the CD68 positivity, as well as the two-tone cells are more in favor of ECT compared to RDD, where you get that emperipilosis. So that is, and the S100 positivity, that would take you more towards the RDD feature. But the general approach would be to label it as a spectrum, ECT RDD spectrum, and you define which is the morphological prominent phenotype. Then you define the radiological phenotype as per the radiological lesions, like the classical lesions here shown as the coated aorta and the hairy cell kidney with the Erdheim-Chester disease. And then you go for an NGS and you do the mutation, because that is what is going to decide your therapy in future, whether you have the BRAF V600 mutation or not. And then you go about treating the patient. Regarding the effectiveness of immune suppressants, the response to steroids is there only for constitutional symptoms. And if there are CNS manifestations, then there's a reduction of the cerebral edema, so that manifestation will respond to steroid, but it will be very transient and suboptimal. As far as azathioprine is concerned, it has got a role in treating cutaneous lesions in RDD. That is the only, and the respiratory lesions, they also respond to azathioprine. In your case, the patient started with subglottic stenosis. So even subglottic stenosis is also being reported as a manifestation of Rosai-Dorfman disease. And I think, what is the next manifestation after subglottic stenosis?
So he had the large vessel vasculitis, which was...
Yeah, episcleritis is again a very rare manifestation.
Yes.
Usually it's a retroorbital mass, so episcleritis is generally not a common manifestation. So that's a little outlier as far as the clinical manifestation is concerned.
So I think that before labeling the patient as IgG4 related disease, we must be, I think, very sure about the serology does not help. We must have a classical histological pattern also. Just a raised IgG4 will not, and some manifestation does not prove that it is an IgG4 related disease. I think we must follow the patient and look at the other other features that come up, and then accordingly label and treat the patient. So this is an, again, take-home message for all of us, that before labeling the patient, just I think be very sure about your that the patient has all the features of the disease.
I wanted to add on that we went back and discussed about the biopsy retrospectively once the patient was diagnosed with Erdheim-Chester disease. There was no evidence of any histiocytosis in that biopsy which we did initially, where we made a diagnosis of IgG4 related disease. We were ourselves not convinced with IgG4-RD because, again, the biopsy was not classical and IgG4 levels were not normal. But because there was no other evidence of any other illnesses that we had evaluated for, that is when we made a probable diagnosis of it. So sir, is it possible that the histiocytes, without being seen in the biopsy, they are manifesting as like subglottic stenosis and episcleritis being a manifestation of ECT, and biopsy not showing any histiocytosis? Is that possible?
No, the issue here is that the biopsy is from as I said in the very beginning, the biopsy is a sample which you pick.
Yes,
It depends on whether the sample what you picked have it or doesn't have it. Probably it's misleading because the peripheral sample would have been picked up in that, where there was more of plasmacytes and more of little bit of fibrosis. I mean, that's where we sometimes, because see, the problem in all these immunoproliferative disease is it also brings in the proliferation of its neighborhood cells.
Right.
When these histiocytes proliferate, it also secretes those cytokines and other products which stimulates the proliferation of the other neighborhood cells. That's where the other cells proliferation cannot be excluded or avoided. See, it's not like a pure malignancy, like where it's only isolated that cell multiplies. Pathophysiologically, what really happens here is the cells in addition secretes the cytokines, which in turn stimulates the other neighborhood cells to proliferate, and that's where we get misled.
So I have two comments to make. Beautifully worked up case. I have had two patients with Rosai-Dorfman. And one, we have used a combination of dexamethasone and lenalidomide. So that has given us beautiful results. We had a patient with retroocular tumor with intracranial extension and cerebral edema, and that's where dexamethasone was chosen. There is one open label series which has shown that using dexamethasone is more useful than prednisolone, and it is pulse therapy. It is not continuous everyday therapy. So there is a pulse therapy schedule for dexamethasone as well as lenalidomide. So that is something rather than azathioprine, because amongst the evidences for rosidorsman, I mean the evidence is very small. Amongst the drugs that have been tested, lenalidomide has some data compared to azathioprine. So that is one option. My second patient did not tolerate lenalidomide, so we gave him methotrexate and he's doing fantastically well. So just
So there have been data about even IL-1 and IL-6 inhibitors, tocilizumab. Do you have any experience with
No,
this?
no. I've seen only 2 patients confirmed Rosidoffman, biopsy-proven Rosidoffman, and these are the 2 ones I have treated with these 2 drugs.
Yeah, just to add on to what Dr. Chandrasekhar said, like in the previous case, there was lymphoma, but for the first biopsy was something like IgG4. This case, it was a histiocytic disorder. Initial biopsy was like IgG4. I have also encountered a solid organ malignancy. The patient had a lung mass. The first biopsy showed IgG4, and then the patient was treated for 6 months. There was absolutely no response, and they did a second biopsy. It turned out to be a lung adenocarcinoma. So you always need to be very careful about labeling patients. We need a longitudinal follow-up. We should not just diagnose IgG4 and forget about it. A lot of times when the disease persists, it could be really surprising. And one of the things we have also seen is the histiocytic disorders. My question to the panelists and to the presenter is, like from what tissue did you send a blood for BRAF mutation, or did you send the tissue for BRAF?
So it was serum. We didn't have the
Yeah,
facility in our hospital to do it in the tissue, so we did from the serum. So
No,
it was
you need to send whole blood, no?
So?
Like even if you're sending, you need to send whole blood for the mutation, not.
So it was done for the blood sample.
So ideally, it should be sent from this thing, and you need to test for BRAF as well as the MAP kinase mutations, because in severe cases like in which when the myocardium is involved, all those things, targeted therapies like vemurafenib and trametinib make a big difference. Otherwise, you are going to lose the patient.
So he was negative for BRAF mutation. We asked around for MAP2K mutation, but there was no labs which were doing that mutation, so we could not get it done.
Okay. Fine. Yeah. So, is there anybody with experience of finding negative in whole blood and finding a positive in tissue? Like, I just wanted to know the experience of the.
It's a relatively rare disease. Anybody else has the experience? Ramesh, did you have that? Tissues. Okay.
You had a scant plasmacytic infiltrate, no? That's what you mentioned.
Sorry, sir?
That biopsy had a scant plasmacytic infiltrate.
Yes, sir. In the first.
Usually IgG4 would have a dense.
Yes, sir. That is why we looked for other organ involvement also. When we had the periaortitis, that is when we thought probably it is IgG4 related disease.
But you have relatively good number of cells. I think 10 to 12 cells.
10 to 12 per high pathway, sir. Yes.
Dr. Meghna, is it a known entity, RDD and ECH overlap? Because there's a LCH and EDD urgent gesture overlap, but is this a known entity?
So very few
Why
case
not
reports.
only S100 positivity, so label it as just RDD and treat it as?
So there are very few case reports. As I mentioned, MAP2K mutation has been seen as an association for an overlap of ECD and RDD, and there are around 2-3 cases that have been reported so far with similar manifestations.
Okay. I think last and quick comment.
Mostly cutaneous.
Yourself, quick.
The stridor as a manifestation and the subclottic stenosis we also seen in GPA, right?
Yes, sir.
So GPA, IgG4 and the biopsy actually showed quite a bit of IgG4 as. So I think these could just be syndromic manifestations of what the primary problem was, histiocytic disorder, which manifested as. So in the future you will have these, with coming of omics, you will have these trajectories where this entire spectrum will probably be just one. The taxonomy is going to change, I think. So these are just same spectrum but different severity of disorders, and this will be a syndromic problem seen in these patients.
Sir, as of now, there is no data on to say whether IgG4 progresses onto ECD because they say it is not possible. But I sense that there are.
Sapan stole my conclusive proof that actually these are the lessons for us to say that the current approach of getting into single diagnosis is always a tough choice in these kind of diseases. I think thank you very much. I'll call upon the last presenter. Sri Rekha. Yeah. Okay.
Good morning, respected dignitaries and my colleagues. I'm Dr. Rekha, resident at KIMS. Today I'm going to present a case of kink in the flow. This is a story of a 16-year-old female who initially visited a physician for the febrile illness. So on examination, she was found to have hypertension, which was incidentally detected hypertension. She was prescribed antihypertensives and was referred to a nephrologist for the further evaluation. So on nephrology evaluation, the complete blood picture and the inflammatory markers were normal. Urine routine, UPCR was normal, and renal function test, liver function test were normal. So they went ahead with renal angiogram. It was done outside, so was not able to procure the images. Only the report was there. There is narrow caliber of bilateral renal arteries and short segment circumferential wall thickening with mild luminal narrowing in the proximal renal artery till the bifurcation, and the kidney size were normal. And she was treated with antihypertensives and referred to a vascular surgeon in view of renal angioplasty. So the vascular surgeon has performed a CT iotogram which showed moderate to severe narrowing in the right renal artery starting from the ostium until the bifurcation, and there is narrowing in the left main renal artery, and also the left osteoproximal narrowing in the left hilar accessory renal artery. And this CT iotogram is suggestive of either a fibromuscular dysplasia or vasculitis. So at this point, she was referred to a rheumatologist, and she came to our rheumatology department with a history of hypertension, and there is no history suggestive of any headaches, blurring of vision, syncopal attacks, claudication symptoms, no history of chest pain, exertional dyspnea, no constitutional symptoms, no other CTD symptoms, and there is no family history of any autoimmune diseases. So at this point, 15-year-old female, young onset hypertension with renal artery stenosis, normal inflammatory markers, and no history of any autoimmune disease. And so the differentials at this point was fibromuscular dysplasia versus Takayasu arthritis. So upon examination, the general examination showed multiple pigmented macules of varying size all over the body, which were suggestive of K-Foley spots, and there are axillary and palmar freckles, and the pulse rate was 90 per minute, regular, and all peripheral pulses were felt. Blood pressure was 160 by 90 in the right arm supine position, no significant variations in the blood pressure in all the four limbs, and rest of the systemic examination was normal. So in this image you can see the K-Foley spots of varying size over the upper back and the trunk. And this is the image showing bilateral palmar freckles with K-Foley spot over the right forearm. So at this point, 15-year-old female with young onset hypertension with bilateral renal artery stenosis, normal inflammatory markers, and no other history suggestive of autoimmune disease, with an examination finding of K-Foley spots, axillary and palmar freckles. So the final diagnosis we thought of is neurofibromatosis with bilateral renal artery stenosis. This is the NIH criteria for neurofibromatosis type 1, in which at least 2 of the following 7 criteria should be fulfilled, in which our patient has K-Foley spots and freckling, axillary and inguinal freckling. So the differentiating features between the FMD and Takayasu was both can present at the young age of onset and female predominance. The common arterial involvement in FMD is renal arteries, and in Takayasu it is more of aortic and its major branches. And the systemic symptoms were absent in FMD, whereas Takayasu presents commonly with the systemic symptoms like fever, weight loss, and fatigue. And imaging shows string of bead appearance in FMD, whereas in TAC it will be the arterial wall thickening, stenosis, and occlusions. And the inflammatory markers are normal in FMD, where they are elevated in Takayasu.
So genetic analysis showed NF1 gene mutation, heterozygous variant, which is likely pathogenic. So the final diagnosis is neurofibromatosis type 1 with bilateral renal artery stenosis, and she was treated with antihypertensives, and need for renal angioplasty in the future was explained. So the learning points from this case is NF1 typically presents with K-Foli spots, multiple neurofibromas, axillary freckling, and ocular leash nodules. The 16% of patients with NF1 develop hypertension, which could be essential or secondary hypertension. And renal artery stenosis in NF1 is usually ostial in location, as in our case. And FMD, most of the stenosis are found in the distal two-thirds of the renal artery. And this case underscores the value of meticulous clinical examination in arriving at a correct diagnosis. So my questions to the panelists are, in a young female with early onset hypertension and renal artery stenosis with normal inflammatory markers, when should large vessel vasculitis still be suspected? And how can a renal artery stenosis due to vasculitis be differentiated from FMD or NF1 related vasculopathy?
That the clinical examination holds the key. See, when to suspect a arthritis, especially of inflammatory type, or when to suspect a benign non-inflammatory is actually, one is the clinical findings, especially if they have symptoms matchable to a inflammatory disease like vague discomfort, vague feeling, tenderness in the vessels. Of course, the inflammatory parameters being ESR and CRP being high. Few other inflammatory markers, even if ESR, CRP are not high, you carefully look at the neutrophil lymphocyte ratios where NLR is widened, even without increased ESR, CRP, consider possibility of inflammatory disease, look for it. In this case, it's a straightforward, it is the K-Foli spots are visible even in the sites which you will otherwise will be hidden by a female. I mean, these are available in the arm and those areas. So I don't think the chance of missing a diagnosis is less likely. And your clinical examination really makes you to feel the difference. Of course, the clinical suspicion is something which makes you to further evaluate and investigate. And you have nicely given the chart based on which you can try to differentiate between whether it's inflammatory Takayasu or any other major vessel disease versus a non-inflammatory structural diseases or structural defects. I mean, so the main emphasis is the clinical examination and suspicion of something which you cannot explain with the current clinical presentations. Any comment?
Very nice case. Only thing I would like to say is that the ESR and CRP in Takayasu can be normal in around 40% of the cases.
Yes.
So if it's an early pre-stenotic phase, it will be normal. If it's a late fibrotic stage, it will be normal. If the patient is on steroids, it will be normal. So if it's a focal disease, it can. So these four conditions, your ESR, CRP, don't go by the inflammatory markers per se in distinguishing large vessel vasculitis from a FMD. So, and the second thing is regarding the renal artery stenosis in FMD and NF1 versus Takayasu. So Takayasu and NF1 more or less they behave the similar way because the renal artery stenosis is more ostial in location. The only difference maybe is that in Takayasu it's more likely long segment, and here it is in NF1 it will be slightly focal. So that is the only difference. And other thing is age, you can say NF1 maybe even in children you can get, while the other two will be generally the young adults. And I think that's all.
So the take-home message from this case is general examination. I think most of the youngsters, they fail to examine the patient and sometimes even take a proper history. So had that been done by the physician himself initially, I think there itself your diagnosis would have been very, very clear, and the patient then could have been investigated accordingly. So I see the irony that the nephrologist, the vascular surgeon, and even the physician, they did not take the pain to examine the patient. And that is how the patient landed up with the rheumatologist who examined the patient. So I think it's a take-home message for all the youngsters that basics remain the same. whether it is rheumatology, it is nephrology, or it's a general physician.
Additionally, NF1 vasculitis, can involve the aorta and the mesenteric arteries. FMD
Yes, sir.
generally doesn't involve the
It can
aorta.
involve cerebral vasculopathy is also known.
FMD will generally not involve. That's another difference.
Yeah, I think
What,
Dr. Abhishek, yeah.
what is the mechanism, doctor? Why do they develop this vessel narrowing in these patients, NF1 mutation? And would you still do a MR angio in these patients? How common it is to get vessel narrowing?
Sir, in NF1 there are two mechanisms for vessel narrowing, sir. It is basically the neurofibromas present in the vessel, or else the vessel can be dysplastic. That is, there will be intimal proliferation and then medial thinning. That can cause the stenosis here.
And it preferentially affects the renal vessels.
NF1 with renal, the case reports were there, sir, and it can affect the cerebral also. Cerebral vasculopathy is also well known, and then mesenteric also is there, sir, in the reports.
Would you still do a MR angio?
No, sir, I haven't done MR angios.
It's preferable if you can get the further detailing, but it's not mandatory. It's unlike other aortoarteritis or anything. Since the proliferations is a chance, so you need to keep a watch. Only if you have a symptom, then you can go ahead with that. Otherwise, it's not mandatory like in aortoarteritis.
Financial constraints are also there, sir, with this patient, and so I basically referred her to a genetics department first. Only she visited our clinic once.
Yeah, that's
Just a small comment. This is a 16-year-old girl, and she's had, in a very short space of time, a renal angiogram followed by a CT aortogram, both presumably high radiation tests and nephrotoxic contrast as well to go with. As doctors wholly, we need to think when we are investigating particularly young children that we try and avoid particularly high radiation investigations and use them judiciously. Bone scans, for instance, have very little value in children, nuclear bone scans. Similarly, in this child, repeating CT-based investigations, I think we have to just keep a thing that we are exposing them at a young age to a lot of radiation.
I think call upon Sham to wrap up. Thank you.
Good morning. I'd like to thank the CRC team for inviting to this meeting. Though initially Kirti told the positive side of being a rapporteur, but negative side you have to be attentive throughout the session. That is the negative side. More attentive. So the first case was about a 23-year-old female who had a necrotizing granulomatous lymphadenitis. So basically it was a generalized lymphadenopathy. Initially, later the patient developed vitritis, then lymphoma, then esophageal carcinoma. I think enough discussion was done on that. So basically, we have to think of two infections many times which coexist with us. One is EBV, other is CMV. They are not so rare. Actually, they are pretty common whenever there is a high index of suspicion. Particularly in unexplained autoimmune, when the serologies are positive, antinuclear antibody is positive, hypergammaglobulinemia is there. Please do consider EBV infection. And other thing is, like how Dr. Sundaram pointed out, most important thing is, yes, patient had EBV, but was there any underlying immunodeficiency disorder in that patient for them things to go on for such a long period? So that was another take-home message. So it could be either, many times these situations, it could be an isolated EBV presentation, or any of these infections can also be associated with our autoimmune. It could be autoimmune along with the one of these viruses presenting along with it. Second was 22-year-old, again a female who had a biliary pancreatitis. Only IgG4 levels are elevated. Pancreatitis, then tubulointerstitial nephritis. So here, what we have to remember is IgG4 levels, particularly, of course, whether it is elevated or normal doesn't really contribute much. But many times it can be falsely elevated. So without a biopsy, we have to be very careful with having only isolated IgG4 levels, which is very non-specific. And always think about the classical versus atypical. We all know what are the classical manifestations of the IgG4. If any of those things are not there, like some red flag signs in those, and that patient particularly fever, a bit of a dominant lymphadenopathy, we have to be very careful. And remember, there are some conditions like IgG4 or maybe sarcoid, GCA, these are all steroid responsive conditions. At least initially there should be some response. So many times when somebody doesn't respond, instead of thinking it as a refractory disease, always think of an alternative diagnosis. And that case again emphasizes the importance of the histopathological, and we have to ideally discuss with the pathologist so that they know what is the clinical context. And one more thing with regard to the positivity of the sampling, how the sampling is done, what is the method, what is the site, because there are some sites like inguinal which we don't prefer, some sites which can be more pathological, and as I told, the size, the SU uptake, all those things before we go ahead with this, because every time we can't keep repeating a PET or a biopsy, we have to be very careful, discuss with the radiologist and then go ahead with the biopsy. And the other thing, see the previous sessions, we know that they were all at least an autoimmune disease, most of them. Here the problem was many of them are mimics. So if it is not going to be organ threatening or life threatening, we can always wait, make sure it is really an autoimmune disease, then start the immunosuppression. Other times we might end up harming the patient. The third case was about a 40-year-old male who had a subglottic stenosis, large vessel vasculitis, episcleritis. Initially when I saw the case, I thought with subglottic stenosis, episcleritis, as I was talking, first thing came was ANCA vasculitis like GPA. So here there are two things. One was Erdheim-Chesters, another was Rosset-Hoffmann. I think panelists explained about it. Generally, Rosset-Hoffmann is more of a lymph, the prominent manifestation will be lymph nodes. And Erdheim-Chesters always look for other associated manifestations like central nervous system, prominent any bony lesions are there, any cardiovascular system is there, involvement is there. But at the end of the day, histopathological with immunohistochemistry is going to give us the clue. Again here, relying on IgG4 was not an ideal. That was another learning thing from this particular case. Then I also felt like in future GPA, IgG4, these all actually could be a spectrum. Need not be a single disease. Maybe in future we have to see how it goes or how we classify these diseases. The last was a young female with hypertension, renal artery stenosis. So normal inflammatory markers is not definite to tell that it is against vasculitis, but we have to be careful at the same time that also look for the involvement of the other arterial. Isolated renal artery, though we can tell it's common in Asians or Indians, if there is evidence of involvement in other places, then we are a little bit more confident in diagnosing the large vessel vasculitis. Otherwise, if it is isolated renal artery, please do consider the differential diagnosis as discussed. And most important thing, I think, take home message for all of us is good physical examination. Many times in BCOP, we may not be able to do a complete physical examination, and if it's a female, at least ask any one of your assistants or associate to do, or that is the most important thing. And again here, like how we discuss, we have to discuss with the pathologist. For radiology, we have to discuss with the radiologist, because unless they know the clinical picture, they won't be able to give us a proper diagnosis. So these are the take-home messages from these 4 cases. Thank you.
Thank you, Dr. Sham. I think in a nutshell, today's session puts us into 3 clear-cut things. Your clinical examination matters. When you hit a wall, think of other ghosts around you. It could be infection, it could be malignancy, or it could be something else. And actually down the lane, as we are understanding immunology and molecular biology much more better, probably some of the approach to the spectra of diseases that what we are managing with a single syndromic diagnosis to a single diagnosis to a way through diagnosis approach that should really going to change the way we are going to treat. That's what we are expecting in next few decades to come with. I think with that, I have one more duty to do as a chairman to announce the winner of this. I think I congratulate Dr. Meghana for winning this oral presentation. And with that, I conclude today's session, thanking both my colleagues, Dr. Arun Hegde, Dr. Pooja Dhawan, and Dr. Cham for being attentive throughout and presenting wrapping up the whole session. Thank you very much.
gives me pleasure in announcing the winner of the vasculitis session, Dr. Sarthak Verma.
Now there is a tea break. For faculty, it is this side, and for delegates, it is this side.
As we are running out of time, I would like to start the next session. Both the chairpersons are here. Now the next session post tea break is the rapid fire session. These are ultra short cases. 3 minutes presentation, 1 or 2 minutes. Just asking only one question. Usually the speakers will have 1 or 2 questions at the end of the presentation. The moderators will answer those questions. There are no delegate or audience questions posed to the speakers or the moderators. So we have 14 cases. Without wasting time, we will start. Now, may I invite moderators Dr. Subramanian Shanmuganandan, Dr. K. Shanmuganandan, under Dr. C. Balaji. Thank you. Over to you. I request all the presenters to sit in the front row so to save the time. As you know, one is presenting, the next one should be ready standing here. Please sit in the front rows.
Good morning, everyone. I'll be presenting fibrosis for interstitial lung disease signals are unusual in multisystem inflammatory disorder. So the story goes like this. Our patient is a 59-year-old man, veterinary hospital worker. His illness began in the year September 2022 with the progressive dyspnea, dry cough, and bilateral lower limb swelling, which progressed over November 2023. And he was evaluated elsewhere, and his HRCT showed fibrotic interstitial lung disease with 2D echo showing minimal pericardial effusion. He was treated symptomatically with diuretics and antifibrotics, including pirfenidone. Over the June 2024, he had worsening of dyspnea, and in July 2025, he presented to our hospital at NH with volume overloaded state and weight loss of around 10 kgs. On arrival, his saturation was 84% and he was tachypneic. And on examination, he had elevated JVP with bilateral pedal edema. Systemic examination, he had bilateral basal crepitations, and he did not have any connective tissue disease features. On comprehensive autoimmune workup, his ANA anchor profile, ACE levels, and myocytes profile were negative. And further going to the imaging studies, he had HRCT showed subpleural and peribronchial interstitial thickening and bilateral pleural effusion. And the differential consider was CTD associated ILD, IgG4 related disease. However, his IgG4 levels were normal, and sarcoidosis, which was very unlikely because of pericardial effusion and bilateral pleural effusion. In view of progressive weight loss of around 10 kgs, we went ahead with the PET scan. We showed FTG uptake in subpleural and interseptal bilateral lungs, and also a right atrioventricular groove hypodense lesion, and with uptake around the soft tissue of aorta, which showed a coated aorta appearance. Considering this, we made a provisional diagnosis of Erdheim-Chester disease. We went back to the CT report and checked for the sclerotic lesions, which revealed multiple foci of sclerosis in vertebral bodies and sternum. And the histopathology of the lung biopsy showed interstitial fibrosis with anthecotic pigment-laden macrophages and lymphoid follicle. And core biopsy from the sternum showed sheets of foamy histiocytosis, and immunohistochemistry showed CD68 positive, CD163 positive with S100 negative, clinching the diagnosis of Erdheim-Chester disease. His BRAF V600E mutation was negative. Patient was treated with injection pegylated interferon alpha 2A, 135 micrograms once weekly, and he was initiated on TAP prednisone 50 mg per day, which was gradually tapered. At 3 months follow-up, his saturation improved to 96% on room air, and his weight also improved to 42 kg from 36 kgs. Key learning points are Erdheim-Chester disease should be suspected in interstitial lung disease like imaging with pleural effusion, coated aorta, right AV grooves pseudotumor, and sclerotic bone lesions. The diagnosis rests on CD68 positivity and CD163 positivity with CD1A and S100 negative foamy histiocytes. Coming to the management, 60% of BRAF V600E negative positive, and in such cases, BRAF inhibitors can be used. And in BRAF negative cases, may respond to pegylated interferon alpha. Questions to the?
Yeah. Since in the previous session we have had a detailed discussion ad nauseum, I will be skipping due to the want of time, but it's an excellently presented case and well discussed. Thank you.
Good morning, everyone. My name is Maurya Devang Patel, and I am an MBBS intern from NHL Municipal Medical College, Ahmedabad. And I'll be presenting a case of bilateral breast abscesses in a 37-year-old woman. So she presented to the OPD with soft to firm lumps on both breasts, with discharge from previously operated scar marks without fever or pain at presentation, and a total duration of illness of approximately 6 months of recurrent breast abscesses. And she also had discharge from the ears, which was evaluated to be chronic otitis media with bilateral tympanic membrane perforations. And she had gone multiple surgical interventions, 3 incisions and drainage in the left breast and 1 in the right breast for suspected infectious abscesses. And despite these repeated interventions, she continued to develop new lesions with discharge from the surgical scar sites. And she had stopped breastfeeding 2 years before the presentation, ruling out infectious Staph aureus etiology. So a core needle biopsy was done from the left breast, which showed granulomas, non-caseating granulomas, which was suggestive of cystic neutrophilic granulomatous mastitis. And the cultures were negative, there was no organisms on histology. And because of the bilateral tympanic membrane perforation, we suspected ANCA-associated vasculitis, but PR3 ANCA and MPO ANCA were negative. And there was no hinting of malignancy. And with non-caseating granulomas in the neutrophilic infiltrate, it was diagnosed as idiopathic granulomatous mastitis. But the real challenge we faced was in the management, where we began, as per the literature, we began with oral prednisone, 30 mg OD, but she developed new abscesses within a month, and so we added injectable methotrexate 15 mg subcutaneous weekly with the tapering of steroid, but again she had purulent discharge and pain and new abscesses despite the addition of methotrexate, and we added MMF and another retapered round of 40 mg steroids, but again we saw purulent discharge. We increased the dose and yet again the same results after a month. After which we added injectable adalimumab 40 mg subcutaneous 2 weekly, to which we saw a resolution of symptoms. She continued to be on adalimumab for another year, after which the patient complained of a high cost, so we switched to JAK inhibitors. And upracitinib was begun, which led to a resolution of the symptoms, and she's now doing well. So the teaching points are that an early biopsy is crucial to prevent iatrogenic harm through surgery, because it can increase septations and cause formation of sinuses, which can delay healing and also not provide the result. The pathogenesis is suspected to be that milk stasis after a period of pregnancy can lead to an extravasation of the ductal secretions into the tissue, which causes a local granulomatous reaction. And there is a peripheral cytotoxic T lymphocytes and NK cells increase that signifies systemic autoimmunity. The question to the panel is that which clinical and lab findings define refractory disease requiring biologics, and what is the rationale for dose escalation versus a drug change?
Very well presented. This granulomatous mastitis, the clinical pointers which define refractory is usually the bilateral symmetrical cases which have a pathology-like phenomena, where once the surgery is done, they worsen and require also having sinus tract ulcers, extra-mammary features like hidradenitis, erythema nodosum. If there are some extra-mammary features, these are all pointers which say that biologics could work upfront. And anti-TNF works well in these cases, especially adalimumab has got the highest evidence.
Thank you, sir. Thank you.
Move on to the next case.
So good morning everyone, myself Dr. Danveer, Additional Professor Rheumatology in AIIMS, and I am going to present a case, rare case of isolated idiopathic CD4 lymphopenia where we have explored this fresh plasma. So to begin with, to define the ICL, it is defined as a persistent low CD4 below 300 at 2.6 weeks apart. So that is the definition, and it is because of the low IL-2 level in the plasma. This was a 64-year-old female from the Kolkata, known case of RA, that she was not on any DMARD or immunosuppressive therapy. She was hypertensive on amlodipine, hypothyroidism was there for 6 years. Presented with 2 episodes of pyogenic meningitis in May and June. 2 quick succession of meningitis was there. CSF biofire panel was for the meningitis, encephalitis was negative. Her CSF counts were high. Protein was high and that ADA was normal, so she was diagnosed as a pyogenic meningitis. Both the episodes were managed with meropenem, vancomycin, and dexamethasone at the local Kolkata by physician, and evaluated for primary and secondary deficiency, immunodeficiency, where they found that IgG levels were normal. There was persistently low CD4 count, and she was referred to AIMS for the further evaluation as a immunodeficiency syndrome. So we have done that. HIV was done earlier, but as TLV 1 and 2 was done at the AIMS. That was negative. Family history for any was unremarkable. Whole exome sequencing was normal in this patient. So she was initiated prophylactic cotrimoxazole, doxycycline, and fluconazole. And then we hypothesized that this CD4 count can be stimulated by giving IL-2, which is not available in India. So it is what is the alternative source? We thought that fresh plasma, not the frozen plasma. If fresh plasma can be given in these patients from the donor within the time span of 2 or 3 hours, it can be the alternative source of IL-2. So what we have done, we had transfused 2 units of fresh plasma on 11th of July and then repeated on the 1st of August, and we found that after 50 days of this plasma therapy, the patient had normalization of CD4 level, and that was the normalization of the ratio also, CD4-CD8 ratio. So the discussion part remains that there are trials of IL-2 in patients. There are case reports. The half-life of plasma is IL-2 plasma half-life is just half an hour, and the extended is 80 minutes. IL-7, the trial is already terminated because the company got bankrupt. So what can be in the patients, we can think about it. And then interferon gamma, all these has been tried in the form of stimulating the CD4 level, because CD4 can be stimulated by IL-2, IL-7, interferon. So what is the milieu which is present in the fresh plasma can be given as a alternative source of all these three. So plasma normal healthy contain all the milieu of these cytokines that can stimulate the CD4, and we know that ICL pathophysiology is unknown, so we do not know what is the other pathophysiology which is present in the plasma of the normal healthy person can also stimulate the CD4 level. So that is what in this patient has happened, and we have successfully treated the patient. We were able to stop the therapy, the prophylactic therapy also, and she is normal. So a thing is that IL-2 is propagated by itself. This stimulated CD4 count leads to the secretion of IL-2, and this leads to the propagating of the CD4. So probably she will remain normal throughout her life once there is normalization of CD4. That is so my job was to light the fire in your belly so that you keep on exploring the thing. And we just note to that rediscover, it is discovery from the India should be there. That is what my my objective was there. Thank you so much.
Thank you, sir, for off the grain going against the grain therapy. Though the half-life per peptide is less, there are certain pegylated interferon. But the thing is, we need to be having more data. But it's a good to start. Thank you, sir.
Thank you, sir.
Good morning. I thank the organizers and my teachers for this opportunity. My case is a mysterious case of hip pain. So this was a 60-year-old gentleman who presented with 6-week history of productive cough, no hemoptysis, no fever, and significant constitutional symptoms, had presented to the pulmonology department, and based on clinical radiological features, he was diagnosed as pulmonary tuberculosis. His sputum for AFB as well as Sibinat was negative, no HRCT was done, and he was started on 4-drug ATT. 2 weeks later, he presented with a debilitating right hip pain, which was affecting his quality of life as well as his mobility, along with arthralgias of bilateral knee, bilateral ankle, no early morning stiffness, no swelling, but he had nocturnal pain in the hip as well as rest pain affecting activities. Investigated outside, found to have very high titer autoantibodies, rheumatoid factor, and ACCP. He was started on hydroxychloroquine, NSAIDs with low-dose steroid with not much relief, and he was then referred to our department. On clinical examination, even when the patient walked into the OPD, he was quite debilitated and was wincing with the right hip pain. On examination, he had right ASIS tenderness with a positive Febers, but no SI joint tenderness, no localized lumbar tenderness, no gibbous, and he was afebrile. While there was tenderness in the joint line of the knee and ankle, there was no swelling. So the differential diagnosis at this point was quite varied. It could be Ponson's arthritis. There is a spatial relation here. There was a diagnosis of tuberculosis. It was lower limb predominant. It was large joint. It was asymmetrical. Was this TB sacroiliitis because there were rest pain, there was nocturnal pain, there was a history of tuberculosis? Could this be seropositive RA? But then hip joint as a presenting feature, late onset RA, is seen in only 0.3% of cases, and the alarm signs couldn't be explained by seropositive RA. Was this spondyloarthritis? But he did not respond to NSID. The age was against the diagnosis. Was this ATT-induced gout? But again, hip is a very deep joint. Temperatures are not as low. So again, it's a very odd feature to be presenting as debilitating hip pain. So we went ahead with further imaging. Investigations revealed normal counts, raised inflammatory markers, normal alkaline phosphatase, uric acid was normal, and HLA-B27 by PCR was negative. We went ahead with an MRI pelvis sheath that showed an expansile lytic lesion of the right iliac bone, acetabulum, as well as a superior ischopubic rami. We then proceeded with the PET-CT as the patient also had concomitant cough and weight loss, and there was a FDG avid lingular mass as well as metastatic deposits in the bone. We then gave an oncology referral, proceeded with histopathology, which confirmed adenocarcinoma. So our final diagnosis was lung adenocarcinoma with skeletal mets mimicking an inflammatory arthritis. He's now on oncology follow-up with chemotherapy. My learning points were that rheumatoid factor is not always positive only in rheumatoid arthritis. You have to look beyond rheumatoid arthritis. As we've discussed in many forums today, rule out infection, rule out malignancy when you have high titer autoantibodies, and the clinical features are not typical of an arthritis. In a patient with suspected cancer, you can have alkaline phosphatase normal if it's a lytic mets. And most important, in the evolving paradigm of infection disease management, look for microbiological or histopathological confirmation and don't just believe a diagnosis that has been given to you. Thank you. This is my question for the panelists.
This case again reinforces the fact that we have to always interpret high titer antibodies in the clinical scenario, that especially asymmetric joint involvement, atypical joints like hip joint, axial skeleton involvement with RF anti-CCP positivity, these are red flags, clinical red flags. Also, very importantly, some of them have bone pain. Pathological fractures. So these are other associated features which could point towards malignancy. And imaging red flags will be development of lytic lesions and sclerotic lesions. So they point us towards some neoplastic pathology here. So
thank you.
Good morning, everyone. I am Rizwana, a DM resident from JIPMA. I will be presenting a case of PR3 positive erosive RA who presented with AION, gangrene, and neuropathy. So aerovasculitis versus ANCA vasculitis overlap. We have a 60-year-old female with no prior comorbidities who presented with 8 years of inflammatory symmetric polyarthritis, who was previously on steroids and HCQ. In July 2025, she was admitted elsewhere with cystitis where steroids were stopped. In August 2025, she presented with sudden painless right eye vision loss, which was diagnosed as AION elsewhere. In October 2025, she presented to JIPMA with 1 month history of burning dysesthesias, painful discoloration, and gangrene of toes and feet and of left hand, and left eye episcleritis. On examination, her vitals were stable. Her ocular examination revealed a visual acuity of 6/9 on the left eye and no perception of light on the right eye. Grade 3 RFID on the right eye, left eye episcleritis, and fundus examination revealing resolving pallid disc edema, as we can see in the picture. Her musculoskeletal examination showed no active joints, but restricted wrist extension was there bilaterally. Also, there was digital gangrene in all toes and left third finger. There was bilateral absent angle reflexes without any sensory or motor deficits. Her gynecological examination revealed uterovaginal prolapse with cystocele. On evaluation, her baseline CBC was normal, ESR was 20, urea creat was normal. Cultures, all blood and urine cultures were sterile. Urine PCR was 0.3, HbA1c was 5.1, and lipid profile was normal. Her immunological examination revealed an HSCRP of 51 mg per liter, RF is 64 with upper limit being 9, anti-CCP was negative, ANA was negative, ANCA by immunofluorescence was C-ANCA2 positive, PR3 ANCA was 31 and MPO was negative, antiphospholipids, cryoglobulins and complements were negative. This was the X-ray which showed ulnar styloid resorption and marginal erosions. Also, her OCT showed RNFL atrophy. NCS revealed symmetrical sensory-motor primary axonal polyneuropathy in both upper and lower limbs. CT angiography in lower limbs were normal. CSCT thorax abdomen was normal. X-ray paranasal sinuses were normal. MRI brain, which was done to rule out embolic or demyelinating disease, was normal. PET-CT also did not reveal malignancy or large vessel uptake. Nerve biopsy showed chronic axonopathic changes. So we have an elderly female with 8 years of symmetric inflammatory deforming seropositive arthritis who presented with right eye AION, left eye episcleritis, digital gangrene and peripheral axonal neuropathy. Her RF is positive with more than thrice the upper limit of normal, and there were erosions in X-ray which was favoring more of RA vasculitis. Also she had PR3 positivity, though they were low titer, without any renal, ENT or lung involvement which was suggestive of ANCA vasculitis. So we have provisionally made a diagnosis of rheumatoid vasculitis with possible ANCA vasculitis overlap. We managed her with IV antibiotics for UTI, IV pulse steroids with rituximab induction. There were no further vision loss and progression of gangrene arrested. So my learning points are PR3 ANCA without renal, ENT or lung disease may indicate rheumatoid vasculitis with either an incidental ANCA positivity or ANCA vasculitis overlap. So biopsy and serial organ surveillance is required. AION with digital ischemia with patent arteries points to smaller medium vessel vasculitis and it mandates early steroids. So my question is, for ocular achial ischemia, when is cyclophosphamide preferred over rituximab? And how often should we monitor for late ANCA vasculitis signs?
Thank you. Excellent case. It depends on which organ involvement is there, which easily accessible for biopsy. But my point is, and my grouse is saying, one swallow does not make a spring cometh. Means that, which is more common, elderly, long-standing, only on HCQ steroids, the diagnosis is open and shut, as you had correctly said, rheumatoid vasculitis, and to invoke AAV is little offbeat. Thank you.
Thank you.
Good morning everyone, I am Dr. Madhuri. So I will be presenting a case of a patient in whom fever suppressed the consciousness and collapsed the cell counts. So this is the story of a young lady with lupus who was diagnosed way back in 2011, where she had initially minor organ manifestations in the form of mucocutaneous musculoskeletal and autoimmune hemolytic anemia. In 2018, as a complication of being given a live zoster vaccine elsewhere, she developed Rasmussen's encephalitis, and since then she had been on multiple anti-epileptic agents. For the maintenance of her lupus, which was primarily a refractory autoimmune hemolytic anemia, she was being given mycophenolate, methotrexate, prednisolone at varying doses, and rituximab occasionally with intermittent dosing of IVIG also. The last dose of rituximab was in Jan-Feb of 2025, and she had presented to us in April, first with a fever and pneumonia, at which point her hemoglobin was 10. Evaluation for infection did not yield any organism, and she was discharged on a double dose of her baseline prednisolone dosage. In 2 weeks or within 1 week of her discharge, she came back again with persisting fever and drowsiness. In this admission, she developed sudden onset breathlessness and drowsiness. She developed severe refractory anemia in which her hemoglobin dropped to as low as 4. There was frank hemolysis and a lot of transfusion challenge in which we had to transfuse her with the least incompatible RBCs. She then developed a sudden or very rapid neurological collapse over 48 hours of her admission, and because of a very poor GCS to protect her airway, she required intubation on day 4, and in this time she continued to have high-grade fever in spite of giving antibiotics and even antifungals. So here we had a differential diagnosis of whether it was an infectious meningoencephalitis, whether it was lupus encephalitis, metabolic encephalopathy, was it a worsening of a pre-existing Rasmussen's encephalopathy, or we brought in the criteria, we saw that she met the criteria for MAS, macrophage activation syndrome, and the neurological dysfunction could be attributed to that. So she was meeting all the macrophage activation syndrome criteria as I have detailed, and the initial blood cultures were sterile. Coming to the therapy, initially we started her on pulse immunosuppression, we started her on Solumetrol, high doses, and simultaneously IVIG as she had had a recent hospital discharge. A possibility of nosocomial infection was kept in mind. There was partial or limited response. She continued to have fever, continued to require transfusions. So at this point, considering a very severe neurological involvement, we started her on anakinra, which is an IL-1 receptor antagonist. And we started it at 100 mg IV twice daily doses, and within 48 hours, her fever subsided and her cytopenias improved. We monitored her using the HED score, which is one of the monitoring tools for macrophage activation syndrome. And for the HED score, that number above 160 out of a total of 337 gives a very high possibility of mass. This lady started with a score of 302, and after the therapy was initiated, she was transitioned onto ruxolitinib, which is a JAK inhibitor. She improved well, and she was weaned off ventilator and decannulated. She had a very long duration of hospital stay, but went home ambulatory and comfortable. So this lady, we would like to emphasize that we have to consider not just blanket immunosuppression, but go for targeted, precise cytokine-based treatment, which I think was the turning point for this case. And questions which are open for discussion: did she have a smoldering mass? When will we start considering these newer agents in the treatment of mass, and the duration of therapy for mass?
IL-1 is definitely the central cytokine for mass, and it amplifies all the major mass activity, be it hyperferritinemia, counts, and the fever. So in a setting of SLE mass, with patient worsening despite steroid and IVIG, in the also you've mentioned about infection. So I think IL-1 is definitely justified here. But my only doubt here was in the maintenance therapy of chosen ruxolitinib, did you consider cyclosporin?
So here the concern was her neurological status. She's already on multiple anti-epileptics because of the Rasmussen's encephalitis. Other thing is cyclosporin has more role as a steroid sparing agent rather than immediate this one. So we gave her 1 week of anakinra and immediately moved over to Jakavi or ruxolitinib.
The role of ruxolitinib is more like a bridge therapy now as a steroid sparing.
Yes.
So good morning everyone. I am Dr. Abhishek, resident rheumatology at AIIMS Rishikesh. So my title is A Storm of Complications, What Lies Beneath. So I will try to justify the title as the story unfolds. So here is a here's a young female who was present with disease duration of 2 years, who presented to us in July 2024 with clinical signs and serology which favored a diagnosis of systemic lupus erythematosus with a high disease activity score. She had lupus nephritis class 3+5, and during this stage she received PRBC transfusion, and she was started on induction with methylprednisolone and cyclophosphamide. First dose was given, and with improvement in clinical signs she was discharged on 60 mg prednisolone and HCQ. So, but within 20 days she presented to us again with complaints of influenza-like illness followed by shortness of breath, and with her clinical examination and radiology favored a diagnosis of community-acquired pneumonia, and also her COVID-19 RT-PCR was positive. So we had reduced her prednisolone dose to 10 mg, and we started her on antibiotics, with which her oxygen requirement decreased, and she improved in another 2-3 days. And then she was fine for 2-3 days, and then again she developed recurrence of fever with oral ulcers, with hemorrhagic cresting and lip swelling, and worsening cytopenias with bleeding diathesis in the form of epistaxis. So this time again we had sent all the investigations, and we had considered the differentials of sepsis, multi-system inflammatory syndrome, and a macrophage activation syndrome. And we restarted her on broad spectrum antibiotics. By the time we had a blood culture and urine culture which was sterile, and her HLH workup was favoring a diagnosis of mass, and her CMV PCR and EBV PCR also was sent initially. But as she had refractory cytopenias and fever despite 48 hours of antibiotic, we have started her on dexamethasone as per HLH protocol. And in the meantime, we got a CMV PCR report which was 2000 copies per ml, and EBV PCR was negative. So at this point of time, we had a dilemma that this patient was already on very high dose immunosuppression, and we had to decide on whether to treat or not to treat this CMV, and how much of this mass could be attributed to CMV. But we decided and went ahead with treatment with IV ganciclovir, and so the patient count showed improving trend, and she was fine for another 1 week. But then she started having a new complaints, which is new onset pain abdomen, which was intermittent initially and improving with PPIs, but later it progressed to severe intensity with bilious vomiting, and she had symptoms of subacute intestinal obstruction. We had ruled out pancreatitis. Ultrasound showed a dilated bowel loops and free fluid in the abdomen with a splenomegaly, mild splenomegaly. and a CT was done which showed diffuse fat standing along with multifocal ileal and jejunal strictures, which the radiologist opined as lupus enteritis. So again, we were not sure what it is, whether it is because of lupus, whether it is because of CMV, though it is rare to have a small bowel involvement. But anyways, we have continued on the patient on oral Valgan cyclovir once she was able to tolerate orally, and we had given cyclophosphamide second dose. Patient again came back after 1 week with episode of severe pain abdomen, and then she was admitted in pediatric surgery, but they have decided on themselves to do a CMV PCR and it was negative. Then they started the patient on empirical ATT and discharged the patient. Patient came to us again for next dose of cyclophosphamide in her due time. This time she was completely asymptomatic, no symptoms of abdominal obstruction and no active SLE symptoms. So we had decided to continue the ATT and continue with the treatment for lupus nephritis. So as of March 2025, patient completed ATT and induction for lupus nephritis and achieved a complete renal response, and she did not have any further episodes of subacute intestinal obstruction. So my questions mainly for the panelists is, should CEMV and EBV serology be sought in all autoimmune rheumatic disease patients with HLH or MAS, and when to treat CMV infection in patient with CMV viremia and possible end organ manifestation when we do not have a tissue diagnosis? And if we ignore this CMV viral load copy, what is the risk of them developing a CMV disease with continued immunosuppression?
Yeah, thank you. It's a stormy case, but my thing would be keep explanations very simple. Stick on to HLE, SLE and MAS, and it was SLE features only which was causing the small bowel symptoms. CMV at 2000 copies we need not treat. It can be just a reactivation of a dormant virus. And the thing is, always have a microbiological diagnosis for tuberculosis. Empirical ATT is out. So if you keep things simple, then the complications clarity also is there. Thank you.
Good morning, everyone. Myself, Anamika Patel, Junior Resident, Department of General Medicine, AIIMS Bhopal. I am going to present the case of lupus encephalopathy masquerading as progressive multifocal leukoencephalopathy, a diagnostic challenge. So we had a 24-year-old female with a known case of SLE and hypothyroidism since last 6 to 7 years. Started on hydroxychloroquine, methotrexate and prednisolone, but she stopped her treatment in 2020-2021 because she was symptomatically better. Later to relapse in 2022 with arthralgia, alopecia and fatigue, so she resumed her treatment. Now presented with complaint of headache and multiple episodes of GTCS for past 4 months with no cognitive impairment. On examination, BP was raised and presentation BP was raised at presentation with photosensitive malar rash, sparing nasolabial fold. Recent MRI brain available was suggestive of multiple asymmetric T2 and flare hyperintensities in parieto-occipital and frontal lobes with subcortical U fiber involvement with a tiny intrinsic nodular enhancement and mild obstructive hydrocephalus. Likely progressive multifocal leukoencephalopathy. However, chronic presentation with no history of rituximab or any biologicals and non-progressive illness over past 4 months was atypical for progressive multifocal leukoencephalopathy, and neuropsychiatric SLE was an important differential. Investigation showed mild bicytopenia, so raised CRP, mild transaminitis and low albumin. CSF was suggestive of mild low glucose and low protein, mildly elevated protein with negative infective workup and negative CSF JC virus PCR. Her autoimmune workup showed positive ANA with nuclear homogeneous pattern, positive nucleosome and histone antibodies, and negative for Smith RNP antibodies, raised UACR and anti-TS DNA titers, low C3 complements, and negative for anti-cardiolipin antibodies. Anti-TPO were within normal limit. However, repeat MRI brain was done, which was suggestive of abnormal T2 and flare hyperintense signal in the bilateral centrum semiluminal and subcortical and deep white matter defined matter of bilateral frontal and parietal lobes in right more than left. Few areas of posterior parietal region showed U fiber involvement. Again, and however, there was a decrease in size of the lesion, all suggestive of progressive multifocal leukoencephalopathy. Renal biopsy was done in a view of raised BP and low complement high titer of anti-DHDNA, suggestive of membranous glomerulonephritis with a full house effect. Treatment in the background of no significant immunosuppression, raised USCR, elevated anti-DHDNA titers and low complements, cytopenias all favored high disease activity with lupus flare more likely than the PML. So she was started on high dose pulse steroid with injection cyclophosphamide, and after 3 doses of cyclophosphamide at monthly interval, she is now asymptomatic and seizure free. Follow-up investigation showed decreasing UACR levels and decreasing anti-DHDNA titers. And follow-up MRI was done at 3-month interval, showed a few tiny round blooming foci in cortical, subcortical location in bilateral parietal region with phase correlation corresponding to chronic microhemorrhages. Few asymmetric small discrete T2 and flare hyperintensities in predominantly bilateral centrum cevium oval and deep 5 meter white matter region of superior parietal lobules. However, there was no definitive involvement of subcortical U fibers. All these changes was likely secondary to small vessel disease, primarily due to previous vasculitis in intestine. So our differential diagnosis were SLE flare with CNS lupus and PML. Points in favor of SLE flare was high disease activity with lupus nephritis supportive, and points against for radiological feature were not typical of CNS lupus. However, PML radiological features were highly in favor of PML, but non-progressive chronic cognitive decline, no history of biologicals or rituximab, chronic presentation, negative JC virus PCR, all favored diagnosis of neuropsychiatric lupus. So key learning points here are PML like CNS white matter changes may be a rare presentation of CNS lupus. Rarely PML can present in lupus without rituximab therapy. Reason being SLE predisposes to PML through both immunosuppressive therapy as well as disease-related immune dysregulation. So early and accurate distinction is critical for timely therapy, and timely targeted therapy significantly alters the outcome. So my question to panelists are, what are the other differential of PML like white matter changes in SLE?
Thank you, doctor. The differentials for the white matter changes in lupus, two already you have enumerated, one being the CNS lupus and the PML. In your case, strongly the case looks like a CNS lupus and doesn't look like a PML, though the radiological features are suggestive of PML here. The other differential that you can think of here is PRESS, but you need a typical history and evolution. And another important differential which can be considered here is infections. So varicella, CMV, these are also, they can also cause leukoencephalopathies, which need to be kept in mind as far as the differentials are concerned.
Yes.
Thank you.
So good morning, dear seniors and colleagues, and thank you CRC for giving such a meaningful platform to present and discuss the case. I'll be presenting a case, what Chandrasekhar sir correctly pointed out, infection and rheumatic disease, if they are together, they are troublesome sometimes. So this is a story of a young male from September 24 to February 25, which till that time I have a follow-up, so I have kept up to that. It started in September with polyarthritis, generalized weakness, neurological weakness with myalgia, fever, and fever was low-grade fever, evening rise and all, with anorexia, weight loss. He had also intermittent abdominal pain and vomiting, and one episode of nasal gland dyspnea, otherwise respiratory symptoms were not much. On examination, when I examined this as an inpatient reference, he had pallor and edema, and respiratory examination wise, there were crepitation, right more than left, basal area, and neurological, there was proximal more than distal weakness with MMT8 of 30/80. On his investigation, he had anemia, leukocytosis, thrombocytopenia documented once or twice, and the later report had thrombocytosis, raised CRP, raised LDH and CPK, raised ferritin. It was in range of 4,000, 5,000, and albumin globulin reversal. ANA and myositis both profile were available. ANA had borderline anti-ribopy, but NDMD5 was strongly positive. This was the CT image which showed the lesion, and on PET also it was done later on, which showed the uptake. So they went ahead with the biopsy of that lesion, CT guided, which showed caseating granuloma and which had MTB detected on gene expert assay with intermediate rifampicin resistance. This was with management with physician, ID specialist, and we were involved as a rheumatologist. So the management, he was counseled regarding the situation that now this is the double trouble we are dealing with, and he was started with IVIG, prednisolone 0.5 mg per kg. Cyclosporin was added at the discharge and ATT was started simultaneously. So on day 21 of follow-up, patient had improvement that he was able to walk without support. Fever episodes have almost gone, and pain, there was around 50% improvement. But there was one more new finding, what we were waiting for. We developed that MCP got run. The lung was not involved in the form of RP, LD and all part. We gave second cycle of IVIG, but after that patient was lost to follow-up because of the cost issue, and then he was supposed to be enrolled with the government scheme for IVIG regular, but we could not get the further follow-up for the treatment. So for us, it was more of challenging to have Mycobacterium tuberculosis and rheumatic disease together, and which was looking more of a hyperinflammatory phenotype which was going on. And infection sometimes can trigger whether that was the thing, and that's what I have kept as a question to panelists. Can tuberculosis act as an immunological trigger and masking the latent autoimmune myositis in this case? Thank you.
Yeah, it was very educative. As usual, the tuberculosis is a mimicker, and many times both coexist. Sometimes it can be incidental. So he had proceeded this one. I would have gone little slow on the IVIG, or rather started little lower dose of steroids depending upon the clinical experience, but well presented. Thank you.
Thank you, sir.
Good morning. I'm Dr. Abhishek, and I'll be presenting on behalf of Dr. Sai, who's my senior. Unfortunately, couldn't be here. This is a case of a 37-year-old lady who is symptomatic since May 2022, had dyspnea on exertion and cough with white expectoration. And as is the usual case, she was treated outside as a case of bronchial asthma with bronchodilators. 1 year later was when she presented to us with worsening dyspnea on exertion, weight loss, multiple skin ulcers which were resembling vasculitic ulcers, although at this point she had no fever or hemoptysis. Her investigations showed anemia, neutrophilic leukocytosis and thrombocytosis with elevated inflammatory markers. LFT and KFT were normal and urinalysis was normal. Imaging showed dilation of the pulmonary artery with lack of normal tapering of the pulmonary artery, with diffuse circumferential thickening involving ascending aorta, arch of aorta and descending aorta, with a right middle lobe hyperdensity which was suggestive more like an infarct rather than a consolidation, along with multiple cavitary lung nodules. So on the background of multiple cavitary lung nodules, vasculitic skin ulcers, in-hospital HB drop which suggested DH, pulmonary arteritis and a pulmonary infarct with PH, we were dealing probably with a undifferentiated variable vessel vasculitis including small, medium and large vessel involvement. Her ANA and ANCA were negative, and skin biopsy of the vasculitic lesions showed periadnixal and perivascular mixed inflammatory infiltrate. She was treated with 1 mg per kg steroids along with cyclophosphamide. She had her interim infections along with steroid-induced hyperglycemia, and she was managed with insulin. Her pH was coming down, RVSP had decreased from 64 to 45. And then later she was started on MMF maintenance, but on that she developed acute onset shortness of breath and streaky hemoptysis. CT confirmed a diffuse alveolar hemorrhage again. So she was again treated with methylprednisolone 1 gram per day followed by 1 mg per kg per day steroids and cyclophosphamide. Developed an LRTI in the interim which was managed conservatively. And then she was restarted on MMF maintenance. Her cumulative dose of 15 grams cyclophosphamide she had received. Maintenance options, we were actually considering rituximab or TNF inhibitors, but in view of recurrent infections on cyclophosphamide, we thought that maybe she would be better managed with conventional immunosuppressions like MMF, azathioprine or tacrolimus. And her CT, latest CT in March 2025 is shown a dilated aorta and a dilated pulmonary artery. So the learning points from this case are pulmonary arteritis can closely mimic chronic thromboembolism, and diagnosis will require expert clinical radiologic correlation. And cyclophosphamide, while being effective for remission induction, we need some individualized maintenance strategies for such patients. So the questions to the panelists are that what should be the optimal long-term maintenance choice in this patient? Should we consider a rituximab or a TNF inhibitor for this patient? And what is the right timing for endovascular or surgical intervention considering a massively dilated pulmonary artery?
Thank you, doctor. First, one comment I wanted to make is your choice of maintenance agent as MMF, because this patient had pulmonary capillaritis and arteritis. Initially started with cyclophosphamide, and then the maintenance agent chosen was MMF. Any reason why you had chosen MMF?
Considering the fact that she was having recurrent infections, we actually thought of rituximab or TNF inhibitor, but only just because of recurrent infections it was.
Between the choice of rituximab and TNF, rituximab more if the phenotype is more like an ANCA, TNF more if the phenotype is more like a Bechet.
Yeah.
And regarding the timing for the surgery, definitely only when the vessel inflammation is low, ESR CRP is near normal, and patient has been adequately immunosuppressed, then that is the right time to plan for the endovascular procedures.
Good afternoon, everyone. Respected chairpersons and my dear colleagues. Myself, Dr. Ashish Chandwani from Army Hospital, RNR, New Delhi. Today I am presenting a case which reminded us that adult onset disease can not only be unpredictable, but sometimes can be merciless, and decisions depends upon the survival that have been made in minutes to hours rather than days. So we had a 29-year-old female with 3 months history of quotidian fever, classical evanescent pruritic skin rash with inflammatory polyarthritis which was symmetrical, involving small joints of hands. Evaluation revealed significant leukocytosis of 22,000 with more than 80% neutrophils, CRP of 70 mg per liter, and ferritin of 7,770 with borderline raised procalcitonin. She also underwent PET-CT, which showed generalized uptake in reticuloendothelial system. Lymph node biopsy and bone marrow examination was normal. After excluding malignancies, infections, and autoimmune diseases, she was diagnosed as a case of Still's disease. She was initially evaluated and managed at a civil hospital in Nepal with methotrexate, moderate doses of oral glucocorticoids, and naproxen. Following which she had persistent symptoms, she was started on tofacitinib, despite which she continued to have symptoms. She finally presented at our center in January 2025, where she was started on IV tocilizumab 8 mg per kg, requiring 2 weekly, and continuation of steroids. Her disease never truly settled. She had a persistent refractory pruritic skin rash, which was so disabling that she could not even sleep. However, she had some improvement in arthritis and fever. She had a very high leukocyte count of 42,000. We finally escalated her immunosuppressant to baricitinib after non-response to tocilizumab in view of persistent skin symptoms. Despite which she had persistent symptoms, and what came next was quite frightening. The numbers this time were very high. It was a full-blown macrophage activation syndrome with ferritin of 88,000, TLCs of 41,000, which immediately dropped down to 3,000 within a span of few days, with very high triglycerides and significant transaminitis. We managed her with IV methylpred for 3 days with cyclosporin maximum doses as per her body weight and IVIG. She had a progressive downhill course. Despite that, she developed ARDS, myocarditis, and hemodynamic instability, and required HFNO support and ICU admission. We went ahead with HLS 2004 protocol, managed her with 3 doses of etoposide along with dexamethasone and cyclosporin. And what came next was dramatic. She became afebrile, her hemodynamic stability recovered, organ functions recovered, and ferritin dropped down from 48,000 to 2,400. So, did we finally achieve victory? The answer is no. She is still battling with symptoms of disease activity, recurrence of fever, arthritis, and skin rash. We restarted her on IV tocilizumab along with cyclosporin. So basically her fever responds to tocilizumab and her arthritis part responds to cyclosporin, but she still requires intermittent parenteral IM glucocorticoids.
So the take-home message is when the Still's disease stops behaving like a rheumatic illness and starts behaving like an hematological emergencies, HLH-based protocols can be life-saving even in adult rheumatology practice. Thank you.
Yeah, you had asked about place of JAK inhibitors. Normally, calcineurin inhibitors come first, and usually we do not use stem cell because of availability, unlike the primary HLH. But it's a good thing that you started etoposide. But we should always consider other factors like viral infections and other mimickers of autoinflammatory syndrome by possibly a exome sequence. Thank you. Well presented.
Good afternoon to everyone. I'm Mihir Pathak, Junior Resident in Medicine Department, KMC Mangalore. And today I'm presenting the case when trapped into adult onset Still's disease. So we have the case of a 30-year-old female, housewife by profession, resident of Kerala. She had no previously known comorbidities and came to our hospital with the chief complaints of fever since the past 10 days associated with chills. The fever was high grade in nature, intermittent, not relieved on medication and associated with arthralgia. She also had a sore throat since the past 10 days. There was no other associated history, no history of weight loss or loss of appetite. Patient had received treatment in a local hospital outside with NSAIDs and empirical antibiotics. There was no relief in symptoms despite treatment. On routine examination, her temperature was 102 degrees Fahrenheit, but rest vitals were within normal limits, and systemic examination did not reveal any findings. Routine investigation showed leukocytosis, neutrophilic in 88% neutrophils with elevated ESR of 53 and CRP of 151. Considering the history and the initial investigations, the clinical possibilities of infectious, autoimmune or malignant causes were put forward. On further investigations, ferritin was elevated 430 and LDH was 234, but the rest infective workup, including procalcitonin, was negative. ANA as well as rheumatoid factor was negative. On further imaging, patient had hepatomegaly, 2D echo was within normal limits, and PET CT was also done, which was showing reactive cervical lymphadenopathy, but maximum SUV of 6.23 in the sacrum. During further examination, during one of the fever spikes, patient developed rash over her forearm, as you can see in the picture. Given the presence of rash and after excluding infective as well as autoimmune causes, we gave provisional diagnosis of adult onset Still's disease, as the patient was fulfilling Yamaguchi criteria. 3 major and 4 minor criteria were present. On day 3 of the patient's admission, patient's elder daughter was concurrently admitted in the pediatric ward with a similar pattern of fever. Her investigations also revealed elevated total counts, elevated ESR, elevated CRP, and no underlying infectious or malignant cause. Because of family clustering and concurrent symptoms, the possibility of autoinflammatory disease was raised, and whole exome sequencing was done for our patient. Whole exome sequencing revealed a variant of uncertain significance in our patient in the TNF receptor superfamily. Sanger sequencing, which was done for both of her daughters, showed the same mutation in both of them. So in view of family clustering and the symptomatology, the diagnosis of tumor necrosis factor receptor associated periodic syndrome was strongly suspected. Patient was started on steroids, to which she had a good response, and they were tapered and stopped over the next 4 months. She was also started on TAP colchicine 0.5 mg BD to decrease the risk of amyloidosis. TNF inhibitor therapy has been reserved for future flares, and daughters are asymptomatic and kept on close follow-up at present. These are my references. This is my take-home message. Autoinflammatory syndrome should be considered as a differential diagnosis for pyrexia of unknown origin when infectious, autoimmune, and malignant causes are ruled out. Whole exome sequencing should be interpreted in a clinical context, especially when there is a variant of uncertain significance. And long-term monitoring for amyloidosis and renal dysfunction is needed in autoinflammatory syndromes. Thank you.
A very good case, well presented. I also liked your title a lot.
Thank you, sir.
So with this particular case, I think what is important is adult onset Still's disease, even once you make a diagnosis using the Yamaguchi criteria, I think still we have to keep our eyes open. These cases can evolve in future into any other syndrome, especially autoinflammatory syndromes because of the close mimic.
Right.
Coming to your questions, genetic testing, yes, in the first degree relatives, the siblings, parents and the kids. With regards to colchicine prophylaxis, only if there is a strong history of amyloidosis, then the colchicine prophylaxis can help. And because colchicine works different in traps and works different with FMF.
Right.
So, and biologics definitely know in carriers
Right.
unless they develop the disease.
Thank you,
Good
sir.
case.
Good afternoon to all. I'm Dr. Megha Unni, an MBBS graduate working in the Department of Rheumatology at Believers Church Medical College Hospital, Tiruvalla. Moving on, this case is of a 42-year-old gentleman with no known comorbidities who presented in 2025 with recurrent fever, anasarca including ascites and pleural effusion, generalized lymphadenopathy, hepatosplenomegaly, ichthyoid hyperpigmentation of both shins, recent dysglycemia, bicytopenia, elevated inflammatory markers, and renal dysfunction with subnephrotic proteinuria. Importantly, he had a strikingly similar episode in 2013 when he was labeled as undifferentiated connective tissue disorder with renal limited vasculitis. At the time also, he had prolonged fever, anasarca, lymphadenopathy, hepatosplenomegaly, along with peripheral neuropathy and macroproteinuria. Renal biopsy at the time showed a diffuse proliferative yet pauci-immune glomerulonephritis without ANCA positivity, and lymph node biopsy was only shown as reactive hyperplasia. So during the current admission, we reassessed the case and he was found to fulfill the criteria for primary Sjogren's syndrome. Because there was an incidental anti-Rho positivity and a confirmatory lip biopsy. Subsequently, we also ruled out infections and malignancies. Now, given the combination of lymphadenopathy, systemic inflammation, anasarca, thrombocytopenia, renal dysfunction and neuropathy, a hyper IL-6 driven disorder was suspected. So, a repeat lymph node biopsy was done, which confirmed our suspicions of an idiopathic multicentric Castleman's disease. Clinically, there was overlapping TAFRO features and partial poems-like features, although plasma cell malignancy was ruled out by an absent M-band on SPEP. So the final diagnosis was made to be IMCD with TAFRO poems overlap secondary to Sjogren's related hyper IL-6 syndrome. Here's a slide showing the diagnosis, the lymph node that confirmed the diagnosis, where we can see the perivascular hyalinization and hyalinized vascular channels. And below is a picture of the diffuse symmetric non-pruritic ichthyoid hyperpigmentation of the shins, which along with hepatosplenomegaly and dysglycemia and organomegaly, everything, confirmed a partial poems overlap. So in retrospect, Castleman's disease was missed in 2013 due to absence of classic cutaneous clues, lymph node biopsy being labeled as reactive, and limited literature on IMCD TAFRO at the time. However, a combination of pauci-immune diffuse proliferative glomerulonephritis with peripheral neuropathy should have raised suspicion of a cytokine-mediated process. IL-6 dysregulation provides a unifying mechanism which explains the lymphoproliferation, the systemic inflammation with anasarca and thrombocytopenia, as well as VEGF-driven features like poems. So in the first episode, treatment with steroids and MMF produced only a partial control, while sustained IL-6 blockade produced with tocilizumab produced a more complete and durable response, stressing on the mechanism-based therapy. Thank you. And my question to the panelists is that, given that the pauci-immune diffuse proliferative glomerulonephritis lacked necrotizing crescents and was ANCA negative, would the panel consider it to be more consistent with cytokine-mediated endotheliopathy rather than true vasculitis?
See, it's always, you become wiser retrospectively, but if you see, put it in a simple perspective, it can be just a Castleman disease occurring in a repeated manner, because all autoimmune diseases evolve in geologic time, and we can have remissions and exacerbations. Thank you.
My next presentation is the polyp that wasn't. So here we have a 45-year-old gentleman who presented with 5 to 6 month history of cutaneous manifestations in the form of photosensitive erythematous rashes that healed with hypopigmentations. They were non-pruritic. As you can see, they were on the sun-exposed areas of the body. Over the last 4 months, he developed an he developed a symmetrical progressive proximal muscle weakness of the upper limbs and the lower limbs, and 1 month history of difficulty swallowing both solids and liquids. The MMT age on examination was 45/70. He had photosensitive rashes. There was salt pepper pigmentation. However, there was no sclerodactyly, there was no microstomia, there was no history of Raynaud's, and there was no other changes that we had noted. We had done the nail fold capillaroscopy because our differentials were, was this a primary myositis or was it a scleroderma myositis spectrum? The nail fold capillaroscopy showed ramified, dilated capillaries as well as bushy capillaries. Investigation revealed normal counts, mild normocytic anemia. Inflammatory markers were, ESR was borderline elevated, SGPT was mildly elevated, CPK and LDH were also elevated, renal function tests, electrolytes were normal, ANA-IF was nuclear fine speckle, the ANA blot was negative. The myositis blot, however, had a TIF1 gamma strong positive. Because of TIF1 gamma, we went ahead with paraneoplastic screening, basic screening in the form of comprehensive history, examination was done, chest x-ray was normal. We proceeded with the PET and also with the medical gastroenterology opinion because of dysphagia. The initial PET was normal, there was not much muscle uptake, and the OGD only had a hyperplastic polyp. Our diagnosis was dermatomyositis. We had started treatment with steroids and methotrexate, and over the next 3 months there was not much improvement, and he came back to us now additionally with features of gastric outlet obstruction in the form of vomitings as well as early satiety. So at this point, we repeated an endoscopy because it was a TIF1 gamma with persisting dysphagia and weight loss. It now had a proliferative lesion 3 months down later. A CT abdomen was done that had wall thickening in the body and the antrum, raising the suspicion of a malignancy. And this time, we proceeded with a FAPI PET, which demonstrated uptake in the stomach. And we proceeded with a biopsy, which was finally suggestive of a signet ring cell carcinoma. So my learning points with this case, first is we know that few antibodies are associated with an increased risk of malignancy. We have the IMAX guidelines that are guiding us, and in these set of antibodies, basic as well as comprehensive screening should be done. The other important learning point for me was difference between an FDG PET and a FAPI PET. So FDG PET relies on glucose metabolism, and it is detected because of high glycolytic activity, which shows up as high FDG uptake. FAPI PET depends more on the microenvironment of the tumor, and it is excellent in those tumors which have cancer-associated fibroblasts and rich stromal and desmoplastic reaction, which was this case. And as GI malignancy risk in DM is 5 to 15%, in those cases where endoscopy and a conventional PET is not contributory, we should think of a FAPI PET. And most important as physicians, when you're guided by scientific evidence and gut feeling, always chase the case till you reach the diagnosis. This is my question for the panelists.
Thank you. I think a very good learning point with regards to FAPI PET. It was actually new to learn about FAPI PET. So when there is a high index of suspicion, I think definitely a thorough search for malignancy is definitely required in myositis, especially when TIF gamma is positive. The desmoplastic tumors, the stromal tumors, invasive breast cancers, many cancers can be missed by FDG PET. So other modalities, discussing with the radiologist and also gynec examination. So these all have to be kept in mind while approaching malignancy screening in patients with myositis.
Thank you.
Yeah. Thanks for all the presenter for sticking to the time, and it was a very rapid fire decision, and I close the session. And I request my co-chairman to announce the result also. It's ready. That's also rapid.
So the results for the ultra short cases. So 3 prizes. Three prizes.
Yeah, three. Top 3.
So we'll go with the third place. Third place goes to Dr. Nayanthara for the FDG versus FAPI PET. The second place goes to Dr. Mahesh for his case on ECD. First place goes to Dr. Mihir for his case on TRAPS. Thank you all.
Thank you, moderators. You completed the session on time. Congratulate the winners. Now we will move on to the next session, snippets. Now I invite Dr. A.K. Khan and Dr. Sapan Pandya. They are the panelists or the moderators for the session. This is a new, completely new session. We'll see how it will take, what kind of shape. If you all agree, we'll continue. Otherwise, next time you don't see this session. Give your inputs.
इत्तर से बदन को महकाते हो तो कौन सी बड़ी बात करते हो. इत्तर is perfume because a lot of अंग्रेजी crowd here. So इत्तर से बदन को महकाते हो तो कौन सी बड़ी बात करते हो. खुशबू तो आदमी के किरदार से आती है. And we have seen Sharat Kumar's kirdar here. And he was asking me, and I said, you always come out with something new. And when the first mail came from him, that this was the idea, I thought it was very good and very relevant, because as a part-time teacher, what I have seen in students, and many of the full-time teachers I'm sure will agree, it is all the more relevant today in the era of artificial intelligence and video online and okay, Marrow, kya class chalti ho, Marrow and all of that. Students don't attend classes. And so it is all the more relevant that what they want is not knowledge. वो तो press of button में मिल रहा है. But wisdom, and probably bedside wisdom or things like that, which some of which may be biased because we've been years, so you can take it to the pinch of salt, but that is what students actually usually want from, and so we'll have some of the wisdom shared here. Dr. Sharat has compiled quite a few cases of his own, and some of which we have sent. And so we'll try and have that in the next half an hour. Dr. A.K. Khan, please.
He called this snippets. Now, snippets, this was a very interesting, this was a very interesting, name to this session. Now, he wants to integrate the seniors from who have been practicing for the past 2 decades, 3 decades, tend to make certain observations, and from which they then go to the clinics and then they make some decisions. Now he wants to make an intergenerational integration, sort of, those snippets which the seniors have compiled or kept in mind or observed. He wants them to be passed over to the juniors, which they can sort of make things easier for them. They, as Dr. Sapan said, that they can be taken with a pinch of salt, because this is your own observation, and which needs to be passed on. Then this needs to be probably, if we have a large database, if we have more people who can get involved in this, we can do a study and then publish it. But then this is the beginning, and I'm sure this will be very interesting. Dr. Sarath, please proceed.
Thank you, Dr. Khan and Dr. Sapan.
The conflict is that we are not old, we are young. So yeah.
Accepted 100%. The rheumatology snippet session is designed for young and early career rheumatologists. Rheumatology is dynamic. Sometimes so the diseases evolve very slowly. Sometimes don't rush. Give your immune system to speak. It always does that. Bad diagnosis was than no diagnosis. When unsure, do not label. Wrong rheumatology label may stay with the patient for life. When in doubt, watch, document, and reevaluate. It's your patient, your responsibility and your accountability. No matter how busy you are, focus on each case. Start on a positive note, infuse confidence on your patient. Connect with the patient. Everyone likes their name the most. Greet them when they enter into your room with their name. Diagnosis in rheumatology is like a jigsaw puzzle. No single piece is enough. The full picture matters. Beware of the nocebo effect. Most of the patients, you start saying that when you're talking about the medication, start with, the good things about the medicine rather than the side effects first, and build the trust later on. Shared decision making is very important. That builds the confidence on you and on your treatment, and also the adherence to the medication. Sorry, my students kept this slide, not me. You must be on the driving seat. When you are managing complex rheumatology cases, you should be in the driving seat. So think of every case as driving towards a new destination, that is new diagnosis. Sit upright, wear seat belt, take the steering wheel, drive steadily. Now you are in a driving seat. Think like that. As we move forward through different case scenarios, pause, think, decide, and together we will extract the key take-home messages together. Patients with Sjogren's syndrome often keep their eyes semi-closed due to severe dry eyes and photophobia, giving the eyelids a crescent shape. So can we name this sign? Can we call it a crescent eye sign? When the eyelids peak, the Schirmer's test becomes a formality. All these patients had inflammatory arthritis. The diagnosis is written on the forehead. Repeated bindi pressure causing cauterization, sometimes the culture becomes the clinical clue. Bindi sign in psoriatic arthritis. You see, especially in this part of the world. I spoke to Dr. Khan, he said he won't see, he has never seen. 31-year-old lady, known case of lupus, pruritic hyperpigmented patches in the scalp, patchy alopecia, scaling at margins. What is the most likely diagnosis? Direct microscopy of the skin scrapings on KOH mount showed fungal hyphae, diagnosis tinea, treated with tetraconazole. 35-year-old female, inflammatory back pain for more than 1 hour, suffering more than 1 year, multiple NTCR tender points, ESR high, HLA-B27 positive, MRI SI normal. So diagnosis here most likely enthesitis predominant spondyloarthritis. So whenever we suspect enthesitis spondyloarthritis, always look for other things as a supportive evidence, like inflammatory nature of the pain, inflammatory low back pain, psoriasis, nail changes, HLA-B27, imaging changes. Then think of enthesitis rather than fibromyalgia. So in our clinic, we always do this. Of course, after ruling out, whenever we say diffuse pains with fibromyalgia, rule out severe hypovitamin deficiency and hypothyroidism, B12 deficiency, severe anemia, folic acid, viral. So these are the mimickers. After ruling out, we check the tender points. Here we follow this figure. 29 tender points is a combination of lead synthesizing index, SPARC and MACES all together 29. If the score is more, then we confirm it to the high resolution ultrasound. Then after confirmation, we start the medication. 9 out of 10 patients do get better. So I have 272 patients in the last 5 years, enthesitis, predominant spondyloarthritis. Earlier, they were diagnosed either as of diffuse body pains, non-specific body pains or fibromyalgia-like presentation. Young patient with white thread pain, initial tenderness, but normal inflammatory markers, HLA-B27 negative, normal imaging. What is the next step? Assess the patient for hypermobile joints. Very common, maybe sometimes we miss out in a busy clinic. So this is another reason, they may present diffuse pains. The reason here is the mechanism is excess tensile force transferred to the enthesis. This leads to chronic traction enthesopathy presenting as diffuse body pains. Another mimicker. Male 45, monoarthritis of the right knee following a blunt trauma, CRP elevated, Broca normal, cultures negative, has scalp psoriasis in the past. What is the most likely mechanism here? Yeah. In patients with psoriasis who develops arthritis following a deep trauma, consider deep corpus phenomena as a trigger for arthritis. Female 52, known case of RA, underwent right TKR, 2 months later presented with synovitis in the same knee, ESR high, WBC Broca normal. What is the most likely cause? In rheumatoid arthritis, inflamed prosthetic joint with normal inflammatory markers should prompt consideration of RA flare before diagnosing infection. Female 35 referred to you for possible autoimmune disease, no CTD symptoms. Routine labs were normal, rheumatoid factor, weekly positive ANA 1:80 speckled. What is the most appropriate management? Reassured, no organ involvement, no autoimmune disease. Anchor your decision on organ, but not on isolated antibodies. In some rheumatology clinics, they have a solo practice. When they suspect lupus, they may ask ANA profile because lack of availability of immunofluorescence microscope in their setting. So is it the right way of doing? What is the evidence we have here? ANIF. So if you ask for ANA profile, the sensitivity of detecting lupus is only 43% max. So you miss out around 57%. Whereas if you ask ANIF, the sensitivity is nearly 98%. So chances of missing lupus is only 1 to 2%. So in the institute, they always do this. But in the solo practice, we have been seeing that some doctors do ask for only ANA profile because of the convenience sake. So whenever you say case of rituximab induced infusion reactions, what do you do next? Do you stop? Do you switch? Do you reduce the dose or do you change pre-medication? So our protocol is, what we have been doing is increase the solipedrol from 100 to 125 milligrams IV as a first dose. If the patient had mild to moderate infusion reactions, 250 milligrams. Significant reaction increased to 500 milligrams. With this protocol, rituximab discontinuation has been rare in our cohort, limited to single digits. Don't abandon the rituximab for infusion reaction, escalate pre-medication. Some bad combos in rheumatology: azathioprine, allopurinol, we all know cytopenias, azathioprine warfarin combination, warfarin resistance, cyclosporin colchicine combination, neuromuscular toxicity, cyclosporin statin combination, myopathy toxicity, and biologics with JAKs increase the risk of infection. We all know this. Why still I present? I think some points to discuss here. High HCQ-induced pigmentation mostly we see in the South Indian community, probably related to our melanin. So is it related to the dose or due to ethnic? So I feel it is, the dose is not global, it is ethnic and disease specific. pigmentation is not cosmetic alone. It affects adherence, and early recognition prevents dropouts. Hydroxychloroquine binds melanin, accumulates in melanin tissues that causes hyperpigmentation. So what I do in my clinic, when they complain, by the time they're in revision, I change it to alternate days or even lower. And of course, always check for flares in future and closely observe them. Probably, we can come up with one study, simultaneously look for blood levels. Known case of RA on methotrexate developed this rash. What is this rash? Methotrexate can cause pellagra-like photosensitive dermatitis due to functional niacin deficiency. Treat with the niacin without stopping methotrexate. This is reversible. Your patient on methotrexate developed severe nausea and vomiting. What is the next best step you can do? We know the trick. We have 4 or 5 tricks in our hand. There is another trick we can do now. I think some people might be doing. In US, a lot of people do this using folinic acid. We use 15 milligrams 1 day prior or 1 day after methotrexate. Significantly, it reduces the nausea and vomiting. So don't abandon the drug. Your patient, lupus headache, another common problem in our clinic. So do we have any trick for lupus headaches? We use aspirin. So what evidence we have? There's one paper from Dr. Graham Hughes, 2001, Dr. Schwanfield, 2021. So when I was in England, I used to do some clinics with Dr. Graham Hughes. What he used to do is for migraine headaches in APS. Here if you see lupus, 40 to 50% have APS seropositivity. So for APS migraines, he used to give heparin subcutaneous BD for 2 weeks. If there is a response, change it to oral anticoagulants. So just I use the same scenarios here. Instead of using heparin, just tried heparin, it's really working well. And I would say 9 out of 10 patients do get better. And the frequency and the intensity of the headaches have come down significantly. So try using this. Male 55, otherwise well-controlled RA. So background RA is well-controlled, but patient complains of now and then migratory joint pains, that is palindromic rheumatism. So what do? Patient has both RA, well-controlled, palindromic rheumatism features, but between the attacks, patient is free, symptom-free. So just adding hydroxychloroquine will do the trick. I think most of the seniors know this. This is mainly snippets for youngsters. Don't escalate DMARDs. APS paradox. Do APS patients bleed? Yes, rarely. So these are the 7 reasons you look for in APS bleeds. Female 28, known case of lupus on hydroxychloroquine has been present with new onset leukopenia, but patient is asymptomatic. What is the most likely appropriate next step? Is it a drug flare? Is it a drug induced or a disease flare? So little trick is rather than abandoning the drug, just escalate the dose. If the patient is on 5 milligram alone, make it 10 milligrams. In few days, you see raise in WBC count. And of course, you have to look for other reasons like maybe infections or B12 deficiency. These are the mimickers. Female 48, asymmetrical polyarthritis for 2 years, tender joint, swollen joint count 11, routine labs normal, inflammatory markers normal, serology normal. What is the most appropriate next step you do? Yes. Every diagnosis of seronegative RA should trigger deliberate search for psoriatic arthritis. In my clinic, probably psoriatic is as much as rheumatoid. Yes, I agree. Female 40, present with inflammatory small joint arthritis, 8 months, EMS 45 minutes, hair fall, hypopigmented scaly plaques on the forehead, ESR 50, rheumatoid factor positive. What is the most likely diagnosis? So is it early RA because patient has polyarthritis and rheumatoid factor positivity, or psoriatic arthritis because the patient has plaque on the forehead? But when we completed the workup, it turned out to be lupus. So always perform the full workup before you label it. In which of the following diseases ethnic clustering is seen? So we have done one study with the CCMB here in Hyderabad. It got published in Genetics and Genomics journal recently. So we have identified high prevalence of spondyloarthritis in Reddy community in AP Telangana. Also similar observation in Agarwals and Jain community. So if disease keeps appearing in a particular community, think genetics and founder effect before calling it coincidence. On-demand anti-TNF in a limited resource setting, good for some spondyloarthritis patients. When you are stuck with the diagnosis, go back to the patient. Patient is the boss. Listen carefully. He may give the history next time. We all know exercise is anti-inflammatory. You stress on that. Transaminitis, don't blame the DMARDs first. Look for fatty liver, viral causes, drugs. High ESR in lupus, Sjogren's or overlaps. Don't chase ESR because it is due to hypergammaglobulinemia. In Sjogren's, LASIK is not cosmetic catastrophic, so it is contraindicated. Meibomian gland dysfunction is the commonest cause of chronic dry eyes in elderly, which mimics Schirmer's, which mimics Sjogren's. When you are stuck in reaching a diagnosis, don't hesitate to seek help from your colleagues. Always do that when I have difficulties. Potassium iodide is very useful in refractory lupus erythematosus. Refractory erythematosus, very useful, but it's not available freely in the pharmacy. Probably you have to order online. Very useful in refractory cases. Avoid polypharmacy in rheumatology. Window of opportunity to observe virally active arthritis, rheumatoid factor positive. So is it early RA? Better to observe the case. Window of opportunity to treat. Early RA, start DMARDs early to prevent erosions. Window of opportunity to prevent complications, tight control of lupus nephritis to prevent CKD. Autoimmunity 2.0, when diseases refuse to stay in boxes. Now we started seeing the new overlaps. SLE, SPA overlap. I have 25 cases in my cohort. Sjogren's SPA, PS out, psoriatic arthritis and gout, large vessel vasculitis and SPA. Autoimmunity is no longer linear. It is a spectrum where diseases blend, overlap, evolve. Recognizing these hybrid phenotypes improves the diagnosis, prediction, and precision therapy. Rheumatology consultation, not episodic, but a lifelong commitment to care. Rheumatology consultation comes with a heavy baggage because rheumatology is not episodic care. It is a lifelong stewardship of health, hopes, and human lives. Rheumatology consultation, especially lupus and related connective tissue disease, comes with a uniquely heavy responsibility. It often feels less like a consultation and more like a lifelong partnership. Once you diagnose lupus, you are, in a sense, marrying into patient's life, walking with them through every major decision they will ever make. So constantly you have to counsel them regarding how to beat the stigma, encourage them for better education, do career counseling, pre-marriage, marriage counseling, pregnancy counseling, and also tightly control the disease, check for drug compliance, and counsel them regarding how to address the stress and fatigue. Today we have lupus patients in more than 10 countries working, and most of them are NRIs because there are software engineers without being defined by their disease. It is telling that most of our lupus girls are successfully married, reflecting trust, education, shared decision making rather than by chance. Outcomes matter when the right guidance and multidisciplinary team, rheumatology patients need not be limited in achieving life's milestones. Thank you.
It is the highlight of the conference. Yes.
Actually, you've been very humble to call it snippets. It's also
So can we have...
the solo practitioners' problems.
Okay, we'll move on next.
No, it's all right. I think the time is, we don't have time, so we would want comments from anyone, especially seniors like you are Kirao sir, Narsimulu sir, so even if you don't want to listen to the youngsters, this is a platform for you. हम तुम्हें सुनवाएंगे, so सुन लीजिए. It's okay. Meanwhile, we can have, till they put up, we can have sir.
We still have some.
Take care of
My friends, we can see since a couple of years, Dr. Sharath consistently organized a clinical conference and a lupus walk and arthritis walk. And propagating such a nice way, I am proud to say he was my student and is now my colleague. And he evolved from where to where I can witness. Even Dr. Ivarkar also witnessed. He was doing MD. I am very proud of him. I am proud of him. And he is a good soldier of IRA. I don't know right or not. I appeal all of you, when he contest IRA election, kindly support him, vote him. Thank you.
Thank you. We have a few slides, maybe you can, yeah.
Just give us 5 minutes because some interesting people, even your slides are here. Okay.
Professor Rohini Handa, we have to listen to this, so please.
Good morning, everyone. These are the clinical pearls shared by Professor Rohini Handa. Now we are going to see some myths and pearls about the rheumatoid factor. So the rheumatoid factor is exclusive to rheumatoid arthritis? No. So rheumatoid factor is seen in many conditions, not just rheumatoid arthritis. It can be positive in Sjogren's and other autoimmune diseases and cryoglobulinemia also. And rheumatoid arthritis is diagnosed solely by the laboratory tests? No. It is a clinical diagnosis. Labs are just the props. So positive rheumatoid factor always means rheumatoid arthritis? No. So the rheumatoid factor and rheumatoid arthritis can exist independently and clinical correlation is mandatory. So the goal of the treatment is to make rheumatoid factor disappear? No. So the rheumatoid factor levels correlate poorly with the response. So do not chase the serology. Focus on the patient, not just the levels of the rheumatoid factor. Seronegative rheumatoid arthritis doesn't require different treatment as the seropositive rheumatoid arthritis. So both should so both the seronegative and seropositive RA should not be treated differently. Thank you.
So these are, I've called it pseudo wisdom because it's come with a conflict. So please don't take it. Some observation I made. Before labeling fibromyalgia non-inflammatory pains, ask for palindromic. I learned later in my career. I missed some of the PR patients. Young females, I called them fibromyalgic and then they were actually PR. So ask for PR. Even in clinical experience. Yeah, even in rheumatoid, ask for each joint. If you ask them pain hota hai, we had a colleague with me who used to say, मैं जो पूछूं उसका जवाब सिर्फ हाँ या ना में दो. So you have to ask individual joint. इधर होता है, इधर होता है. Then they tell you कि इधर होता है. Otherwise they don't tell you. Every eye opacity is, they always tell you that, right? There's more for MDs actually than for trainees in rheumatology because medicine people would know that. Every eye, they always say it started with a Diwali cracker and it's actually corneal opacity which was a PUK or something. Ask them in detail and not infrequently it is peripheral circuitis of RA. Similarly, the stooped uncle accompanying the boy fell down in the well but it's actually ankylosing spondylitis. You have seen that, right? They come with that uncle. He says, no, mere ko to kuch hua tha and it's actually ankh spondylitis. So, don't believe past TB. This is very common in the hospital that I go to. Everything is TB. So ask them what it was. And not infrequently it is the same thing which has happened now that was, ILD and stuff like that. Too much blinking of an eye I have seen. I can now pick up Sjogren's in those patients. No patient tells history of, I have not heard a single patient tell me that I have parotitis. You have to ask for that. Then they tell you. Purpura over low limbs, improving on lying down. We know it is hypergummal purpura, but again, misdiagnosed as HSP also by even us sometimes. Myositis patients fall down, and that's what you have to ask them again. They don't tell you. They fall down because of proximal muscle weakness. Learn to recognize very early scleroderma that you can see on the face and fingers. When the patient walks in, you can actually see that, and then ask for Raynaud's, and they'll tell you yes. You have to pick up those things very early. Next, please. You are a rheumatologist when you pick up lupus from Jacquard's. So you've seen Jacquard's enough to pick up case ka ANA karwao, otherwise it looks like RA. And can make out a prosthetic joint when moving the knee and avian when rotating the hip. If you have not done that, you have not seen enough patients, remember. You have to see them lying down. You'll be able to pick these up clinically. Most of panniculitis has been called cellulitis. So don't believe diagnosis that people write, ultrasound and stuff. It is actually panniculitis. There is no history that is not given. There is only history that is not taken. We have to have the patience to sit with the patient, to ask them. We are also culprits. We don't do that, but you have to have that patience. The art of medicine is digging out history when it was not there, and quickly in our country, and rheumatologists, I think, are the best there. I don't have any doubts. So I think that's, any other slides we have? Yes.
10 commandments to practice in the rheumatology sent by Dr. Shamsar from Chennai. First one, the diagnosis in rheumatology often relies on the history. Allow the patient to speak and clues are almost always present. Autoantibodies are only clues, not definitive answers. The clinical context is king. Always try to integrate the clinical picture, investigations and timing. A single snapshot rarely provides the full picture. Rheumatic disease evolves. Watchful waiting can sometimes be more effective than a series of tests. Treatment mainly depends on the affected system and severity rather than the disease name. Rheumatology exists in the gray zone. Your calm confidence will reassure your patient. Explain complex ideas clearly. Replace fear with understanding. Not every ache is inflammatory. Not every flare indicates disease activity. Distinguish damage from disease and symptoms from inflammation. Always consider other causes, as many rheumatic diseases are less common. Rheumatology often requires a multidisciplinary approach involving pulmonology, ophthalmology, dermatology, nephro and neuro and other specialties. Providing the best and most complete care demands collaboration. Remember, collaboration is a strength, not a weakness. Mother Nature is more inventive than any classification system, and diseases can develop and change over time. Be prepared to reassess, revise and relearn. Patients live with the disease, not us. Please openly discuss risks, uncertainties and preferences. Shared decision making is the best approach for clinical practice. Last one but not least, rheumatology changes rapidly. What was evidence-based 5 years ago may now be outdated. Stay curious, stay current and stay compassionate. Thank you.
Thank you very much for these 10 commandments. What I want, in my experience, okay, I'll put in a few words. In my experience, if whatever patients come to you as fibromyalgia, especially females, please don't turn them out as fibromyalgia only. Look for hidden spondyloarthropathy, because many of them are non-radiographic spondarts, and many of them have a dorsal spinal involvement. And clinics and history is very important in such situations, and that can help you in tiding over the crisis. Yeah.
So these are from Dr. Kavita Krishna from Pune. Watch the walk. All proximal muscle weakness is not myositis. All joint stiffness is not arthritis. What follows are two case scenarios which emphasizes the importance of these three statements. First case is a 74-year-old male who was referred for stiffness and pain in all joints and hand deformities. His ESR was 34, rheumatoid factor was positive, treated as elderly onset RA, who was worsening despite DMARDs. His wife said he does not move his limbs because of pain in his joints, and he has a stiff back, and he was unable to turn in bed at night. MRI spine, however, only showed degenerative changes. His hand deformities were of osteoarthritic etiology. He walked into the clinic, and on observation, he had short steps with loss of arm swing. On examination, he had rigidity with mask-like faces. And after starting anti-Parkinson's medication, he had responded well. And the second case is a 45-year-old male who was referred as a refractory inflammatory myositis. He was symptomatic for 1 year duration with dysphagia, proximal muscle weakness, and neck muscle weakness. He came walking using a stick. Examination, upper limb showed wasting, hypotonia, weakness, and his sensations were normal, and lower limb showed spasticity. And there were fasciculations over his arms. The diagnosis was motor neuron disease. The key takeaways were watch the walk, observe the patient as he or she enters your clinic, and gait and stance gives us many clues. A strong neurology base is essential and an asset to a rheumatologist. Over to you.
Yeah. So many a times we are so busy just filling our data, looking into the computer to enter things. So we miss the entrance of the patient into the clinic. So it's very important to see how the patient has walked into your clinic, because once they come and sit and once they have a referral note as a refractory myositis or an arthritis, they may miss the neurological signs. So detailed neurological examination is very important in all the patients that we see in a rheumatology clinic. Thank you. Yeah, so as the super senior citizens of our country are increasing, we have to see there are multiple problems in the same patient, degenerative changes, arthritis, Parkinson's, etc.
So, see, simple things like Bindi sign or what is the other one? Crescent eye sign. Simple things. There is no intervention. And also regarding hydroxychloroquine or rituximab infusion reactions, we can do some collaborative work together, and it will be wonderful. That is one of the reasons. Not only, there is a passing on these snippets to the younger generation, and it will to generate more ideas. So it will be useful for our further future basic research. Not basic, a very bottom line research. That's my whole idea.
I think what we have come to understand after I'm trying to wind this session now, what I've come to understand that keep your eyes open. The moment the patient comes to you, watch him how he's walking. Use simple common sense and then examine him properly. The copybook style, and you're not going to miss anything. And don't make the diagnosis while the patient is entering to your room. I mean, that's very important. And at the end of the day, the proper examination, proper history taking, proper examination, and your observation. You could jot it down. That's what you have seen over a period of time, and then you could correlate. And as Dr. Sarath mentions, that we could collaborate and see such observations. We could see, and if we observe that, we could publish that. Many of the things like we are seeing psoriatic arthritis, many of them do not follow that Casper criteria, many of them. But still we make a diagnosis of psoriatic arthritis. So we could collaborate and see whether we can make our own sort of guidelines where we could fit in these patients. And that's it. Anything else?
No, so I think what Sharath is trying to say that we have our own observations, and it is time that we stop listening to the West blindly and that we generate our own data, our own observations, we document them and have, like he said, signs of our own. We just need to document those. It can be during residency also, you can have those observations. The one thing I like to say last is what I was discussing with Sandhya yesterday, is that kindness is often a function of age, and only after you become seniors you realize that you have to be kind. We've all done those mistakes in our youth when arrogance is usually much more. And so my request to all the residents will be, and they are always in a hurry because they have to see so many patients, and this was a dialogue, this was a quote from one of the mayors of New York who went on to say that in my experience of decades and years with ministers and various people, what I've realized is that the most intelligent person in the room is often the kindest. So kindness is something that you have to practice, and we should all do that. As Shyam very rightly wrote, the patient is not with us, he's with the disease. So I think we all have to be kind, that there's no option there. So I think that we'll end this. Thank you.
And you have always to believe the patient. Patient is always right. So we don't many a times ignore what he is saying, which we do. But that we need to keep in mind that he is always right, and we need to keep our eyes open to see why that thing is happening. Dr. Gupta has a point over there.
My observation in 25 years is psoriatic arthritis patients are more than
Okay. Okay.
Okay, thank you very much, moderators. Wonderfully done. Well, thank you. Saban, I like your last snippet, kindness.
We don't have to announce any prize.
So quickly we'll move on to the next session, the last scientific session. Later on we have prize distribution also. So next session, image competition, I will call the panelists and also the judges, Dr. Abhishek Patil and Dr. Gayatri.
Thank you, sir. And after listening to the doyens of rheumatology, now let's move on to the young Turks are the futures of rheumatology, that is the residents. It gives immense pleasure for me and Gayatri and Shirley to present these cases that were assigned by the students and residents from various institutes. We'll quickly go through them. And this is a case of juvenile dermatomyositis who was initially treated and with various DMARDs and myositis improved. But then she persisted to have these recalcitrant calcinosis and ulcers. So tofacitinib was instituted by the treating team for that, and with that, within a year, as you can see, there's a significant resolution of the calcinosis and as well as the ulcers. So this is a patient, I'm sure all of us would have come one or two such cases where the patient presented with inflammatory arthritis looking like presentation, but you can see a macroglossia with the tongue indentation, and the biopsy of the tissues revealed significant eosinophilic infiltrate with apple green birefringence with congruent sign confirming AL amyloidosis and maximum intensity projection of the PET scan showing the uptake around the joints. Now, this is a case that we as adult rheumatologists don't see, but this is a 2-year young female presented with, 2-year male who presented with recurrent sterile inflammatory arthritis of the knee joints and lower limb joints. He also had repeated aspiration cultures were negative, and he had improved somewhat with NSAIDs and antibiotics. But he then later developed these skin lesions. The biopsy revealed neutrophilic dermatosis, and suspecting that there could be underlying pathology, that then the treating team did a biopsy which showed this erythropoietic change in the RBC precursors, and this is a skeletal radiograph demonstrating the metaphyseal enlargement. So when you have such a patient with sterile inflammatory arthritis with conjunctive dyserythropoietic anemia, one of the syndromes you see is monogenic disorders, and in this it is lipin mutations, which is suggestive of Majeed syndrome. So this is a patient who presented with basically a lacrimal swelling and recurrent salivary swelling and various outside treated as Mikulicz syndrome, which is non-specific DMARDs, but with suboptimal response. And then she was negative for most of the inflammatory markers. One of the biopsy also showed granulomatous lymphadenitis initially. But when periorbital tissue, that is orbital inflammatory disease tissue, was biopsied, it showed CD16, and I think learned in the morning also that the histiocytic disorders are quickly becoming a group of disorders that we should be aware of, and we should be asking for the CD68, CD1A, SN100, and that's what this patient also showed, showing histiocytosis. So this is a patient who had previously pulmonary tuberculosis and a 40-year female. Then she presented with again arthralgia and hemoptysis, chest imaging and the CT scan as you show here. I think it is the right, which is labeled as left by the authors, but cavitary lesions in the right lung, and then suspecting recurrence of TB. When the BAL was done, it was negative. Then a biopsy showed fibrinoid necrosis and the ANCA positivity. So the diagnosis was revised to GPA and treated with rituximab with a resolution of the cavitary lesions. This is a 7-year male with systemic JIA. with fever, arthritis, hepatosplenomegaly, neutrophilic leukocytosis, hyperperitonemia, and a negative rheumatoid factor. Despite steroids and various TMARDs, there was suboptimal response. So at this point, I don't know why exactly, but the authors probably suspected that there could be a skeletal mucopolysaccharitis because of hepatosplenomegaly, and some of them can have inflammatory state. So they ordered an X-ray, and X-ray showed platybasaly and odontide hypoplasia. So they thought that it could be a mucophilosis. Some of them, like Spencer and others, can have significant inflammatory condition. However, the exome sequencing in them yielded, I presume it is macrophage inhibitory factor, which is not associated with these skeletal dysplasias. This is a common mistake, I think a common thing which we also come across, where there are various hand deformities in a 55-year female with diagnosis of rheumatoid and progressive finger deformities. But on examination, as you can see, the X-rays show no joint affection. There is a predominant cutaneous and subcutaneous tissue which is involved. So this was a case of difference contractures, and many of these are idiopathic, are associated with tobacco and alcohol usage. This is another interesting case. A patient who, 65 female, confirmed case of rheumatoid, treated for years together with methotrexate, levenhamide, suspect developed ankle pain, and the initial, particularly aggravated on weight bearing. No history of trauma or fall. The initial radiograph unremarkable, but the follow-up imaging showed this hypointense line all along the metaphysis of the tibia with surrounding sclerosis, suggesting it could be a methotrexate-induced osteopathy. So methotrexate can cause, inhibit the proliferation of osteoblast, and that can sometimes result in fractures of the lower limb. It would be interesting to know what was the alkaline phosphatase here, because that's how you typically differentiate this from other forms of metabolic bone disorders. And this is a diagnostic pitfall. I think we have also had few patients like this. 58-year male presented with painful oral ulcers, gingival swelling. And when you have this kind of a presentation, you suspect ANCA vasculitis, and has IF was a positive. However, clinical examination showed a necrotic gingival lesion. The take-home message from this is whenever you suspect vasculitis, the diagnosis is small vessel vasculitis is through biopsy and not through serology. So the biopsy showed a broad-based right angle branching or rarely branching septate hyphae, confirming possibly mucormycosis. So this is a patient, this is very classical that we see subacute cutaneous lupus erythematosus in a female with a distinct demarcation between the affected and non-affected area, and typically in a photo-distributed location called Sari sign. This is a case of a 22-year male agricultural worker who presented with plantar psoriasis with recurrent painful limb swellings from last 8 months. He's unresponsive to immunotherapy. On examination, he had diffuse tenderness over the right calf. Serology confirmed cysticercosis as the infection, and MRI and ultrasound both shows the MRI shows hyperintense thirst with surrounding muscle edema. Ultrasound shows a hypoechoic thirst with prosopleus collax. So it underscores the importance of infections, particularly patients who are on immunomodulators. This is a patient with non-inflammatory back pain presented in the elderly age group. And when the imaging was done, multiple hyper intense foci were there in the X-ray. So there was suspicion of an infiltrative disorder. MRI showed them to be sclerotic, very well rounded, not a dirty looking marrow on the MRI. And the PET scan showed that these are sclerotic lesions, so and which are not showing any inflammation. So this is basically osteopyclosis. Most of the lab parameters were normal, as you can see in the patient. So this is a patient, who had unilateral sacroiliitis initially. So whenever you have unilateral sacroiliitis involving the soft tissues, you suspect infection, as seen in the STIR image, which is axial with axial cuts. So treated with antibiotics and treated with anti-tubercular treatment, but there was no response to treatment. So then underwent a biopsy and the with a PET scan, and there was also an increase in the bone marrow edema over a period of 3 to 4 months despite of antibiotics and tuberculosis. So suspecting some other etiology, the treating team decided to do one more biopsy, and that showed these typical features of plasma cells with perinuclear admixed with few lymphocytes and neutrophils without any granuloma. So this is suggestive of a solitary plasmacytoma, so mimicking an infectious etiology of the sacroiliac joints.
Thank you, Abhishek. I'll take forward from here. So this is a case of middle-aged to elderly female with leontiasis osteophysis, and this patient is 51-year-old female who presented with chronic headache with prominent facial prominence. With progressive facial prominence. Her ALP was quite high, it was 600, and skull X-ray showed diffuse calvareous thickening, which was classical of Paget's disease. So later the bone scan which was done, it showed the uptake which was confined to skull, confirming the active Paget's disease, and she markedly improved after IV zoledronate 4 mg. That just shows the importance of IV zoledronate and importance of bone scan particularly in such case scenario. So this is one of the important things which we see in OPD. We have this lady presenting with chronic inflammatory polyarthritis with EN rashes over face, trunk and limbs, and there was no nerve thickening. Basically there was no evidence of Hansen's or there was no muscle weakness. Her ANA was weak positive, ENA, MSA, they all were negative, but skin biopsy did show lepromatous leprosy, and her MDT, so MDT led to an improvement. Obviously later steroid responsive neuropathy occurred during the therapy, so that just shows the importance of skin biopsy even in cases of chronic inflammatory polyarthritis. This is again one of the most important cases which we see in our day-to-day practice. So we have a 50-year-old female who presented with just significant arthralgia, not inflammatory arthritis, with neuropathy, which was acute to subacute onset with unintentional significant weight loss and GI symptoms, and she had these symptoms for 3 to 4 months. Later she developed these purpuric rashes over the lower limbs, and they were rapidly progressive, they were painful, ulcerative, and they were necrotic with hemorrhagic crusting, as we all can see. So the further evaluation revealed underlying plasma cell dyscrasias with positive cryoglobulins, and it was consistent with cryoglobulin vasculitis. And I would like to just give credit to the residents here because they could diagnose this case timely. This is one of the most difficult cases, yet very interesting. So sorry for the busy slide. So we have a male, elderly male with palmoplantar psoriasis and he is a smoker who presented with complaints of progressive dysphagia, which was more for liquid. He also had hoarseness of voice with unintentional significant weight loss. The barium swallow did show diversion around the lesion. I mean, there was a significant lesion on barium swallow. So later, the video laryngoscopy showed diffuse bulging of the posterior pharyngeal wall. There was obviously suspicion of malignancy considering his age and history of smoking. So as you all can see, it's not moving. No. So you all can see the CT head and neck was done, and there was large marginal osteophyte. Here you all can see that. Then another scan showed sacroiliitis as well. Later there was a dagger sign here on X-rays, following X-rays. So there was a confusion between axial spondylorthropathy, axial psoriatic arthritis or DISH. However, clinical clues, There were 4 axial SPA with palmoplantar psoriasis with exuberant anterior cervical osteophyte causing dysphagia. So there was no malignancy in this patient. So this is again, this could be a spotter for the residents here. So we have a 25-year-old male with knee pain showing bulbous finger trips with digital clubbing. So as we all have read in our clinical medicine textbooks, clubbing is really important in your clinical examination. So patient had, young male had knee arthritis with gum hypertrophy and significant clubbing, and X-ray showed X-ray showed periostitis with irregular bone thickening, and WS identified a heterogeneous pathogenic variant, and that was positive for your pachyderma periostosis. This is again, I think this was very difficult case to deal clinically. So we had a 43-year-old male presented with febrile illness with painful rashes over the limbs. He also had limb and scrotal ulcers, and there was history of single crop of oral ulcers with no ocular involvement. So this was important probably. And there was distributive shock with elevated lactates. The inflammatory markers were obviously raised. ANCA serology, ANA, all were negative, but skin biopsy from shin revealed EN lesions with florid vasculitis, thrombosis, and perivascular C3 deposition. His pathargy was negative. USG of involved digit showed synovial thickening with marked subcutaneous edema. So probably there was a suspicion of infection triggered Behçet. He was treated with broad spectrum antibiotics initially. Later he was given pulse steroids, and he showed rapid clinical improvement. Subsequently, colchicine and azathioprine were added, and prednisolone was tapered. However, I just have a doubt in this patient. We usually do not use colchicine and azathioprine together. Am I right? Or we still can, because I have seen really 2 bad cases with very bad pancytopenia with combination of azathioprine and colchicine. We can discuss that later. So this is an elderly man who had GPA. He had right eye proptosis, vision loss, scleritis, and orbital cellulitis. And rituximab improved this as well as systemic disease. If we all have, whoever has worked in transplant unit will know, such cases do exist. So this is chronic graft versus host disease manifesting with palmar fasciitis with inflammatory polyarthritis. So we had a 29-year-old woman with history of AML M5 who underwent allogenic bone marrow transplant in 2020 and has been in remission since then. After about a year, she developed chronic graft versus host disease with oral and ocular involvement, and she was treated for that. She was maintained on that. Later she came with history of progressive inflammatory arthritis with positive prayer signs. So her inflammatory markers and autoimmune serology all were negative. However, such cases do exist exist after your stem cell transplant. This is again important case, tough case to handle. A 48-year-old female who presented with history of scaly skin lesions for a year was treated as psoriasis. She again had significant weight loss and fever for 3 to 4 months. She had generalized lymphadenopathy and psoriatic lesions over neck, elbows, hands, and feet. Her X-ray, however, showed bilateral lymphadenopathy. Her histopathology lymph node examination showed non-caseating granuloma, where skin biopsy also revealed similar findings. Serum ACE levels were also elevated, hence she was diagnosed as soriform sarcoidosis, and she was treated with steroids and methotrexate. As we all know that we don't use steroids that usually for psoriasis, but in this case steroids had to be used, and this just illustrates a rare presentations of cutaneous sarcoidosis mimicking psoriasis. I just have a pointer for residents here that whenever you have any rheumatological case, I think chest X-ray has to be done as a part of your initial investigations. This is mainly for pediatric residents, but we also see pediatric rheumatology cases here. Ma'am probably can give us some pointers after this. So we have a young male who had chikungunya-like infection, later had he developed profound bilateral viral retinitis. So clinical picture showed alopecia, dull appearance, facial hyperpigmentation during acute phase, and then there was significant systemic recovery after steroid therapy, but vision loss was irreversible. So the fundus examination of both eyes showed optic disc pallor, arterial attenuation and retinal edema. There were RP alterations and fibrovascular proliferation. So it was all hallmark of proliferative retinopathy or aggressive retinitis. OCT reviewed vitreomacular traction, and so there was basically extensive retinal damage. So these findings underline the essential clinical message. Post-chikungunya, MISC should be recognized as a rare possibility. And early ophthalmologic evaluation is crucial because chikungunya or any viral infection can lead to such retinal damage. This is photo for the residents. I mean, I don't even have to explain, you all know what is it. So we had 51-year-old man presented with chronic neck, back and knee pain, inflammatory versus non-inflammatory. There was also scleral and ear pigmentation and progressive spinal stiffness. Imaging showed extensive spinal calcification, as you all can see, and this just demonstrates usefulness of a simple X-ray in your day-to-day practice. So the urine, standing urine showed darkening, and that was positive for HJD gene mutation. So this was a case of this is a classic case of alkaptonuria. Coming to last case of the day, this is a case of 19-year-old lady who presented with recurrent spontaneous painful rash in multiple areas. Acute phase reactance, CSR, CRP and immunology workup were all normal, but MRI of the arm revealed subcutaneous inflammation, and biopsy of the skin showed extravasation of RBCs in subcutaneous syndrome, suggesting Richard Gardner syndrome, which is autoerythrocytic syndrome, which is extremely rare. So that marks end of our session. So I and Abhishek also learnt a lot, and it was at times we felt criminal to even score such images. Yes.
We have received 80 images. So we have selected only top 25. So Dr. Gayatri is going to announce the top 3 now. We will see who they are.
So fortunately, unfortunately, there was a person who also had one in oral category, so we couldn't give prize to him. So that decision was taken by me and Abhishek. So I'll start from third prize. So third prize goes to Dr. Kirti Vardhan, NIMS, Hyderabad. Congratulations. Second prize goes to Dr. Swapnil Sahu, Apollo, Lucknow. First prize, any guesses? So Bishakha from Hinduja Hospital. Magic syndrome, I think.
Thank you, Dr. Abhishek and Dr. Gayatri. Wonderfully you have completed on time. Thank you. We'll move on to the last one of the scientific program is prize distribution. And I request you all to stay to encourage the youngsters, because there was a complaint last time. We couldn't spend time with the winners. So I request Vinod to come on. Now we are going to announce the winners of the CRC 2026. And when we call upon, please come and stand here so that we can give the certificates and also respect to cash prizes and the trophy for the quiz winner.
Start from the bigger one, that is oral presentation. In ARIA and Spondyloarthritis session, Dr. R. Naveen Kumaran. In scleroderma, Jockrens related CTDs, Dr. Ritesh Kumar Mishra. Pediatric rheumatic diseases, Dr. Vimal Manik Shah. Inflammatory myositis and autoinflammatory diseases section, Dr. Ranjan Gupta sir. SLE section, Dr. Abhishek Noduri.
Go Abhishek.
Under vasculitis, Dr. Sarthak Verma.
ఫస్ట్ కాదు పోస్టర్స్ ఫస్ట్ మీరు నా దాకా చెప్పేసి ఆపేయండి తర్వాత నేను వస్తాను మీ లోపల మీరు చెప్పుకుంటే బాగోదు.
Under miscellaneous rheumatic diseases, Dr. Meghana. Now we will move on to the poster presentations. Under Arya section, V. Venkat Sai. Under Scleroderma, Dr. Kintali Pradeep Kumar. Under Pediatric Rheumatic Diseases, Dr. Sandeep Balakrishnan. Dr. Inflammatory Myositis, Dr. Nidhi Goyal. Vasculitis section, Dr. Ningsem. Miscellaneous rheumatic diseases, Dr. Chennam Shetty Teja.
నేను తీసుకుంటాను.
Under, now we'll move on to the rapid fire session. Third prize, Dr. Nayantara Shanai. Okay, okay. I will tell you. 3, 2, 1. Okay. Rapid fire. 3, 2, 1. Next. Under, we'll move on to the rapid fire session. Third prize, Dr. Nayantara Shanai. Second prize will be Dr. Mahesh S. Kant. First prize, Dr. Mihir. We'll move on to the image competition. First prize, Dr. Baishaka Swain. Image competition. Yes. No, first. Second prize, Dr. Sapnil Sahu. Third prize, Dr. Kirtivardhan. You take it. Dr. Abhishek will take for Kirtivardhan sir. Go. We'll move on to the quiz. Third prize, Dr. S. Nandita from CMC Vellore. Nandita. Quiz. Last. First prize is trophy.
MA first year.
Second prize, Dr. Lovely Kumari. The trophy winner, Dr. Baishaka Swain.
each one of you for making this 1.5 days of academic exchange a great success. So with that, I welcome Dr. Sharad to give his vote of thanks. Thank you.
సార్ ఇప్పుడు చెప్తారు సార్. ఓకే సార్. సార్కి మైక్ ఇవ్వమ్మా.
My friends, thank you, Dr. Sharad, for making a wonderful conference. I see a lot of youngsters in this clinical conference. I want to say, as APA President, this conference is Epicon at Patna. Nearly 70 slots are given. More than that, I want to say, since last 1 year I took over the responsibility of important session, we have allocated 1 crore research fund for the API. They will be given to API members, non-API members also, but priority will be given to API members. So I request to all of you become API members. Apart from that, Indian College Physician, once you pass your MD, after 7 years you are eligible for becoming a fellow of Indian College Physicians. The advantage of that, being as API member, you get JAPI, and by FSCAP, every year we have 9 to 10 monograms. And I have myself written, and Dr. Rohini Handa written good number of monograms. I have written on vasculitis, Varprasad, me written SLE, and recently body of rheumatology. These books will be delivered at your clinical residence free of cost. There are some academic advantages. What I see, I started first DMD, NB, rheumatology and NIMS, and good number of my students. My students also started these courses in various places of India. Number has increased significantly. My dream of one rheumatologist every district place getting fulfilled in my lifetime, which I never expected. So I'm happy, not on that, our clinical diagnosis, clinical equipment, on par with Western country, Asia, ULR. I spent some time in Guy's Hospital, John Hopkins, and King George Hospital, Sydney. Our clinical equipment on par with them. What we lack is a basic research. Every rheumatology consultation or department should have a basic immunological lab. And from there we have to develop a research lab. That happened, it is there reckoned in the syllabus of MCI, but it's not happening. That's the unfun part of it. Various our lab people oppose us. Kindly, some Sanjay Gandhi Lucknow, CMC, Vellore, and Madras Medical College, and SK Das and King George, they have, but I'm yet to see products coming out of it. Basic research 1 crore and clinical research 1 crore we kept in API. Now I'm the president-elect, and 28th evening 5 o'clock I take over president. I am planning to allocate nearly more funds for clinical and basic research. I am planning to allocate up to the tune of 5 crores. The only condition is after your presentation, after work, you have to present our annual conference and you have to publish in JAPI. The advantage for you. I appeal all of you, become IRA member and API member once you become eligible ICP member. Next 1 year, bless me to do more fruitful academic service-oriented activity on API. Thank you all.
Thank you all for staying till late. So lunch is ready. I'll try to finish in a few minutes. So I thank all the faculty and delegates for making it success, and a special thanks to the scientific chair, Dr. Vinod Ravindran. He's my close friend. And special thanks to my students, Dr. Vimal, Rekha, Mohit, Gunasri, Venkat, Mustafa, Sristi, and especially Sankirtana, Vaishnavi. They've done a lot of hard work to make it successful, and Mr. Naveen, my secretary. And Mohit has put 100% effort into the success of CRC. And Sankirtana, Vaishnavi worked hard for the success of this conference. Of course, Naveen always there in the back end, 24/7. Now we'll acknowledge all the people who have contributed for the success of CRC 2026. Dr. Minu Basu, he couldn't make it because he was ready to the airport. Then he got a call from the mother that she's not well, admitted in AIMS, so he couldn't make it. Mr. Dr. Srinivas and my boss, Dr. Bhaskar Rao, he has a quote which I always implement: I for illness, W for wellness. So CRC is all not about I, it's all we. So that is the reason why it has been successful every time. And Vinod, Rajkiran, and to all the faculty. And next posture, just next time send better pictures. Some of them actually they didn't send because we're all busy practitioners. So my team actually got it from the nets. So some of the photos are not looking good. Next time, please send. Thank you all for your contribution. So all are your soldiers for the CRC. Because of you only, it has become successful. So many people worked hard for, the behind the screen, so much hard work. Abstract reviewers. We have received 269 abstracts and images all together. These people worked hard for the souvenir. And I thank the IT department of KIMS, PRO, Mr. Srikar, YouTube. Mr. Madhu has been doing it since 2019. You can see that the clarity of the picture and the sound. He has done a wonderful job. Photographer, Mr. Giri, and the branding department, Mr. Srinivas, security department, stalls, Mr. Arun and team, F&B team, maintenance department, purchase department, Mr. Kalyan, housekeeping team, accounts department, Mr. Rajendra, and transportation team. Thank you, all of you. And so these are the big guys to support us. Without them, it won't happen. A big thanks to all the pharma people. Most of the contribution is done by IPCA. When I first started in 2019, Biju said, sir, whatever is the expenses, don't worry. You deliver the good scientific content. I'm there to support. Where is Biju? Please. Thank you, Biju. Thanks for all the support. Thank you. And next comes Hetero after IPCA. Hetero నుంచి ఎవరున్నారు? Guruprasad garu. Thank you very much. Please stand up. Thank you. And Johnson, J&J, Cipla, Pfizer, Zydus, Overseas, Intas, Shilpa, MSN. Just on Friday, I think Vinod, when you came here, we never had a proper departmental picture. Thanks all the department staff. And my research team. So far we have done 87, we have completed 87 clinical trials. All are global, phase 2, phase 3 studies. Probably number 1 in the country. So now I invite you all for the next upcoming CRC. So you're all going to be there, 2028. So see you all in 2028 in this auditorium. Thank you all once again for making CRC 2026 a success. Thank you. Thank you. Please join us for lunch. Any comments, suggestions, positive or negative, please drop a mail or a WhatsApp. Faculty on the site and delegates on the site. Not only faculty, all the senior colleagues, please, on to my left side. Madam.
దాన్ని అది అసలు డే టు డే ప్రాక్టీస్ది స్నిప్పెట్స్ చెప్పినావు నేను మొత్తం అవన్నీ ఫాలో అవుతుంటే అవన్నీ చేస్తున్నాను అది బాగా నచ్చింది దానికి ప్రైజ్ ఇవ్వాలి అసలు కలిసి గిఫ్ట్ ఇవ్వాలి
జగదీష్ నాగరాజ్ అందరూ రమ్మని ఒకసారి
స్వాతి మీరు ముందు కూర్చుని పోతారా
బయట ఉంటే పిలవండి. థ్యాంక్ యూ. Where is the sister? Here. Thank you, department.